Hi, my name is Michel Kehela. I am the program director of MAGIC. It is with honor and pleasure that I would like to invite you to MAGIC 2022. We're going to have 2 days of an amazing conferences with didactic, hands-on, live cases. Some of the most prestige faculty going to be involved in this conference. You will have opportunity to interact with them and be exposed to some of the most cutting-edge technique currently available in advanced endoscopy. We have a very busy program. I suggest we get started immediately with the didactics.
Good morning. My name is Cal Patel, and I'm speaking to you this morning from Houston, Texas, and I'd like to welcome you to this morning's session centered on endoscopic ultrasound. I'd like to thank the course organizers for giving me this opportunity to join you this morning, and looking forward to a wonderful course. As you can see, I selected a relatively simple image on the first slide here, and like you, I often use a simple drawing when discussing ultrasound with patients or trainees, but it really doesn't do justice to the tremendous innovation that's gone into this technique over the years. And this morning, I plan to discuss those with you. I'll start by giving you a sneak peek at many of the exciting innovations in the U.S. that we're going to hear about later this morning. Dr. Chang will be discussing applications of EUS in endohepatology. Dr. Kedia will talk about using EUS to overcome the challenges of altered anatomy endoscopy. Professor Bartha will discuss the use of therapeutic EUS in overcoming gastric outlet obstruction. Dr. Tyberg will focus on biliary and gallbladder applications. Dr. Shahid will talk about one of the longer standing applications in managing pancreatic fluid collections. So I'm going to focus on topics so as not to steal their thunder that may not be covered later today. And I'm going to I'll start by reviewing the early innovation in EUS that's allowed us to get to our current state. EUS, especially for those of you who may be new to the field, you may not realize is relatively recent development in the field of endoscopy. The first scopes equipped with ultrasound were developed in the early 80s. And as you'll see throughout the development of EUS, there would be sort of landmark events every few years. Following the development of first the radial scope, and then the linear scope, it wasn't until the early 90s where nearly simultaneously in the United States and in Europe, the first EUS FNA procedure was performed. Professor Willman in Europe and Dr. Wiersma here in the United States. Following that, you can see the next 20 plus years, we saw an explosion of activity in expanding EUS applications, primarily focused on expanding the number of sites that could be sampled and a parallel development of different types of needles to enhance biopsy and diagnostic yield. I'll focus this morning's talk in three broad areas regarding innovation in EUS. One will be on training and availability of EUS. Two, I'll talk about ongoing efforts to improve the diagnostic abilities of EUS. And three, I'll focus on delivery of therapy, particularly as it relates to pancreas cancer. Now, as we all know, EUS is hard. It's quite challenging to acquire the skills, and furthermore, mastering the skills can take quite a bit of time, even after formal training. And it's imperative as we train endoscopists in the U.S. and before launching endosonographers into more and more complex therapeutic applications that the basics are truly mastered. In an effort to do this, several innovations have come about in training. One of these is the use of simulators, as seen here on the left, a system that many training institutions have adopted Symbionic system, provides a vast library of training scenarios, both in standard endoscopy as well as advanced endoscopy, including EUS. While these offer a great introduction, those of us who've used it know that after, just like a video game, after you do it a certain number of times, you learn the tricks and can sort of master the game, but it's unclear how well that translates to performing the procedure. Another approach seen on the right is to marry the overlay of anatomic detail to the EUS image. This focuses more on training sort of the cognitive aspect of correlating the spatial relationship of an EUS scope with the surrounding organs. This is perhaps what makes an EUS so challenging. Unlike optical endoscopy, which frankly we use in our everyday life when you're looking using your camera on your phone, we're pretty good at understanding what we see in front of us. But how to orient the echo endoscope around an organ in order to generate the image that we need is the hard part. And so innovations in marrying three-dimensional anatomic detail with US imaging can be quite helpful. Speaking of our phones, we're lucky to have the use of apps such as this one, developed by Dr. V and colleagues several years ago, one that I used in my own training. And here we have instant access, sometimes even during a procedure, to reference a vast, expertly curated library of images, techniques, and tips on performing both diagnostic and interventional EUS. Apps have become more and more interactive and sophisticated, and even employ gaming techniques to encourage mastery of these skills. But of course, perhaps the most effort and innovation in EUS training has focused on hands-on training. Here you can see on the top panel pictures from a course that we put together here in Houston, using pretty sophisticated explant models to simulate pancreatic necrosis, gallbladder drainage, and as you can see, we even have a simulated Ken Binmuller to assist us. On the bottom, we have images from a very high-level course done in Europe, where using live animal models, a dilated bile duct is created to allow practice and mastery of direct biliary drainage. And while these types of events do provide very valuable hands-on experience, as you can imagine, these involve a tremendous amount of investment of time and resources, and can be difficult to make widely available. In an effort to make EUS training more widely available, of course, we have a variety of other types of courses. ASGE developed a fairly comprehensive longitudinal training in diagnostic EUS, focusing on experienced or endoscopists in practice, and developing a year-long didactic and preceptorship program to encourage experienced endoscopists in adding EUS to their skills. We also have courses targeted at existing endosonographers and allowing them to add more therapeutic skills. This is actually an upcoming course through the ASGE that will focus on therapeutic EUS for advanced endosonographers. And There's no shortage of courses, as you can see, both here in the United States and around the world. Many courses exist, but I think the challenge is how do we take the scenario or the environment seen here and translate it to high quality patient practice. And this leads me to an area which I think is due for innovation, which is in measuring and maintaining quality and competency in advanced endoscopy. A recently developed group, the Foundation for Interventional and Therapeutic Endoscopy, has made this part of their mission statement. As you can see here, one of their aims is to create universal guidelines for hospital privileging and certification process. I think this is critically important because it's really difficult and nearly impossible for courses to have longitudinal follow-up with the trainees that attend them. And so it really falls upon the local institutions where practitioners are at to maintain these. And often, because our field is so innovative, we often outpace the ability of local committees to evaluate and maintain appropriate credentialing and privileging standards. And so I applaud this group's mission to help and to create universal guidelines that can be used by all institutions as we add more and more innovative techniques in our field. As we train more endosonographers, are we really making EUS more available? And I think we all can recognize that advanced endoscopists or endosonographers tend to cluster in certain areas. Less than 20% of hospitals and a very small fraction of ambulatory centers in the United States have EUS capability. And this has the potential to lead to healthcare disparities. In a study performed a few years ago in Illinois, we can see here on a map that correlated esophageal cancer mortality with EUS availability. And probably, as common in many areas in the United States, we can see EUS providers clustered in more urban areas compared to rural areas marked in the striped counties. And we can see on those counties with the worst mortality related to esophageal cancer were those that were the farthest away from EUS providers. Now, certainly EUS may just be a surrogate for other higher levels of care, but I think we can all agree that to really make our innovations in EUS the most powerful, expanding geographically and to a more diverse set of communities is extremely important. Now, the reasons this may be limited, one, of course, is the lack of incentives to broaden practice and different practice areas, but also the availability of equipment. EUS equipment traditionally does carry a high capital cost, and this may be limiting in certain areas. And one of the most exciting innovations in making EUS more available is seen here. This is the attachable EUS system developed by Endosound, which was recently the winner of this year's AGA Shark Tank competition held in California. This system consists of a detachable Endosound probe, which can fit onto any standard EGD scope. It's designed in a way that allows an FNA needle or other therapeutic tools to pass through the standard working channel and out the tip of the scope, and allows both diagnostic and therapeutic applications. This has the potential to overcome some of the limitations due to cost of traditional ultrasound equipment. However, of course, we will still need the endosonographer to go with the system, and I hope this will encourage and allow endosonographers to expand to newer communities throughout the United States. Moving on to innovation in diagnostics. As I alluded to in an early slide, a lot of attention and effort has gone into developing biopsy needles that provide better diagnostic yield. And often it takes quite a bit of time to go from the innovation to demonstrating the impact. But we are there when it comes to biopsy needles. As you can see in this very recently published network meta-analysis, taking a look at all the data surrounding the performance of biopsy needles compared to traditional FNA needles, we begin to see clear impact, particularly with some of the novel designs, such as the fork tip and Francine needle types, in terms of diagnostic yield on solid pancreatic masses. So this is an area where we've done well with time, but there are some areas that still have some work to do. And one of those areas is in the diagnosis of pancreatic cysts. One innovative approach is the development of the through-the-needle microforceps, which allows the ability to obtain tissue from nodules, septae, and the wall of the cyst. This is performed during EUS aspiration through a 19-gauge needle, as seen here. The tool has been around for a few years, and we have seen the results primarily of retrospective studies. These do indicate that adding microforcep biopsies to standard imaging and fluid analysis does appear to increase the sensitivity and specificity. However, we don't have great prospective data to confirm this. As you can see in the video, a 19-gauge needle is inserted into the cyst, through which the forcep is advanced through the tip of the needle and then advanced to the cyst wall, and a biopsy is obtained, similar to any other forceps biopsy. We look to see for the telltale tug on the wall, which indicates tissue acquisition. As you can see from the video, however, there are limitations into which parts of the cyst can be accessed, and like any biopsy technique, sampling error remains an issue. And based on these limitations and perhaps the reputation of advanced endoscopists as being a little bit concrete, I think we're heading into an era of an innovative way of thinking about diagnosis. And this brings up the idea of optical diagnoses. Here we can see one of the tools available for that, which is the needle-based confocal endomicroscopy system. And here, in a very nice study performed by Dr. Robles Medrana in South America, we can see perhaps the direction we're headed in. So his group compared the outcomes of pancreatic cysts that were evaluated by traditional EUS compared to EUS plus other advanced techniques, including microforceps biopsies, confocal imaging as seen here, and traditional fluid analyses. And what he demonstrated was that the addition of these adjunct techniques has the potential to significantly increase the characterization of pancreatic cysts. Here we can see EUS alone provided definitive diagnosis in only about 50% of the time, whereas the addition of forceps biopsies, confocal imaging, or the combination has the potential to increase this significantly. And one of the limitations, however, of optical diagnosis has been reproducibility, and also, how do we translate our findings to the end user or consumer of our results, whether it be a surgeon, oncologist, or other healthcare provider who doesn't do the procedure or doesn't see the images. And here is where I see EUS intersecting with one of the hottest topics in endoscopy, which is artificial intelligence, or AI. Here we see the most basic schematic of how AI systems are developed, particularly for imaging analysis. A set of well-described inputs are entered into an algorithm. A nearly infinite number of permutations are analyzed, and then a set number of outputs are delivered. So how does this look like in EUS? The potential impact of this approach was recently published in Gut last year by the Mayo Clinic Group in a study where they developed their own AI algorithm to aid in the distinction between autoimmune pancreatitis and pancreatic cancer. Drawing upon their vast cohort of patients with these conditions, they used a library of EUS images to develop a learning system and then validated that on standardized AIP and pancreas cancer images. And what you can see based on the EUS characteristics, a probability of diagnosis can be given by the AI system. And what's important to note is that the system is giving a probability, not making a diagnosis. And so the way we can use this is an additive to our clinical decision making. And I think we look forward to a time when we combine standard of care, advanced imaging, both manual and automated interpretation, in terms of pancreatic cyst, next generation sequencing of the fluid, and we feed this information into a AI algorithm, which then allows us with greater confidence to distinguish between varying pathologies, low-grade dysplasia versus high-grade dysplasia, or invasive cancer. And I think we can all agree on some of the top priorities where this approach will be valued in indeterminate biliary strictures, pancreatic cysts, as we discussed, and differentiating pancreatic cancer from other benign mass-like pancreatitis conditions like chronic pancreatitis and autoimmune pancreatitis. Finally, I'll talk about innovations in EUS-guided cancer therapy, predominantly focused on pancreas cancer. One broad area is EUS fine needle injection, simply taking usually the same needles we use for FNA and delivering one of many agents directly into the tumor or sometimes into a metastatic lesion. The three broad categories of agents that have been delivered by this technique include immunotherapy, chemotherapy, and oncolytic viruses. Because these studies take a tremendous amount of time to develop and execute, we are still primarily in phase 1 or 2 stages of these studies. Notably, there has been one randomized clinical trial of an agent, TNF-arrayed. This was performed a few years ago Unfortunately, that did not result in showing a meaningful effect on pancreatic cancer survival. However, many of these studies are ongoing, and I expect over the next 5 to 10 years, as we begin to see the results, we can hope for meaningful impact from this approach. Our own institution recently shared results from our own phase 1 and 2 study at this year's ASCO meeting, and we hope to be able to share long-term results over the next few years. The other approach to EUS-guided therapy is in ablative techniques, and perhaps the most widely used thus far is EUS RFA. This has been applied to all sorts of lesions, including pancreatic neuroendocrine tumors, pancreatic cysts, and even small studies in pancreatic adenocarcinomas. Seen here is the system, which is integrated into a dedicated needle that is advanced into the target lesion while energy is applied. Professor Barthold's group recently published a prospective multi-center experience using RFA on pancreatic neuroendocrine tumors and pancreatic cysts. Here we can see in these beautiful images the appearance of a typical neuroendocrine tumor. Under Doppler, we can see the telltale peripheral arterial flow, and using contrast-enhanced EUS, we can see the enhancement before ablation and then the lack of enhancement after ablation. And their results, which were notable for the fact that over 3 years of follow-up, 14 neuroendocrine tumors treated in 12 patients. We see 12 out of 14 were gone after 1 year. 2 did not initially respond. One of those 2 responded after second therapy. And then long-term follow-up of those that responded, you can see it was, in most patients, sustained. Pancreatic cyst can be a more difficult target for RFA due to size and complexity of the lesion. Here you can see a large lesion that has an enhancing mural nodule before and then after ablation. We see diminished enhancement. Taking a look at 17 patients who underwent RFA for cyst, a couple of notable things. In those patients who had mural nodules, you can see both at 1 and up to 3 years afterwards, really great response to treatment. Larger cysts, of course, not surprising, hard to get uniform energy to the entire cyst, do tend to be the ones that don't respond as well compared to smaller cysts, which had complete and sustained disappearance after treatment. So RFA appears to be a very promising application. There's different ways to deliver the energy, both in monopolar and bipolar, and there's also, just like in Barrett's esophagus, a cryoablative tool that's being studied as well. So to wrap up, I believe that innovation in EUS will continue to expand and grow and grow and grow. In order to do so, I think there's some keys. One is collaboration. I think will drive innovation more than any one individual themselves. I think as creative endoscopists, it's critical that we shift away from anecdotal experience and really focus on controlled multi-center trials together. And finally, I think it's imperative that as we innovate, we quantify the value of our work and innovation to both drive broader acceptance and also to develop models of reimbursement. With that, I'd like to thank you for your attention, and I hope you enjoy the rest of the course. Bye-bye.
Hi, everyone. I'd like to thank Michelle Kahela and the organizing committee for inviting me as a West Coast faculty to join the Mid-Atlantic Magic. In the next 15 minutes, I would love to share with you some exciting updates on endohepatology procedures. These are my disclosures. I'd like to begin by talking about endohepatology, which is the broader concept which encompasses EUS shear wave elastography, EUS biopsy, as well as EUS portal systemic pressure gradient. And from there, I give an update on EUS PPG data to date, as well as clinical experience. And then go on to talk about emerging indications for EUS PPG. In 2012, we presented this new paradigm of endohepatology, which is defined as the integration of endoscopy within the practice of hepatology. And now endohepatology really does represent the one-stop shop endoscopic liver evaluation. During endoscopy, we can screen for esophageal and gastric varices, portal hypertensive gastropathy, and in the same session, we can perform shear wave elastography, and now we can perform contrast EUS as well as EUS liver biopsy, and finally EUS portal systemic pressure gradient measurement. And the diagnostic strength of endohepatology can help in some of the unmet need areas, especially in NAFLD and NASH. For example, the precise diagnosis of NASH oftentimes will require a liver biopsy, and this can now be performed by EUS liver biopsy. And in addressing progression of disease, EUS shear wave elastography may be useful, as well as EUS guided portal systemic pressure gradient measurement. Now, if there's a suspected liver lesion, contrast EUS can also be employed. Let me show you a quick 30-second video of EUS shear wave elastography. Here, by simply pressing the shear wave button, I can assess with 10 passes that the left lobe is 11.4 kilopascal. And here in the right lobe, it is 15.9 kilopascals. And we can also assess the spleen as well as both lobes of the liver. And here the spleen stiffness is 55.3 kilopascal, which is extremely elevated. At this DDW, our group, led by Dr. Choi, EUS guided bilobar liver and spleen shear wave elastography and its association with hepatic fibrosis stage. 44 patients underwent same session EUS shear wave elastography as well as liver biopsy. Our univariate analysis showed that a shear wave value of the left lobe or right lobe of 12.5 kilopascal represented an 81 to 88% association with F3, F4 fibrosis on biopsy. In addition, if you combine shear wave of the left liver as well as spleen, that combination had the highest operating characteristic for predicting fibrosis greater than 3 on liver biopsy, with a positive predictive value of 80% and a negative predictive value of 93.8%. Moving on now to EUS liver biopsy. This is a bilobar biopsy demonstration showing the 19-gauge Francine needle going into the right lobe of the liver. This is the single pass, single actuation technique, which is under E-flow Doppler control. The needle is safely withdrawn. The specimen is expressed. You can see a nice specimen. Now we go to the left lobe of the liver. Again, another pass, single actuation, another nice specimen, greater than 15 complete portal tracts in both right and left lobes of the liver. Going on now to EUS-guided portal systemic pressure gradient measurement. We know that portal hypertension is a serious complication of cirrhosis. The hepatic venous pressure gradient, or HVPG, accurately reflects the degree of portal hypertension. It is the single best prognostic factor in liver disease. It guides medical therapy, and it predicts liver decompensation as well as liver cancer risk. A normal pressure gradient is equal to or less than 5 millimeters of mercury. Greater than 5 is the definition of portal hypertension. Greater than or equal to 10 is clinically significant portal hypertension. Greater than or equal to 12 represents a high risk for bleeding from esophageal or gastric varices. The current practice is transjugular hepatovenous pressure gradient. Here, a free hepatic vein pressure as well as a wedge hepatic vein pressure can be obtained. Now, there is no direct measurement of the portal vein, but the wedge hepatic vein pressure in most cases correlates quite well with the portal vein pressure. However, there are causes of portal hypertension in which the HVPG indirect measurement may not be accurate. And this is in the case of pre-sinusoidal portal hypertension, which can be caused by early primary biliary cirrhosis, as well as sarcoidosis, or idiopathic portal hypertension. In these cases, a direct measurement of the portal vein pressure would be required. The currently available EUS PPG device includes a handheld pressure gauge, which is then attached to a non-compressible tubing and a 25 gauge needle. We performed the preclinical animal study, which was published in GIE in 2016, in which we compared EUS PPG with simultaneous transjugular balloon catheter measurements. And we reported that the portal and hepatic venous pressure comparisons between the transjugular measurement and the EUS 25 gauge PPG measurement had a correlation coefficient of 0.985. We then went on to publish our human pilot study in GIE in 2017, where the aim was to evaluate the feasibility and safety of EUS PPG, as well as to correlate EUS PPG with both endoscopic and clinical evidence of portal hypertension in patients with liver disease. All 28 subjects underwent EUS PPG with 100% technical success, enabled to identify and access targeted vessels and obtain meaningful manometric pressures, and there were no complications with a PPG range from 1.5 to 19 millimeters of mercury. Our technique involved passing the needle into the hepatic vein, and this was usually the middle or left hepatic vein. And once the needle is in place, we would obtain 3 serial measurements of the hepatic vein pressure and the needle removed. We then proceeded to pass the needle into the portal vein, and this is usually the left portal vein, where a series of 3 consecutive measurements were taken and the needle was then removed. I'd like to share with you this 30-second video summarizing the procedure.
Okay, I'm in. Gonna come back just a little bit. Okay, we'll take 10. We'll take 11. Back now. Go back some more.
3 measurements in the middle hepatic vein were obtained, and that's the left portal vein.
Okay.
Pressures are 14, 14, and 14. The needle is then removed. And so the middle hepatic vein gave an average of 10.3 millimeters of mercury, the left portal vein 14 millimeters of mercury, and the difference or the gradient was 3.67, which is within the normal range. Most recently, our group published a series of 64 consecutive patients undergoing EUS PPG. 67% had concurrent EUS liver biopsy. There was 100% technical success and no SAEs. 45% of the patients had elevated PPG greater than 5 millimeters of mercury. 23% had greater than or equal to 10 millimeters of mercury. Our univariate analysis showed that the variables associated with EUS PPG greater than 5 millimeters of mercury included clinical cirrhosis, portal hypertension, hepatic decompensation, thrombocytopenia, INR greater than 1.05, APRI score greater than 1, FIB4 greater than 3.25, as well as fibrosis stage greater than or equal to 3. These are all associated highly with EUS PPG greater than 5. Our multivariate analysis showed that if the EUS PPG is greater than or equal to 5, the fibrosis stage greater than 3 on EUS liver biopsy had a likelihood of 26.98. As a matter of fact, an elevated EUS PPG had the highest performance among the variables in predicting stage 3-4 fibrosis, with a sensitivity of 57.9%, specificity of 87.5%, positive predictive value 78.6%, and negative predictive value of 72.4%. At this DDW, our U.S. multi-center endohepatology experience of 159 patients from among 6 institutions. And here again, the US PPG correlated well with the clinical parameters as well as scores of liver disease. In this study, 39 patients had concomitant US PPG, transient elastography, and liver biopsy. In 19 patients, or almost half, with EUS PPG less than 5, accurately characterized patients who on liver biopsy were shown only to have stage 0, 1, or 2 fibrosis, while the transient elastography was falsely positive. On the flip side, 5 patients, or 6%, with no clinical markers of liver disease had an EUS PPG greater than 5 and had advanced histology on liver biopsy. This group from China reported a small series of 9 patients with acute and subacute portal hypertension, where both the EUS PPG and the HVPG were obtained in every patient. They found the mean EUS PPG was 18.07 and the mean HVPG was 18.82, and the Pearson correlation coefficient was 0.923. Now that we've updated some of the clinical data, let's talk about the clinical indications or phenotypes for EUS PPG in a mature practice. Our first phenotype is the worried well or the pre-op clearance patient, and that represents about 10 or 20% of our practice. The second phenotype is the etiology of the liver disease is uncertain, about 20%. The severity of the liver disease is uncertain, 25%. Both the etiology and the severity of the liver disease is uncertain, about 25%. There is a suspicion of non-cirrhotic portal hypertension, including idiopathic, about 10%. And finally, the pre-transplant evaluation, including liver and kidney, or the patient with ascites but no clear evidence of cirrhosis, about 5 to 10%. So in conclusion, my main takeaways are as follows. EUS PPG measures hepatic and portal vein pressures directly. EUS PPG appears to be safe and correlates with clinical parameters of portal hypertension. EUS correlation with HVPG has been shown in the animal model, and human trials with further correlation are ongoing. While not supplanting HVPG, EUS PPG may offer unique advantages. And the one-stop shop endohepatology concept is certainly clinically emerging. I'd like to thank you for your attention.
Pancreagen Pancreatic Cancer Risk Classifier and PanDNA Pancreatic Cyst Molecular Classifier can increase confidence when used with EUS FNA and ERCP procedures and other first-line tests to look below the surface.
Hi, I'm Prashant Katie, I'm Medical Director of Interventional Endoscopy at Methodist Dallas Medical Center. I'd like to thank Michelle and Monica for inviting me to the MAGIC course to give the legacy lecture, Biliary Access and Altered Anatomy. We're going to jump right in here. And as you know, ERCP is the gold standard for pancreatic biliary access with very high success rates. Surgically altered anatomy, however, is becoming more common due to bariatric and oncologic operations. In the setting, enteroscopy-assisted ERCP has success rates of about 70%. Also, percutaneous biliary drainage is a well-established option. However, it does have its risk of catheter-related adverse events, such as pain, bleeding, dislodgement, need for repeat interventions, and also significant lower quality of life. Because of this, over the last 2 decades, endoscopists have developed various therapeutic EUS techniques that will allow for biliary drainage in these altered anatomies. I kind of divide them into 2 categories. One is the direct EUS-guided biliary drainage. This is a one-scope technique in which you use a therapeutic EUS scope to access the biliary system directly with a needle, and through which you advance a wire. And over that wire, you can perform biliary intervention with the EUS scope itself. This is usually antegrade therapy or formation of a hepatic gastrostomy in the setting of a surgically altered anatomy. The other category is EUS-directed ERCP. This is a 2-scope method. This is where you're using EUS to allow for directed biliary access using a duodenoscope. This can be achieved in two methods. One is the rendezvous technique, which has been around for some time. A newer technique is really the formation of an enteroenteric fistula using a lumen-opposing metal stent, and through which a duodenoscope can be passed to perform conventional ERCP. Now, before we get into these techniques, let's talk a little bit about the pre-procedure planning. This is, of course, very important in any of these procedures before you start. You got to review the anatomy, right? You got to understand what type of anatomy you're dealing with. Look at the operative reports, look at the history, make sure you correlate that with the imaging, CTs, MRIs, et cetera, because you got to confirm this anatomy. Otherwise, your risk of failure can go up. And when you're doing that, also confirm the need for biliary intervention and what type of plan of action you're going to undertake. Some of the common anatomies that we encounter include Billroth-2, Whipple, a Roux-en-Y gastric bypass, and Roux-en-Y hepatococcygeostomy. So in Billroth-2, usually you have a distal gastrectomy with the formation of a gastrojejunectomy, a angulated pancreaticobiliary limb, and then a more en face enteral limb here. Generally, the ampulla is about 30 to 50 centimeters from the gastrojejunal anastomosis, so it can be accessed with a forward or a side viewing endoscope. However, you will encounter an inverted ampulla, so your bile duct orientation will be more towards the 5 p.m. as opposed to the 11 a.m. And in these scenarios, using a straight or a rotatable catheter is very useful. We often have patients in the left lateral or prone position here. If you look at large studies looking at afferent loop intubation and cannulation using forward and side viewing scopes, success rates are similar, 90 to 86% for intubation and above 90% for cannulation. The main risk factor with these procedures is perforation. Large studies have shown 3.6% of perforation of the gastrojejunal anastomosis and up to 18% in other small case series. And that's because of the angulation at the GJ anastomosis and fibrosis there. So that needs to be discussed with the patient. In cases where conventional cannulation fails or you can't reach it because of malignant obstruction, EUS-guided biliary drainage can be employed in these series. And small case series have been shown that a hepaticoenterostomy or antegrade methods can be useful in these techniques. Now, let's talk about Whipple anatomy. This is a very common surgical anatomy that we see for head of the pancreas diseases, proximal duodenal diseases, and here you end up with usually an antrectomy, although there are pylori-sparing Whipples now, with a duodenectomy and the formation of a gastrojejunectomy, a hepatococcygeostomy, and a pancreaticojejunal anastomosis as well. There is a angulated pancreaticojejunal limb, as we said before, and then there's also a more en face enteral limb here. The hepatococcygeal and PJ anastomosis are usually about 45 to 60 centimeters from the GJ anastomosis. In our center, we usually use a pediatric colonoscope in a supine position, and we have pretty good success rates with that. If you look at large studies in the literature looking at colonoscope and EA-assisted ERCP, success rates are about 84 to 93%. However, again, EUS-guided antegrade and rendezvous therapy has been and can be employed in these scenarios. What I think is more interesting for the Whipple anatomy, which is a little tangent from biliary access, is really pancreatic access, because if you look at the pancreaticojejunal anastomosis in Whipple anatomy, it's almost impossible to access it by ERCP conventionally. It's not uncommon that these patients will develop a pancreaticojejunal stricture, which leads to recurrent pancreatitis due to ductal obstruction in these patients and progressive dilation of the pancreas duct. And trying to access this stricture conventionally is very, very low success rate, 0 to 8%. Therefore, EUS-guided pancreas duct drainage in these scenarios can help avoid revisional surgery or completion pancreatectomy. The concept here is to use a linear ectoendoscope to access the main pancreatic duct from the stomach usually, and a needle can be advanced into the main pancreatic duct, through which a long wire can be advanced into the duct and then maneuvered across the stricture into the jejunum. After this has been performed, various dilation methods can be used to create a tract, and then a jejuno-pancreatico-gastrostomy stent can be placed, forming a long-term fistula for this patient, decompressing the duct with high rates of success in terms of clinical resolution of pancreatitis. We helped publish a multi-center study with Dr. Cahalo's group a few years ago showing success rates of 89 and 92% with adverse events about 20 to 35%, many of which were pancreatitis after the procedure. But I can tell you in all of the cases that we've done at our center, there are pancreatitis recurrent episodes resolve after this. Now let's talk about Roux-en-Y gastric bypass. This is the second most common bariatric procedure performed across the world. And for some reason, surgeons still perform this procedure without taking out patient's gallbladder, even though they are extremely lithogenic in the setting of weight loss after bariatric surgery. About 30% of patients will develop stone disease and are set up for need for ERCP within 2 years of this procedure. So in the gastric bypass, you end up with a small gastric pouch with an end-side gastrointestinal anastomosis, a long roux limb about 150 centimeters with an angulated JJ anastomosis with a pancreatic biliary limb that's about 30 to 60 centimeters to your native ampulla. Now, enteroscopy-assisted ERCP in this scenario has a success rate of about 63%, so not so great. And so other methods have been developed. Conventionally, in the past, laparoscopic ERCP was a standard in which we would work with our surgical colleagues to create a access point from the excluded stomach using a 15 millimeter trocar into the excluded stomach, through which a standard duodenoscope could be placed and then traversed to the ampulla to perform conventional ERCP. Data shows that the success rates were quite high, 90 to 98%. Adverse event rates were reasonable. However, there was a conversion rate up to 13% in some studies. The main problem with this procedure is really a pain to coordinate, right? You're in the operating room. It's a very long procedure. You're kind of at the surgeon's schedule and mercy. And then you're doing your ERCP in a non-endoscopic setting. So it's very challenging in those scenarios. So this is why the concept of EDGE was developed. The idea was to create a singles team, single session, minimally invasive procedure that had a high technical success rate that could be performed completely in the endoscopic suite. And this is what Dr. Tejela's team in 2014 developed and performed. The idea here is to create a temporary fistula from the gastric pouch or the jejunum to the excluded stomach using a lumen-opposing metal stent. And these became available in 2014, and this is when this was first performed. This temporary fistula allows for passage of a standard duodenoscope through it to give access temporarily to the ampulla to perform conventional ERCP. The landmark study came out in 2014 and was met with a significant amount of skepticism and resistance, as can be imagined, as it was the first procedure of its kind. Concerns being about long-term risk, weight gain, fistula, etc. But over the past 8 years, the data on EDGE has been very, very strong and published in multiple settings. If you look at this meta-analysis of 168 patients, overall technical success rate 97%, overall adverse events 28%, but serious adverse events were less than 1%. So these are very good outcomes. If you look at the comparative outcomes of EDGE versus enteroscopy-assisted ERCP, again, technical success rates for EDGE are higher, the procedure times are lower, and they have similar adverse events. And if you look at one of our studies, we're comparing EDGE to laparoscopic-assisted ERCPs. They both have very high technical and clinical success rates, similar adverse events, but EDGE had a significantly shorter procedure time, as you can imagine, and a significantly lower length of stay in the hospital. This has also been corroborated by a meta-analysis that was just presented at this past DDW, including 5 studies. Now, I think we are kind of in agreement that the short-term outcomes of EDGE are good, but what about the long-term outcomes? And I think this is still an evolution, and we're trying to understand this better. We presented one of the largest studies looking at this past DDW with Dr. Michelle Tejela's group, 172 patients. What we found across 10 centers, what we found is that about 75% of cases are being done with the 20 millimeter lens now instead of the 15, and 44% of those cases are single session edges. Attempted fistula closure when the lens is removed only occurred in 37% of cases. And of those, the majority were closed with suturing. And long-term fistula assessment of the fistula in all cases only occurred in 36% of cases at about 6 to 7 months mean follow-up. So we really have a low rate of closure and a low rate of follow-up, and so we're not doing a great job of that. And of those small number of patients that did have a long-term assessment, persistent fistula existed in about 30% of those patients. So we looked at data to try to predict what were the risk factors that may correlate with development of persistent fistula. And what we found that the only factor that predicted it was a long LAMS indwell duration. So 85 days versus 51 days did predict a long persistent fistula in that group. However, LAMS size, location, cautery assistance, single session, attempted closure did not predict the occurrence of a persistent fistula. But clearly we need more data on this. We need better data on this, quality data, and we need more rigorous surveillance and standardized surveillance from all groups performing this procedure. And in the study, 37% of patients gained an average of 11 pounds, and 42% of which really gained less than 5 pounds. So really not significant weight gain, although multiple studies have now shown that weight gain is correlating with the evidence of persistent fistula. Finally, we'll talk about Roux-en-Y hepaticojejunostomy. This is a procedure in which the stomach and duodenum and ampulla are left intact. However, you have a jejunal anastomose about 20 centimeters past the ligament of Treitz with an angulated entry into the pancreatico-jejunal limb, which can be long to reach your hepatico-jejunal anastomosis to the proximal common bile duct. In this scenario, enteroscopy-assisted ERSP does have a success rate of about 72 to 82%, so this can be quite challenging. And in terms of EUS-directed therapies, one concept that has been put out there is using a fully covered metal stent to access the left biliary system to create a conduit, basically kind of like a fistula, through which antegrade therapy can be performed. This was described by Dr. Barron's group in a small series with a 100% technical success rate. And what they would do is advance a cholangioscope or a forward viewing scope through these stents to perform therapy, which is quite good. And the other newer concept now is performing EDEE, or EUS-directed transenteric ERSP, a spin-off of EDGE, where you're using a LAMS to form a enteroenteric fistula into that pancreaticobiliary limb, through which a forward or side viewing endoscope can be advanced to perform conventional ERCP. And this is being performed more and more in different centers. One case series showed a 99% technical success rate in a small series of 18%. So take-home points here: surgical altered anatomy in the setting of ERSP is becoming more common. Therapeutic EUS, both by direct EUS drainage and EUS-directed fistula formation, are powerful and effective techniques that provide minimally invasive options for pancreaticobiliary access in various anatomies. Pre-procedure planning, including reviewing of their anatomy, imaging, and operative reports, is crucial to plan appropriate interventions, such as one scope versus two scope methods. EDGE has now become a worldwide first-line option for biliary access and Roux-en-Y gastric bypass with good individual and comparative outcomes. However, we really do need more standardized follow-up of the fistula closure, and patency needs to be established and studied to optimize long-term outcomes for these patients. Furthermore, EUS-directed therapies via fistula formation are needed to further study these novel indications. And these procedures really need to be performed in centers of excellence in therapeutic EUS in a multidisciplinary setting with proper IR and surgical backup. Now, since this is the legacy lecture, I'd like to end with a quote: "Carve your name on hearts and not tombstones. A legacy is etched into the minds of others and the stories they share about you." I'd like to commend Dr. Michelle Cahala for doing this in a lifelong, selfless service to advancing the field of interventional endoscopy and teaching those around him. He has certainly created a wonderful legacy, and I think that his teachings will live on with the students around him. And I thank you for this opportunity. Thank you.
The world's first AI-driven test to predict the risk of progression from Barrett's esophagus to cancer. TissueCypher.
My name is Harun Shahid. I'm one of the advanced endoscopists here at Rutgers Robert Wood Johnson. I want to welcome everyone to Magic 2022. Thank you for everyone for joining us today. Today we're going to be doing a few live cases. Obviously you saw some of the lectures already. We do have Dr. Nikhil Kumta and Dr. Prashant Kedia who are going to be moderating the cases. So they'll be moderating the cases. So we can move on to the initial presentation for the first case.
Good morning, everybody. My name is Mohammed Beg, one of the advanced GI instructors at Robert Wood Johnson. Welcome, everyone. I will be presenting the first case that is going in. So the first patient we have is a 33 years old female with history of gallstone necrotizing pancreatitis, complicated by peripancreatic collections, and she previously was managed in the community conservatively and was referred to our center. She ultimately underwent EUS-guided cystgastrostomy, and ERCP with biliary and transpapillary gallbladder drainage on 5th of July 2022. Subsequently, she had a prolonged admission and she underwent inpatient necrosectomy sessions on 15th of July, 22nd, 25th, and 1st of August, and the last session was on 5th of August 2022. So then she was discharged, and today she's coming in for outpatient EGD with necrosectomy and usage of possible endorotor device. Going over the images, so this was the initial CAT scan, which was done at the time of initial diagnosis, as you can see on 3rd of June. And you can see there was a large peripancreatic collection, and afterwards she underwent the cystgastrostomy and necrosectomy sessions, and this is the last CAT scan from 5th of August, and you can see the collection has significantly reduced in size. This is our lumen-opposing metal stent and the plastic stents going into the collection. And today, Dr. Shahid is going to do the further necrosectomy session.
Welcome back, guys. Once again, Harun Shahid. I also have Dr. Mihailo Georgievsky in the room. He'll also be commenting during the case. As our advanced fellow just mentioned, we have a lady here who had bad necrotizing pancreatitis with a very large walled-off necrosis cavity, has undergone some traditional necrosectomy sessions already. She did well enough to be discharged from the hospital and now coming back for an outpatient necrosectomy. Our plan today was to do necrosectomy using the endorotor, which is almost like a morcellator device. So there are two endorotor devices that are available. One is a smaller catheter that goes through a therapeutic upper endoscope, and a larger catheter called the Necromax 6.0, which is this catheter here. I'm not sure if we're able to zoom in a little bit to show the catheter. But basically, it's a catheter that has a outer cannula and an inner cannula. The inner it has suction which kind of pulls in tissue. And it has the inner cannula rotates at over 1,000 rotations per minute, and basically cuts that tissue and suctions it through. Yeah. So this device is normally used. It's a very large device, as you can tell. It does not go through the channel of a regular therapeutic endoscope. So we actually have. I'm going to ask you to hold this for a second. So usually we'll have an EGD scope that has a outer sheath that allows the passage of this device, and it allows us to perform necrosectomy. So we can put that back. I did take a look inside this cavity before coming live, just to see, how easy it is to gain access to the cavity and pass the instrument. And we were able to get into the cavity, but the initial entryway is a little narrow. And if you look at this device, it's about 6 millimeter diameter sheath, and then you have a regular endoscope, which is about 8 or 9 millimeters. Because of that narrowing, we're having a little bit of difficulty getting deep into the cavity to use this to perform necrosectomy. I don't think we'll use the larger device. We're going to use the smaller device that does fit through a therapeutic endoscope, and show you kind of how that device works. So I'm going to switch over to the other endoscope. We can move this out of the way, guys.
Hey, Haroon. Good morning.
Good morning, Prashant. How are you?
This is Nikhil.
Oh, Nikhil, I'm sorry.
That's okay. I just while you get everything set up, I just wanted to ask a question. If for the audience, what's your approach with utilizing some of the other modalities aside from necrosectomy, for example, use of hydrogen peroxide or any other adjunctive measures that may be helpful in necrotizing pancreatitis? Can you talk about sort of your approach or algorithm to patients?
Just quickly, just to show the endoscopic view, we're seeing here a 20 millimeter lumen opposing metal stent that's draining this walled off necrosis cavity. So as Nikhil mentioned, there are a lot of adjunctive therapies that we can use for necrosectomy, endoscopic necrosectomy. Normally when we're doing necrosectomy, it's a long, arduous process. It takes a very long time. We're using snares and baskets and, retrieval nets and things like that to remove the necrosis out of the cavity and release it into the stomach, and continually intubating and extubating the lumen opposing metal stent to do that. So there are a few other modalities that we can use to help facilitate necrosectomy. One of them is using hydrogen peroxide. Usually the hydrogen peroxide is diluted in a 1:5 or 1:10 dilution and lavage the cavity. What that allows basically an enzymatic reaction to occur where that necrosis is broken down and facilitates necrosectomy. There are studies showing that does help in terms of necrosectomy and decreasing the number of necrosectomy sessions. So I routinely will use hydrogen peroxide in all of my cases when I do necrosectomy. I usually use a 1:5 dilution mixed with normal saline. There are other modalities as well. Things like using a nasocystic drain where you can place it transnasally and into the cavity to help kind of lavage the cavity, 24, 48 hours or until your next necrosectomy session to help kind of mobilize some of that necrosis and allow that to drain. So that's, I will be giving a lecture a little bit later today as well on the management of pancreatic fluid collection. I'll go through some of the data regarding some of these other modalities. But Nikhil and Prashant, what is your normal practice when you're dealing with someone who has necrosis, pancreatic necrosis? And just quickly, I'm going to just mention this is the necrotic cavity. As you can see, the proximal portion of the cavity, just immediately distal to the lumen opposing metal stent, is actually pretty clear. You still have some necrosis deeper into the cavity, and almost something that looks like purulent debris further down. And the reason that I was having difficulty with the Necromax larger catheter is this right here, as you can see. It's still a 20 millimeter stent, lumen opposing metal stent, but you can see the initial entryway into this cavity is actually much smaller. So that's why we were having difficulty fully advancing in there. And I thought it wouldn't help us facilitate necrosectomy with a larger catheter. Sorry, Prashant, I think I cut you off.
Prashant here. Yes, it looks like you got your work cut out there for you a little bit. These are, as you mentioned, challenging lesions and have to kind of be individualized based on the patient in each case. And I think each endoscopist across the board has their own kind of personal preferences on how to address these lesions. Personally, at our center, generally, when somebody has a symptomatic walled-off collection, we will place a 20 millimeter Axios, as you have done. And we don't perform index necrosectomy. We kind of just allow for drainage at the index session and then monitor how the patient does. This is kind of based off the initial stepped-up trial data where 35% of patients never actually ended up needing necrosectomy after a form of drainage itself. So we'll do the Axios initially, wait to see how the patient does after drainage. We're often placing a double pigtail through the Axios, and then over time watching how the patient does. The key thing is nutrition for these patients during this time, and so one of the main things we're addressing is how are they going to get enteral nutrition throughout this process of treatment and whatnot. And if they can't take it orally, these patients are often getting PEG-Js at our center to facilitate long-term nutrition. And then over time, we'll see how
what was the last part, Prashant? Sorry, I missed what the last part you just said.
I was just saying that we will often place PEG-Js in these patients that have prolonged courses for requiring the physician to facilitate nutrition.
Oh yeah.
When I do my initial necrosectomies, usually I'm using a combination of rat tooth forceps, suction, and stiff snares. I used to use a lot of Roth nets, but they just get destroyed during the process, and you're going through multiple Roth nets in a single necrosectomy session. So we'll usually use snares and forceps, and then we've been now recently, as you're doing, using more of the endorotor device.
Yeah, I agree with you 100%. My personal preference is actually to use snares. I don't really use any of the Roth nets or retrieval nets, just because, as you mentioned, they oftentimes, you use it once and it's kind of almost done. So there's a question from the audience asking, what stent do we normally place initially? I'm assuming that's the metal stent that's placed. So normally I tend to, depending on the size of the cavity, I'll be placing a 20 millimeter lumen-opposing metal stent, which are these biflanged dumbbell-shaped stents. I'll come out of the cavity just to kind of show what this looks like again. We're seeing obviously one portion of it. The other side of the stent looks exactly like this as well. And what it does is it prevents migration. It is a 20 millimeter diameter, so it's very easy to pass a therapeutic endoscope through this cavity and perform necrosectomy. These lumen-opposing metal stents have drastically changed how we perform necrosectomy. When you think about, how necrosectomy was initially performed, when EUS was first being utilized, it involved a lot. You needed to puncture the collection, sample some of it, pass a wire, use a cystotome or a needle knife to create a fistula tract, dilate the tract, and then place a metal stent, or initially were really just plastic stents that were placed. And then, we obviously moved on to using fully covered biliary stents, off-label to drain these walled-off necrosis cavities. And then with the advent of these lumen-opposing metal stents has drastically changed how we do, pseudocystin walled-off necrosis drainage. So my preference is to use a 20 millimeter just because it is a larger caliber stent. It facilitates performing necrosectomy. I think it allows better drainage as well. So that's what I'll place. And then on the initial index procedure, I don't perform any necrosectomy, as Prashant had mentioned as well. I'll place, a few double pigtails into the cavity to try to prevent the lumen-opposing metal stent from getting occluded. We have one more question.
Harun, Nikhil here.
Hold on 1 second, Nikhil, sorry. I have another question coming in through my earpiece. So the question is, if I plan to do necrosectomy with endorotor, do I preferentially place the stent in a particular position? I think oftentimes, it would be great to be able to place the stent in a relatively straight position where the scope enters the cavity in a straight position, facilitating using the device like the endorotor. The problem that oftentimes happens is it really depends on what your window is and what you see on EUS. So you don't oftentimes have the ability to make that decision and know exactly where your stent is going to be. Obviously, when you're using a linear echo endoscope, it's an oblique viewing scope, so you're not seeing the GI tract as you would with a forward viewing endoscope. So even though it may look like you're in a straight position, where you end up placing the lumen-opposing metal stent may be at an angulation and could sometimes make it difficult to perform necrosectomy or intubate the collection. Sorry, Nikhil, I cut you off. You had a question as well?
No, I was actually going to read that question to you from the chat.
Sorry.
From Professor Alberto Larghi from Rome, who also is asking another question on the study by the Dutch group in gut that shows no difference between plastic and metal stents for necrotizing pancreatitis. If you can comment on that, and then maybe we'll let you go ahead and get started as well on the endorotor so that you can talk us through this case as you're answering some of the questions that come in.
Yeah. That study did show there was no significant difference. I think, when you place metal stent, it does facilitate performing necrosectomy and being able to intubate the cavity. It is a much quicker procedure as well. Obviously, you didn't see me place this lumen-opposing metal stent initially, but it's a very, with a cautery-enhanced lumen-opposing metal stent, to drain the walled-off necrosis cavity on at least the index procedure, it takes 5 minutes, as opposed to if you're placing double pigtail stents. Normally, you're using multiple double pigtail stents into these cavities, and again, you're going through that whole process of using multiple instruments, of multiple exchanges. There's always a risk you may lose your wire. The lumen-opposing metal stent is placed freehand. You don't even need a wire to guide you in that situation. So my preference is still to use these lumen-opposing metal stents just because of the ease of necrosectomy after the procedure. I'd be interested to hear. I'm going to start doing some of the necrosectomy here. You're gonna see me turning on the device here. Now the inner cannula is actually rotating at about 1,000 RPMs. You can see. I'm going to turn it upwards, so you can see the outer cannula, and the inner cannula is what's spinning there. I stopped it there, and now it's spinning again. So that's what's going to basically cut the tissue, and then you have suction basically that's going to pull in some of that tissue, and you're going to be able to see it kind of pulling in some of this tissue here. There you go. So this has drastically improved the amount of time that we spend doing necrosectomy. Let me try to get a little bit deeper in the cavity. This initial study that was done with, I believe it was 30 patients, showed that about 50% of patients only needed one necrosectomy session for complete clearance of the walled-off necrosis cavity. For those of us that perform endoscopic necrosectomy, it's a very long, arduous process, and oftentimes it does involve multiple endoscopy sessions. So, I think it's a great new technology that's being utilized for endoscopic necrosectomy. That initial study really looked at using the smaller device, which is what I'm using right now. It didn't look at the larger device, and you can see it's kind of being suctioned in there. So it's working very well, and you can spend a lot of time trying to grasp this tissue with a Rothanet, with a retrieval basket, with a snare, and oftentimes you're not grabbing enough tissue. You try to come out, and all the tissue doesn't come with you; it stays in the cavity. Sometimes the consistency of the necrosectomy is like mud, so it's hard to get all this stuff out. I'm going to ask Mihailo, who's in the room, what's his preference on using devices for necrosectomy. Obviously Mihailo is actually in private practice as an advanced endoscopist. He was one of our advanced fellows who's doing great things in Atlanta now. So I wanted to hear your experience. This is not something that's usually available in private practice. So what are you doing in terms of these patients that have necrosis?
It's very interesting. There's such a big difference, I guess, from group to group and from person to person, how they do necrosectomy. Mm-hmm. And just because there's no standardized trials or standardized papers on how to do this, right now I use quite often actually a nasocystic catheter, and I keep the patients inpatient for a week or two, with them going back and forth with a necrosectomy, endoscopic necrosectomy every 3 to 4 days. But the nasocystic catheter, my personal experience, works great, especially if you do 1 to 4, 1 to 3 with a mix of hydrogen peroxide and saline, and just keep it at 50 cc's per hour flow for 24 to 48 hours. It does a lot of softening that necrosis, and then you just go in and clean out the remaining of it. When I do actual necrosectomies, I usually go with a braided snare. I still think it catches the best, much better than the extraction baskets or the Rothanets, at least in my experience. And as soon as the patients are feeling well and there's no indication that there's still active infection going on, I usually send them home and get them back every 2 weeks with the premise that they can eat and they can digest most of the necrosis just with their gastric acid and with the food that they're ingesting. So far, that's been working great, and I will probably keep doing that for now.
Thank you very much for that, Mihailo. We're going to actually go over to room 2 where Dr. Sarkar is doing his case. So we're going to switch over to room 2 for now, and you may come back to me a little bit later.
Hi, everyone. Can you hear me?
Yep.
Hi, good morning, Avik. Nikhil and Prashant here. We can hear you.
Good morning, Nikhil, Prashant. Thanks for joining us today. I'm Avik Sarkar. Before we get to the case presentation, I'll just go around the room. I have Kelly here to my right. I have Sadia in the back. Juniors giving us fluoroscopy today. Ellen and Dr. Kohlmeyer are giving us anesthesia. And last but not least, I'd like to introduce Dr. Abed Abdelkader. He was one of our fellows a year ago, and now he's a superstar endoscopist down in Florida. So welcome, Abed. Nice to see you.
Thank you. Thank you for having me.
So now we will have the case presentation.
So here we have a 74-year-old man. He has a history of a cholecystectomy. Was referred to us. He had a pancreatic head lesion that was confirmed pancreatic head cancer with an associated malignant biliary stricture. On EUS, it ended up appearing that the patient had some encasement of the vessels and was deemed not a surgical candidate. In May of 2022, this year, ERCP with stent revision, placing a fully covered self-expanding metal stent, and also RFA of this malignant biliary stricture was performed. So today, we're planning on doing an ERCP with stent revision and RFA of this biliary stricture.
Okay, so I've already gotten started a little bit. I took out the prior biliary stent that was there. It was a metal, fully covered biliary stent, and it's gotten a little bit bloody. And I've had some difficulty finding the ampulla after I took the stent out. So I was able to recannulate, and we have gotten inside the duct again, and we did a quick cholangiogram. Can we show the cholangiogram image? There it is. So we can see here that despite the patient having a metal biliary stent in place for a few months, there's still a mid-biliary stricture from the underlying malignancy. So normally we would do just a stent exchange, but in these patients who have unresectable pancreatic cancers that are causing a malignant biliary obstruction, we tend to do same session biliary radiofrequency ablation during our stent exchanges. Prashant and Nikhil, is this something you guys incorporate into your practice?
Great question, Avik. This is a technology that's been around for some time, but has not really taken off, per se in standard practices around the world. Partly because, the criteria for selection and who we're performing these on. I agree that these are probably more palliative measures that we're using and employing here. It's not curative. It's just to potentially prolong stent patency. Maybe prolonged survival. The studies on RFA have been largely retrospective and not the greatest prospective studies. Actually, stronger data exists in PDT, but that's just a bear to undertake, for these types of lesions and malignant strictures. So we do it selectively in some patients, but we're not routinely doing it in every single unresectable pancreatic cancer patient in which we're doing stent exchanges for, because often not doing that many stent exchanges for these patients because of their survival times in general. I don't know if you have any other thoughts.
Yeah, I would agree with you, Prashant. We actually present our cases in a multidisciplinary tumor board. We want to make sure that we have buy-in from our oncologists, our surgical oncologists, and then a lot of it also involves the patient and their willingness to come back for procedures. I would agree with you that photodynamic therapy or PDT is also quite onerous. The patients have to get an injection. They have to be very careful in avoidance of the sun. So a lot of patients don't prefer PDT, but we do offer in selective cases, RFA with the Habib probe for palliative treatment of unresectable, predominantly, distal cholangiomas, or in some cases with pancreatic cancer that's invading into the bile duct. But what are your thoughts, Avik? And I look forward to seeing you doing some RFA today.
Yeah, so before I discuss more on that, I just would like to show you the catheter. Can we have the camera zoom in on the catheter here? So this is our, it's an 8 French catheter. It's wire guided. There's a lumen in the center for the wire to pass through. You can see there's 2 silver electrodes that are just at the tip of this catheter. And this whole area from the top of the first silver tip to the bottom of the second silver tip is the ablation zone. So it's a 2.4 centimeter ablation zone. And these are radiopaque markers. So we've measured out our stricture here with our cholangiogram, and then we're going to pass this catheter over the wire, and I can position precisely the catheter in the area where the stricture is and perform our ablation. So I'm going to hand this over to Kelly now to help me pass this down.
Avik, do you want to talk about the settings, energy settings you're using on these catheters, and if people want to employ RFA, how they can set these up on their standard Irby machines and whatnot?
Sure. So today we're using the new Irby Vio 3. We have a soft coag bipolar current at 10 watts, I believe, correct?
Yes.
2.5
That's an
watts.
important point.
2.5 watts.
Is the energy settings and the time that you're employing for these catheters. Usually 8 to 10 watts, usually around 90 seconds for distal strictures. If you're employing this technology at the hilum, which you're not, you have to control those settings even further, right? There have been some studies in RFA in hilar strictures, which have led to major hemorrhage due to hepatic artery injury and actually fatalities in that. And so usually the energy settings in the hilum are lower and less intense. But 8 to 10 watts for about 90 seconds or so is kind of a standard for the distal bile duct. I don't know, Gil, if you have any comments on those things.
No, I absolutely agree. Just be very mindful with the energy settings. I tend to stick to more of the lower end of that, 7 to 10. And you have to be, as you mentioned, very careful up within the hepatic parenchyma or up in the hilum. With the depth of tissue injury that can occur, you can run into problems with bleeding sometimes.
Okay, so we have the fluoroscopy image up. We have the catheter in the duct now, and you can see I've positioned the top of the ablation zone right just above the top of the stricture that we have. And you can see that the contrast has not fully drained due to the stricture that's here. So we will go ahead and get started with our ablation. We're going to use our blue coagulation pedal, and I'm going to just hold this pedal down, and there's a timeout function which the ablation will stop once the time limit is reached. I don't know if it's possible to adjust the camera to the Irby so we can look at the Irby screen. It's right here where I'm pointing. Abed, can you walk us through, as I'm doing the ablation, what the Irby here is doing?
Yeah, so as he hits the blue pedal, the coagulation pedal, there's going to be a raised bar here along the side of the number that reflects the endoluminal contact with the biliary malignant tissue. So if that line is essentially not illuminated, it's kind of reflecting essentially there's no tissue contact. So you want to make sure that you have that blue bar. Ride the pedal for about 90 seconds, which is a set rate, and it'll deliver the maximum wattage that it's set at. And then typically afterwards, you may see during this process, you may see a little bit of bubbling too, as well too, if you're near towards the ampulla.
Yep, so you see I just lost some contact here because the bar, it kind of went down, so I'm going to try to do a small adjustment.
It's really helpful for real-time feedback as well too, so you can adjust as you go.
Can I get fluoro, please?
You can kind of see here the tissue contact now is a little bit on the lower side and it's somewhat fluctuating up. That's better.
Yeah.
Yep, right there.
Okay. So I'm going to just come down again. Flora, please. I'm going to just do one more at the bottom here. And typically after we do the ablation, and you can see here again, I have good contact again. So after doing the ablation, we obviously will get necrosis of the lining of the bile duct. So our practice after doing the ablation is to do a few biliary sweeps with a balloon to remove all the necrotic debris. After which we do place a stent, and in this case I'll be placing a fully covered self-expandable metal stent. So
so that's a good point. You know, with this device, you're having the heat that's essentially causing protein denaturation, and then you have cell dehydration and essentially coagulative necrosis that happens. And so it's important that, you know, once you do your RFA, you then go with a biliary balloon and actually sweep out some of the debris that's there. And then depending on the size and the location of the stricture, you can do an additional RFA application in that same stenting. You know, and then generally after you finish all your RFA sessions, then you're going to go back and put a self-expanding metal stent.
So we just finished the ablation, but unfortunately we lost the wire, so I'm going to recannulate and then do our balloon sweep. So I'll take the balloon catheter over the wire.
So with RFA, the concern is that you're delivering energy relatively blindly into a duct, right? And so the damage that Nikhil was talking about can lead to complications. There are some complications that have been listed, with RFA, bleeding kind of being one of the more common ones, and then cholangitis post-RFA. And that is because of the coagulant that Nikhil was talking about. And if it's not cleared or it's not given a pathway for drainage, these patients often after the RFA procedure can develop infection because of that. There are some newer RFA technologies that are available not in the United States, Korea, not, which have heat sensitizing or heat sensing catheters that can regulate the temperature of the catheter so that if they get to certain levels, it will slow down the energy levels. And so that is supposedly thought to potentially improve risk of complications and deliver energies that are more apt to control the tissue but not cause damage necessarily in the bile duct. But there's no comparative trials on these devices now, but interesting things coming down the road with technology.
Any experience for anybody in the panel with the other new biliary RFA with Taewoon?
No, not at this point.
All right.
Yeah, same for me. I use the Habib probe currently.
Shukdawar. So as you guys were mentioning about the coagulative necrosis that happens, and that's kind of the direct effect that we see in the bile duct, but we also see an indirect effect on some of the surrounding tissue. So, in this patient who has pancreatic cancer, although we're not directly ablating the pancreatic cancer, there's some indirect ablation that does occur due to the tumor being right adjacent to the bile duct. And, I know there's been some studies looking at this to see if chemotherapy is more effective in these patients who have ablation. Do you guys have any experience with that in your institutions?
Yeah, so as I mentioned, at our institution, we present these patients in a multidisciplinary setting. And so usually these patients are generally on concurrent chemotherapy. You have to realize that this is really only going to be applicable for unresectable malignant biliary strictures, and it's a palliative indication. So, but we oftentimes will have concurrent biliary RFA and chemotherapy as well. Prashant, what has your experience been with these patients?
Yeah, I agree. We always discuss with the oncologist and teams about how we're going to manage these patients. There hasn't been a large drive for us to do it. There's been a large push from the oncologist side. If we notice that there's any stent occlusion early on in any patient, we will offer this, and they have no problem with us doing it. But as of right now, because we're looking at this in the palliative setting, the survival of these patients is on the order of months. The additional advantage of RFA in terms of survival has not been proven. There's no large studies. Doing a randomized control trial on something like this is really challenging, or hasn't been done yet. So it's more of a case-by-case basis. And so far, the cases that we have done have gone well. I feel like it does keep the strictures open longer.
Vic, while we're watching getting access and some of the course that we've got a question from the audience for you. How do you prevent stent migration with a fully covered stent?
Yeah, that's a great question. So fully covered metal stents obviously are beneficial because they can be removed very easily, and there's not much tumor ingrowth that happens except for the very tip of it. But that being said, they can migrate because of their properties. In my experience, when I'm placing these for malignant strictures, I have a very low migration risk. And because the stricture is so tight, the stent tends to stay in place. The caveat being these patients are on treatment. So if they're responding to treatment and their stricture is improving, then yes, we may see some migration. So initially when I place these stents, I just place the covered metal biliary stent alone, and the tight stricture keeps it in place. As I'm doing stent exchanges, and if the patient is responding to treatment, I'm seeing the strictures improving. When I place my metal biliary stent, I will anchor it in with a plastic double pigtail stent to anchor it and keep it in place and prevent migration. So as I was removing the RFA catheter, some necrotic material did come out, and now I'm going to do my sweep to see if I can get some more necrotic material out. So I have the balloon now at the bifurcation. We're going to inflate the balloon to 12 millimeters. I'm going to do fluoro here, and I'm going to do my sweep. Fluoro.
One other point I'll make on this technology is another area that it may be useful for is ampullary lesions.
Yeah.
So as many of us here do, we do ampullary resections, ampulectomies, and whatnot, and the question of ingrowth into the bile duct for patients that are not good ampulectomy or Whipple candidates can be used RFA to palliate any type of remaining tissue introductorily. And that has been quite successful in a small case of experience that I have in some of the case series in the literature. I don't know if you guys have been using it for these kind of newer indications.
I've tried it on a patient with an ampullary lesion who declined cancer, although there's always the risk of pancreatitis afterwards as well too with these patients, especially if you're doing anything more than one ablation or near the pancreatic orifice as well too.
So all right, thank you both so much. I think we see some of that necrosis coming out. I think we're going to switch rooms now. We'll come back to you. If we can go back to Haroon, and we'll check in on the progress of the necrostectomy.
Hey guys, welcome back. I apologize or forgot to mention, my wonderful staff in the room. So I just want to go through who's here with me. Vivian is our CRNA. Dr. Brett Kohlmeyer is our anesthesiologist today. Our nurses in the room are Greg and Pat. As I mentioned, Dr. Mihailo Georgievsky is here, also helping to moderate, and then Tom, our radiology technician, is also in the room. What we do here, we can't do without them. So I just wanted to make sure that they know that, they're an integral part of our team. So I came out of the cavity actually just right before. I needed to clean the end of my scope, and I wanted to just show you while we're cleaning the underwater device again, and before putting it down, is come out of the cavity just to show you what we've been able to accomplish in those 15 minutes that you guys were away. So here is our walled off necrosis cavity again, and we had some necrosis in the proximal aspect here, which is now all clean, and deeper into the cavity we still have some left, but the end of the cavity is right there. So, in that 15 minutes, we were pretty much clean out the majority of this cavity. and we have only a little bit left to do. So I'm going to just wait for the catheter to come back. In the meantime, one of the things I forgot to mention regarding the catheter is that, you can turn the catheter yourself at the biopsy channel port to change the position of the opening for that inner and outer cannula. So if, the necrosis is below you, you can change it to the 6 o'clock position by yourself or move it, wherever the necrosis is. We're just reconnecting the catheter right now, so I apologize. But it looks like we're coming along pretty well in terms of necrosis. And this is why I think this device is so great, is that you can accomplish a very large amount of necrosectomy relatively quickly. In someone you're doing traditional necrosectomy using those snares and baskets and things like that, you may spend 1 hour, 2 hours and not really get too far. In that same amount of time, if you were using the endorotor, you can clear out a significant amount of necrosis, which is why that initial study showing that you can get, complete clearance in one session and over 50% of those patients was dramatic. Well, what are your guys' thoughts so far about how we're coming along?
I think it looks really great. It takes time for these, but it looks like you're making good progress. We do have a question, two questions actually, from Professor Alberto Larghi in Rome. The first one is, why do you have fluoroscopy? And then the second question is, will you place plastic double pigtail stents after you're done?
The need for fluoroscopy in the initial portion of this probably is not necessary. The fluoroscopy is really here to show you what it looks like on fluoro, and also when we place the double pigtail stents, we like to use fluoroscopy for that. But we don't use very much of fluoroscopy for a necrosectomy, and you could potentially even get away without needing any fluoroscopy. I think when you're placing the double pigtail stents to see where your wire is, because sometimes you can't see how deep your collection actually is. So to have fluoroscopy, see how deep your wire is, and judge, how long of a double pigtail stent you're going to need is very important. So I put
interesting how this whole evolution of endoscopic necrosectomy is occurring. You were talking earlier about what type of stents to use, plastic versus metal. There's differing data on that. Recently the Orlando group had a large study showing that metal stents were superior in terms of number of sessions and need for surgery. 15 versus 20, there's some retrospective study showing that 20 shows less for necrosectomy sessions. And now you have this new device, right? You have this new endorotor device that is highly more effective, at least in the few, experiences that many of us have had. You can see how effective it is. And now how you can put that into the algorithm and see how does this affect our number of sessions, how early are we getting these lesions done. And we really need more prospective study on this, because we're really finally developing tools that are specifically designed for endoscopic necrosectomy, which we did not have before. So it's a pretty exciting time for this kind of endoscopic technique and process.
Yeah, I agree with you. I mean, we've come a long way from how, walled-off pancreatic necrosis used to be managed. And you think about, over a decade ago, you're talking about, managing this surgically, which, doesn't even cross our mind anymore because we're able to do everything endoscopically. And, you have adjunctive therapies. And I'm interested to know, and I discussed this a little bit in my lecture as well, is, when you have this walled-off necrosis that extends into the paracolic gutters, or is far enough away from the GI tract that you're not able to drain, Prashant and Nikhil, what is your practice for those collections? Like, when do you get IR involved? Do you do anything else with those collections?
Yeah, I think that's a great question, Haroon, and it's an issue that that we see fairly often, is especially when you have paracolic extensions. Sometimes you'll see collections even extending down to the pelvis. I take a step back here, and I think for necrotizing pancreatitis, there's essentially one of two things that are going to lead to mortality, right? It's either going to be infection or bleeding. And so it's very important that you get adequate source control for these patients to, reduce their morbidity and mortality. So if we feel, after we place our initial cystgastrostomy that we do not have adequate source control, especially down to the paracolic gutters, I do think that it's potentially beneficial to have your interventional radiology colleagues put a drain in. You can use that drain even for irrigation as well, sort of analogous to the nasocystic drains that we may place. But there are certain instances where an IR drain can be helpful. Additionally, if we are unable to access some of the paracolic gutters for necrosectomy, you can actually utilize that IR drain and convert it to be able to perform sort of transcutaneous necrosectomy, the Claudio Navarrete maneuver. So what you can do for that is you actually put in a standard biliary wire through the IR drain, remove the drain, and then you can dilate through the abdominal wall using savory dilators to get that tract big enough to be able to get a scope through, and then you can perform necrosectomy, basically through in a transabdominal fashion. And so we've had some success with that as well. You're able to reduce the number of sessions overall needed for clearance of the necrotic debris.
Yeah, that's exactly
comment on that.
Yeah.
Okay, go ahead.
Oh no, I said that's exactly the point that I was getting at, and that's our practice here as well. For those collections that need to be drained that are in areas that are inaccessible by endoscopic ultrasound to drain, we will get our interventional colleagues involved. They'll place an IR drain, and we'll use that drain to perform percutaneous necrosectomy as well. I think you mentioned that you're using a dilator and then passing a scope through that area. We actually tend to use a fully covered esophageal stent that protrudes out of the abdomen or out of the side, and use that as our conduit to perform necrosectomy. And the patient may have that stent in. It can be removed, and you can place pigtails in, or you can leave that fully covered esophageal stent in and kind of cover it with an ostomy bag while they're in the hospital, and use it again as a conduit to repeat necrosectomy as many times as is needed. And we've actually had pretty good results from doing that. Sorry, I think I cut someone off. Was that Nikhil or Prashant that was about to say something?
So Arun, we kind of follow an algorithm very similar. There was a nice article published in the Minnesota group almost a decade ago now that still I think rings pretty true. If you look at overall, in terms of pancreatic fluid collections, only 15% of them will not be accessible from the GI tract. 85% of them will be accessible from the GI tract, and less than 50% of those that are accessible will have paracolic gutter extension. So those collections that are just around the stomach or duodenum without extension, we usually do single modality drainage or endoscopic access, as you're doing right now. But for those collections that have paracolic extension or renal-perineal extension, we do a dual modality drainage. We kind of follow a little bit of what the Seattle group has been publishing on for so many years and showing extremely good outcomes. They almost have a 0% surgical necrosectomy rate in many of their studies, where basically you put a percutaneous drain in, you put your axios in, so it's a dual modality access, and then you use the percutaneous drain not for drainage or debridement. It's for debridement, it's for flushing. Mm-hmm. So it's creating a dual access pathway where you're flushing saline through the percutaneous drain and using the efflux through your lands in the stomach or duodenum. And this is something that patients can actually do at home. They don't have to be in the hospital. You can give them catheters. They flush their percutaneous drain multiple times a day, and that actually facilitates debridement. And so we haven't had to do so many transcutaneous stents because that's usually an inpatient, something that you can do as an inpatient as opposed to an outpatient. And this has been very successful for us for dealing with paracolic gutter extension. There is a question from the audience from Rajesh. How do you prevent sucking of vessel in the cyst wall in? Do you have to tease out the necrosum from the side wall before using the rotor device? And how are you using irrigation? So these are all interesting questions because it's a new device and what type of damage may cause in there, I guess.
Yeah, there's always the possibility that you can cause damage to, especially if there's a vessel running through the collection. You just have to be cognizant of, what your cavity looks like and, what could potentially be a vessel. I think, it's important that you don't go up against the wall of the cavity if you can avoid it, because you can technically pull in some of the cavity wall and get some bleeding. But it is something you need to be cognizant of. You kind of want to stay kind of in the center and the areas of necrosis, and monitor what you're doing with the understanding that there's always a possibility there could be a vessel in there. Do you guys have any particular maneuvers that you do to try to avoid that?
We will oftentimes get a CTA before we start our necrosectomy session, just to get a sort of a roadmap of where the vessels are. I remember a couple years ago, actually, Professor Largy, who's been pretty active in the chat today, had published avoiding the SMA. But you have to be careful in these patients. We know that they can have pseudoaneurysms. Oftentimes in the setting of necrotic pancreatitis, they'll have splenic vein thrombosis, and they can have sometimes collaterals that'll form. So you certainly have to be mindful of the vessels. And I think those of us that do necrosectomy fairly frequently, it's not uncommon for us to see some vessels coursing through the cavity. So you have to be very careful in terms of your management and avoiding the vessels. And I think that's where imaging can be very, very helpful.
Yeah,
we have another question that has come in, Harun, which is, can you talk about when you do your imaging between sessions?
Yeah, I mean, it really depends on, how the patient is doing clinically. This patient is doing pretty well and is being managed as an outpatient with necrosectomy every 1 to 2 weeks. So it really depends on what the cavity looks like. During the last necrosectomy session, the patient still had a pretty significant amount of necrosis left. So I didn't get any repeat imaging before bringing her back this time. If they're an outpatient, I try to limit the amount of cross-sectional imaging studies I need, just because of the amount of radiation these patients end up getting. So I'll try to do imaging about once a month. I think when these patients are in the hospital and they're pretty sick, we tend to get repeat imaging more frequently, just because we want to make sure we're not missing any type of new complication or extension of a collection or formation of a new collection. Especially when you're bringing them down for repeat endoscopic procedures and they're symptomatic, you want to make sure they're not developing something new, like a new collection, new abscess. Obviously bleeding can happen as well. So that's normally my practice. There's no set guidelines on what you're supposed to do. I think if you asked every advanced endoscopist, they would probably give you a different answer as to how often they image these patients. But I do agree with your initial comment about having imaging, obviously, contrast enhanced imaging to see where the vessels are. We make sure that we have that available to us before we also start doing endoscopic necrosectomy. Before I go on, I just wanted to show you really quickly. We're basically hitting the back wall of the cavity right now. But this, I'm going to stop the rotation of the device. And this is, again, the device. And I just want to show you how easy it is to rotate to basically, perform necrosectomy against any wall of the cavity. So this makes it, facilitates this much better. You don't have to put as much torque on the scope. And, you can basically face it in the direction of the necrosis and continue doing what you're doing.
So Dr.
And for the audience, he's controlling both the rotation of the blades as well as the suction with foot pedals that are by his foot. So he can rotate the blade using his hand, and then he can turn the blades on and then utilize vacuum suction to perform the necrosectomy.
I don't know if you guys are seeing it, but there's some we're kind of clearing the catheter every once in a while. You'll see kind of fluid and air come through every once in a while. That's Greg, who's assisting me here. The catheter is not very large, so it can get clogged with some of this necrosis. So it's very important to have someone available to clear the catheter every few minutes, or depending on how thick the necrosis is, maybe every few seconds or so, just to make sure that you can continue doing necrosectomy.
What's your take on antibiotics?
These are all great tips.
Sorry, one second. Sorry, Mihailo is asking a question in the room.
I'm just curious about, this is an outpatient, and I have a lot of outpatients that keep them back. What's your take on antibiotics in between sessions? Do you send them home on rotating antibiotics different, or you just leave them without?
So the question was whether or not, I don't know if everyone heard about, antibiotics in these situations. I think I like to give antibiotics, not necessarily for the, for the whole time between sessions. I'll give antibiotics for a few days, just because there's always the possibility that there's an area that's not being drained properly, and we're driving a scope into a collection, potentially, leading to infection deeper into the cavity. So usually I'll give them like 5 days of antibiotics. Again, this is probably, very different depending on which advanced endoscopist you talk to. Even if you talk to, my partners, I'm sure you'll get different answers regarding that. Nikhil and Prashant, do you have any particular regimen in terms of what you're doing in terms of antibiotics when you're doing this, especially in the outpatient setting?
Yeah, it's definitely case-by-case basis. If you're seeing something like this where you're seeing a lot of kind of pancreatic fluid and potentially infected or whatnot, kind of fluid for sure, we put them on a few days of oral quinolones or whatnot to kind of prevent any possible infections that may relate to stent occlusion or cavity occlusion. But not necessarily in all cases. Sometimes there's just very dry, tarry necrosis, and the patient has been kind of stable, mostly dealing with pain and such, and so we may not do it in all of those cases. I have a question for you, Haroon. What's your treatment endpoint on these patients? Are you treating to get rid of all necrosis, radiographic resolution, or the clinical resolution? How do you decide when to finish?
Yeah, you mean in this session, or you mean just in general?
In general, yeah. As you're doing so many of these sessions, how are you deciding when someone's done or not done?
Yeah, I mean, the goal is to get rid of, all the necrosis if you can, just because they're more at risk for developing infection. You want to make sure the necrosis is, for the most part, is clear in the cavity, and the cavity itself has decreased in size, usually to about, my cutoff is usually about 3 centimeters or so. That's when I feel more comfortable about removing the lumen-opposing metal stent and maybe placing pigtails in there. So I go by, all the factors you mentioned, clinically how the patient's doing, how much necrosis is actually in the cavity, and also, what things look like on cross-sectional imaging.
This is a moving target, right, for so many patients, and I think those are all good points. The other thing I think that's important to take into account when you're deciding when to finish treatment and how you're going to finish treatment is the status of the pancreatic duct.
Yeah.
Right, performing a pancreaticogram to see do they have duct injury or transection, which has been shown to potentially lead to recurrence and higher chance of recurrent collections. Those collections I'm more aggressive on because they have a chance to come back, and then when you're finishing, leaving double pigtail stents indefinitely to kind of keep that tract open, potentially long-term.
Yeah, that's very important. I think anytime you have, pretty bad necrotizing pancreatitis, the likelihood of finding a pancreatic duct leak is probably relatively high. So I think if you can stent across a leak to try to prevent recurrence is very important. That is a kind of almost a controversial topic depending on who you talk to. If you look at some of the studies, some people advocate for placing a pancreatic duct stent, and others say that it's not necessary. I'm assuming that that's your practice as well to evaluate the pancreatic duct?
Yes, at our index drainage procedures, whichever drainage we're doing transmurally, we are always trying to assess the pancreatic duct if we can at that time. If we can't because there's such bad groove pancreatitis and the ampulla is not accessible, down the road when they're improving, we do try to access it at a later date or use an MRCP to try to at least get some understanding of whether there is a duct transection to decide what to do finally with our stent.
Yeah, I agree with you. I think an MRCP with secretin is actually very helpful to get an idea of what the ductal anatomy looks like, and that's something that we utilize a lot here. Yeah, so I think we're pretty much close to, I'll probably continue doing a little bit more necrosectomy, and my plan in here is, once I remove a little bit more necrosis, I'm going to flush this area with a dilutional hydrogen peroxide and then place some double pigtail stents through here. But I think we've made some significant progress. I think we're at the end of the live cases for the morning session, at least for now. I think we're going to move on to lectures next. So I want to thank everyone for joining us this morning and for all the questions that you had. It was very... thank you very much for all your questions. I mean, this is obviously a topic that, we deal with a lot here when we see as advanced endoscopists all the time. And I think the management for how you deal with these patients differs depending on what institution you're at. So it's nice to hear what everyone else is doing at their institutions as well.
Thank you, Haroon, and to you and your team, as well as to Avik and his team. I think we'll transition now after the first live session back to the next session, which is on therapeutic EUS. So thanks everyone for the morning cases, and we'll go back now to the didactics, and then we have a Q&A session to follow. Great job, guys.
SPath Pre-Mounted Biliary Stent System by Endo GI with a novel integrated RX proprietary self-detaching tip.
So, dear colleagues, we are going to speak about endoscopic palliation of gastric outlet obstruction. So, what about the way to do gastroenterostomy endoscopically? Magnets, I will not speak about it. NOTS procedure, I will speak at the end of my presentation, and EOS guided with different means. And now ESG guidelines are available. So EOS guided gastroenterostomy, you can do that directly. That could be assisted with a slim scope or with insertion of a nasobiliary catheter to fill the duodenum with saline and sometimes with methylene blue, or you can use the wireless endoscopic simplified technique, which is a West technique, or you can do EPAS, which is EOS assisted with a single balloon or double balloon. Which one to choose? ESG does not recommend any preferred choice. So I show you this video, which is a gastric outlet malignant obstruction. And you see the first time is to put a sheath through the pylorus and with the guide wire, and to push the guide wire into the angle between duodenum and jejunum after a nasobiliary tube. And after you fill the duodenum with saline and contrast, and then after, when you have a filling of it, you can do the gastroenterostomy with the EOS scope, and you see you use a hypokinetic drug. You see the LAMS device, and you push it in the lumen of the duodenum, and after you release the distal flange. After you gently pull back the distal flange, and you move to the endoscopic part, and you will release into the stomach the proximal flange, and the anastomosis is done. You can use a guide wire or not, but take care if you use the guide wire. If you push too much the guide wire, you have the risk of pushing away the small bowel. So now you see the anastomosis is done. We let in place the guide wire to be able to push over the guide wire the sheath and the catheter to control. We have no leakage and we have no misdeployment. And if you have any trouble, you can use it to do the stent-in-stent technique for rescue procedure. So you see, we push some contrast and everything is okay. In this case, we are in the domain of the duodenum. So what about the landing curve? The landing curve should be achieved after the 7th procedure in this study from Ami Tyberg in 23 patients. And you see the time of the procedure is decreased from 88 minutes to less than 1 hour. So I will not speak about afferent loop and alternatommy indications. I will speak about gastric outlet obstruction in benign indication and in malignant indication. So in ESG meta-analysis, we have 15 series, and the technical and clinical success rate were about 90% of the cases with adverse events in 7% of the cases, and ESG recommends multidisciplinary discussion and careful evaluation of patients undergoing EUS-guided gastroenterostomy. This is a strong recommendation. What about AGA? AGA clinical practice update in expert review gave the advice to perform surgical gastrojejunostomy should be considered for patients with gastric outlet obstruction and life expectancy more than 2 months who are surgically fit. So this is not the same advice than in Europe. What about now benign indication? We have more and more increasing rate for benign indication and in Crohn's disease and chronic pancreatitis. So you see in this the series on the left column, you see the benign indication for gastric cancer obstruction where 15.8% of the cases with no difference in the technical and clinical success rate. And on the right and the bottom, you see this series of 22 patients included were only with benign indication, and the LAMS was removed in 18 patients with recurrence in 5.6% of the cases, and surgery was prevented in 83% of the patients. So in my personal series with direct technique, including 35 patients, benign indication were 41% of the cases with Crohn's disease and chronic pancreatitis with similar rates, success rate again. So ESG suggests that EUS gastrostomy should be reserved for poor surgical candidates in benign refractory gastric obstruction, but we are changing more and more our attitude, and we are actually including some cases of gastroparesia after failure of GPWEM. So I show you this video, which is a case of Crohn's duodenal disease with huge disease with refractory Crohn's disease to any medical treatment. And you see we push directly the LAMS stent, the needle or the 19 gauge needle inside the lumen after we fill with saline and contrast. And you see now the lumen of the jejunum, which is filled with contrast and saline. We push the guide wire very carefully, not to push away the duodenum or the jejunum. And after we pass over the guide wire with the LAMS device, and we will release the distal flange. Okay, and now we pull back our device again until we reach the gastric wall, and after we fill the gastric lumen with air or CO2, of course, and when we see the black ring, we can release safely the proximal flange, avoiding any misdeployment in this case, and you will see the release of the proximal flange. Okay, so this direct technique should be used in case of alternotomy or in case of complete obstruction of the duodenum when you are not able to pass any guide wires through. So I show you the video 1 month later, and you see clearly the LAMS stent on the posterior face of the stomach, and you see we have a short stenosis due to the evolution of the Crohn's disease, and a lot of duodenal stenosis in this patient with ulceration due to the fact that the patient had refractory disease to any medical treatment, and after this kind of treatment the patient was accessible to feeding, and so he was cured with this treatment, despite the surgeon asked us to do that because the patient underwent previously more than 5 surgeries and had a short small bowel. So what about the overall results in this meta-analysis, 12 studies, and you see about 2/3 of gastric obstruction, about 2/3 of direct puncture technique, and you see again the technical and clinical success rate were 90% of the cases, and adverse events were 11% of the cases. So finally, what is the best management for gastric outlet obstruction? EUS guided treatment, duodenal stenting, or surgery. So first, looking to duodenal stenting, meta-analysis and systematic review, you see in this one, you see there was no difference for technical success rate and clinical success rate, but much lower rate of reintervention rate significantly, and similar adverse events. So ESG recommends that EUS gastroenterotomy as an alternative to surgery and enteral stenting. This is a strong recommendation. If you look to this international study with propensity score match comparison, you see the technical success rate was similar, the clinical success rate was better with EUS approach, and stent dysfunction was much lower than with duodenal stenting. Adverse events were similar. So in this study, clearly ESG could be preferred to over duodenal stenting in malignant gastric outlet obstruction. What about surgery? Now you see this meta-analysis. EUS had the lower technical success rate, but a better clinical success rate compared to surgery, lower overall adverse events rate, and shorter procedure time, of course. And in this meta-analysis, including only gastric outlet obstruction, the technical success rate was better with surgery, but the clinical success rate were similar, and adverse events were fewer, of course, with EUS approach, endoscopic approach, than with surgery. What about this international study with, again, propensity score match comparison? Technical success rate and clinical success rate compared to surgery was the same, but the mean delay for oral intake was lower with EUS, hospital stay was lower with EUS, and adverse events was much lower, even with severe complication compared to surgery. Okay, so EUS should be preferred to surgery. What about the type of adverse events? Adverse events, the rate is about 11%, but you see you can have severe or fatal cases, mainly due to misdeployment or dislodgement. And so you can mostly manage it endoscopically in about 90% of the cases with knots or with the stent-in-stent technique. I will show you. Patency is okay, and the only predictive factor for successful EUS-guided gastrointestinal anastomosis is the distance between the stomach and the small bowel lumen. So I will show you this video. This is a patient with previous duodenal stenting, and we perform duodenal stenting. We perform EUS-guided gastrointestinal anastomosis, but we had the misdisplacement of the distal flange between the small bowel and the stomach. So we use the guide wire to insert a stent over this guide wire, and so we use the stent-in-stent technique. And you see the CT scan 2 days later without any pleural peritoneal infusion. So this is a small bowel 1 week later, and you see the stent-in-stent technique is a very good rescue technique. So if you have any anatomical difficulty, use the guide wire for the potential rescue procedure. So I just moved to my the end of my presentation. Just about the NOTS procedure. And I show you the NOTS technique we are using for achieving endoscopic gastric bypass. This is one of the parts of the endoscopic gastric bypass, but as we measure, we are able to measure the length of the bypass limb. We need a NOTS approach to target the anastomosis. So I show you. So we pass through the gastric wall. This is with a hook knife. Actually, we are using a guide wire with a balloon to pass through the gastric wall very safely, avoiding any bleeding. Okay, you see, we use a double operating channel scope to go into the peritoneal cavity. On the left operating channel, we use a grasper. Now we have a dedicated grasper, and we catch the small bowel. On the right operating channel, we use in this case a knife with a guide wire, but now we use a direct technique without guide wire, and we will pass over the guide wire, holding the small bowel with the grasper, the rotaxios inside the lumen of the small bowel, deploying the distal flange, and we will retrieve the scope and both the device and the grasper until we reach the gastric wall. You see, we are passing into the peritoneal cavity through the mesentery. Okay, now we reach the gastric wall, and we will release on the left operating channel the grasper, and on the right operating channel scope, we will release the proximal flange, doing with it doing the gastrointestinal anastomosis. And now, maybe in another presentation, I will show you the whole procedure for endoscopic gastric bypass. We publish it, and you see clearly the mucosa of the jejunum, and it's okay for this part. So we published this technique of NOTS procedure in human beings 7 years ago in this paper in gastroenteroscopy in 2015 in 3 cases with Campbell-Muller. So it's working. So this is a CT scan 2 days later showing the axial stent between the gastric lumen and the jejunal lumen. So in conclusion, EUS gastroenterostomy is possible and efficient with EUS approach, and the main indication is gastric outlet obstruction with increasing rate of benign indication. LAMS gastroenterostomy are really challenging duodenal stenting and surgical gastroenterostomy, and this procedure requires experience and skillness and should be improved for safety. So thank you for your attention.
Good morning, everyone. It's my pleasure to be here today, and I'll be talking with you about EUS-guided biliary and gallbladder drainage. Where are we going? So starting off with EUS-guided biliary drainage, or EUS-BD. We all know that ERCP is the gold standard treatment for biliary obstruction, but anywhere from 3 to 5% of biliary obstruction cannot be managed by conventional ERCP. And this can be for a variety of reasons, including ampullary pathology or diverticuli, altered anatomy, or gastric outlet obstruction. And traditionally in these patients, percutaneous drainage has been the alternative approach. However, percutaneous drainage is associated with significant complication risks and morbidity associated with the external drain, and therefore EUS biliary drainage is an alternative therapy when conventional ERCP is unsuccessful. The concept of EUS-guided cholangiography was first described in 1996, and the first case of EUS-BD was performed by Mark Giovannini in 2001. And since then, there's been multiple studies looking at efficacy and safety of EUS-BD over the past 20 years, many of which were combined into a meta-analysis from 2016 that included over 1,000 patients and showed pretty excellent technical and clinical success rates and a relatively what seems high adverse event rate, but this meta-analysis did include studies that were when this technique was first being developed, and that adverse event rate has definitely gone down over time. There are several approaches to performing EUS-BD, including an intrahepatic approach in which the intrahepatic ducts are accessed through the stomach wall and through the liver, or an extrahepatic approach in which access is obtained through the duodenum into the extrahepatic biliary tree. And comparative studies between the various techniques have not demonstrated any major differences in terms of efficacy or safety. This is a meta-analysis from 2018 looking at the two techniques and showing really no difference in technical and clinical success as well as adverse event rates. However, several smaller, newer studies have recently come out suggesting that choledochoduodenostomy may be associated with longer stent patency, but also might show some higher adverse event rates. But no matter the approach, the procedural steps and technique is grossly the same. The first step is to visualize the biliary tree on endoscopic ultrasound, and then access the biliary tree and obtain a cholangiogram by injection of contrast. I put here the next step, obtain wire access, in asterisks because sometimes this step is not needed. In the era now of lumen-opposing metal stents with cautery, sometimes the duct can be accessed directly without a wire ahead, but in cases of hepatogastrostomy, generally wire access is the next step, after which the creation of a fistula tract is performed either using cautery or a balloon dilation or both, and ultimately deployment of a decompressing stent from the biliary tree into the GI lumen. What's really exciting is that now this procedure has become so well accepted that there have been several studies looking at performing EUSBD first line instead of even trying conventional ERCP in patients with malignant biliary obstruction. And you're going to hear more about the data a little bit later this morning, so I'll just briefly summarize. These studies included over 200 patients and basically showed equal efficacy and safety between the groups, and one study actually showed a lower adverse event rate and reintervention rate in the EUS-BG group, primarily due to the avoidance of post-ERCP pancreatitis. Additionally, there are two comparative meta-analyses also looking at EUSBD in comparison to conventional ERCP in malignant biliary obstruction, and again, both showed equal technical and clinical success between the two groups, and in one study, less adverse events in the EUS-guided BD group. This is an example of what this technique looks like. Here we're showing the intrahepatic approach. You can see that the intrahepatic bile ducts are being accessed from the stomach through the liver. Here a cholangiogram is being obtained with contrast injection. You can see markedly dilated intrahepatic ducts with a very tight distal stricture and actually no filling of the extrahepatic biliary tree or the small bowel. The next step is to obtain wire access. Here you can see the wire being advanced through the FNA needle down into the extrahepatic biliary tree. It's always ideal to cross the ampulla or the anastomosis depending on the patient's anatomy. So in this case, a balloon catheter is being used to give a little extra leverage to the wire, at which point the wire is then able to be successfully redirected across the ampulla, and here you can see it now in the small bowel lumen. The next step is to dilate both the stricture itself as well as the fistulous tract, and that is to facilitate deployment of the stent, which is going to be deployed in a top-down fashion. So here you can see the stent being advanced from the intrahepatic ducts down across the stricture and into the small bowel lumen, so that it will be deployed with the distal end in the small bowel lumen, the middle of the stent across the stricture, and then the top of the stent will be just below the hilum. And then the original puncture site can be closed just with a regular hemoclip. And these are just some examples of what this procedure can look like. A question that is frequently raised is, what about the learning curve for EUSBD? And there have been a couple of studies looking at the learning curve using a variety of statistical techniques, and I'll show pretty similar number of cases that are required to reach efficiency, somewhere between 30 and 40 cases. Another question that frequently comes up when we're talking about EUSBD is, what about patients that may be surgical candidates? There are some cases of malignant biliary obstruction where endoscopic biliary drainage can serve as a bridge to surgical resection of the inciting malignancy, and the surgical outcomes of patients with malignant biliary obstruction who undergo EUSBD prior to surgery has not been well examined. So in order to attempt to provide some guidance and answer this question, this is a study that was just recently presented at this past DDW. It was a multi-center international study of consecutive patients who underwent hepatobiliary surgery after having undergone EUS, biliary drainage, or conventional ERCP, and it included 145 patients, 58 who had undergone EUSBD, 87 who had undergone conventional ERCP. And what we found was that in the EUSBD group, there were fewer repeat endoscopic interventions prior to ultimate surgical resection. There was a shorter duration between endoscopic drainage and surgical intervention. There was a higher surgical, technical, and clinical success rate in the EUSBD group, a shorter length of hospital stay after surgery, and no difference in endoscopic or surgical adverse events. And interestingly, it was also asked whether there was increased surgical complexity in the EUS BD and ERCP groups compared to standard surgical technique, and there was no difference between the two groups. So the conclusion from this was that EUS BD appears non-inferior and maybe even superior to conventional ERCP for malignant biliary obstruction prior to hepatobiliary surgery, and that EUS BD should not impede patients from undergoing surgical intervention, and surgical candidacy should not impede patients from undergoing EUS BD. And these are just some other examples of the ways in which therapeutic EUS can be used to successfully obtain biliary decompression. Here's combining different therapeutic EUS techniques, EUS GJ with ERCP. And I think we're going to see more and more of this type of innovation as the field of therapeutic EUS just continues to grow. I'm going to switch gears a little bit now and spend the next half of the lecture talking about EUS-guided gallbladder drainage, which is, I think, perhaps my favorite of all the therapeutic EUS procedures. We all know that surgical cholecystectomy is the gold standard treatment for cholecystitis, and that patients who are not surgical candidates have traditionally undergone percutaneous drainage. But similar to EUS-BD, this is plagued by high complication rates and morbidity due to having an external drain, and therefore EUS gallbladder drainage has become an alternative option for patients with cholecystitis who are not surgical candidates. I think gallbladder drainage is probably the most well-studied of the therapeutic EUS procedures after pancreatic fluid collection drainage, and there's been numerous publications over the years. This is a meta-analysis from 2016 looking at the 6 largest EUS-guided gallbladder series, and their analysis showed pretty excellent technical and clinical success rates and a low adverse event rate. What about when directly compared with percutaneous drainage? This is a retrospective multicenter study encompassing 155 patients from 7 international centers, and what it showed was equal clinical and technical success and no difference in adverse event rates, but fewer repeat interventions in the EUS gallbladder group. What's really exciting now is that we have a randomized trial comparing endoscopic and percutaneous drainage. This is a study from Anthony Teo's group where non-surgical patients with acute cholecystitis were randomized 1-to-1 to undergo either EUS guided gallbladder drainage or percutaneous drainage. This study included 80 patients, and what they found was that the EUS gallbladder drainage group was superior on multiple outcome measures, including adverse events at 1 year and 30 days, recurrent cholecystitis, reintervention after 30 days, as well as unplanned admissions. And so the take home here is that it only remains to be determined if there are enough therapeutic echoendoscopists to take over drainage of all the non-surgical cholecystic gallbladders. And this is what the procedure looks like. Here you can see a nice distended gallbladder on EUS visualization. In this case, a lumen-opposing metal stent with cautery is being deployed directly into the gallbladder lumen. You can see it nicely in the lumen on endoscopic ultrasound. The distal flange is then going to be deployed in the gallbladder lumen, and then that stent is going to be pulled back and acted as a retractor to oppose the gallbladder lumen and the stomach wall, as you can see happening here, and then the proximal flange is going to be deployed in the GI lumen. And if you look at the bottom left of the screen, you can see the proximal flange being deployed right in the stomach, and it's always very satisfying when you get a nice big gush of bile or even sometimes purulent material, and sometimes that gush can be quite impressive. These are some of my favorite pictures, and I'm sorry for anybody who is having breakfast during this talk. Another question that frequently comes up similar to EUSBD is, what about patients that may need to go for surgery? Can they do that after undergoing EUS gallbladder drainage? Because in some cases, non-surgical patients can improve and become surgical candidates after their initial gallbladder drainage. And data on the surgical outcomes of these patients who undergo EUS gallbladder drainage prior to surgery is limited. This is a study of 34 patients retrospectively looked at who had undergone either EUS gallbladder drainage or percutaneous drainage, and then ultimately went on to have a cholecystectomy. And what review showed was that there was really no difference between the rates of open versus laparoscopic cholecystectomy in the two groups, and no difference in post-surgical adverse event rates. This is another abstract that was just presented at this past DDW, again attempting to provide some guidance and answers to this question. This was a multi-center international study of patients with acute cholecystitis that underwent EUS gallbladder or percutaneous drainage followed by elective or semi-elective cholecystectomy. It included 139 patients, 46 who underwent EUS gallbladder drainage and 93 who underwent percutaneous drainage. And what we found is that in looking initially at the initial procedure outcomes, there was no difference in technical success and procedural adverse events between the two groups. The EUS gallbladder group had a shorter time to resolution of symptoms, a shorter length of stay, as well as less hospital readmissions. And then looking at surgical procedural outcomes, there was no difference in technical success and surgical adverse event rates. There was no difference in the rate of lap to open cholecystectomy conversion. The EUS gallbladder group had a shorter interval between gallbladder drainage and surgical cholecystectomy. The EUS gallbladder group also had, interestingly, a shorter operative time and a shorter length of stay after surgery. So the take home here is that surgical cholecystectomy after EUS gallbladder drainage seems safe and feasible. And if patients' underlying medical conditions improve, prior EUS gallbladder drainage should not preclude cholecystectomy. And similarly, if patients with potentially resectable, who are potentially resectable in the future, that should not preclude them from undergoing EUS gallbladder drainage. So in summary, ERCP remains a standard of care approach for biliary decompression, but it's not feasible in all patients, and there is the risk of post-ERCP pancreatitis. EUSBD is already an established alternative to ERCP, and given the emerging literature, may even become the preferential treatment for malignant biliary obstruction going forward, even in surgically resectable patients. But the choice of technique of EUSBD is dependent on several factors, including accessibility to the duodenum and whether the obstruction is intrahepatic or extrahepatic. Cholecystectomy is the gold standard of care for acute cholecystitis, but not all patients are surgical candidates. And for those that are not, EUS gallbladder drainage is a safe and efficacious alternative to percutaneous drainage, even in patients who may become surgical candidates down the road. And now this procedure is even proven superior to percutaneous drainage in a randomized controlled trial. And I will leave you again with the statement that it only remains to be determined if there are enough therapeutic echoendoscopists to take over drainage of all the non-surgical cholecystic gallbladder. And I will stop there. Thank you so much for your time.
Good morning, everyone. My name is Haroon Shahid. I'm one of the advanced endoscopists at Rutgers Robert Wood Johnson Medical School. I wanted to welcome everyone to MAGIC 2020. Today I'll be discussing the modern management of pancreatic fluid collections, which is one of the most common conditions advanced endoscopists deal with. I don't have any disclosures. Just quick introduction, pancreatic fluid collections occur as a complication of acute pancreatitis due to trauma, malignancy, and postoperatively after pancreatic surgery. Acute pancreatitis is the most common GI discharge diagnosis in the United States and is one of the most common causes of forming pancreatic fluid collections. When we talk about pancreatic fluid collections, it's important to understand the different types of pancreatic fluid collections that exist. And we base this off of the revised Atlantic classification. When someone develops acute pancreatitis, they can have interstitial edematous pancreatitis or necrotizing pancreatitis. And if a fluid collection forms within 4 weeks with someone who has interstitial pancreatitis, they form an acute peripancreatic fluid collection, which is not well walled off. And usually at about the 4-week mark, that fluid collection will wall off and form what's called a pseudocyst. In patients that have necrotizing pancreatitis, when they form a fluid collection that includes necrotic debris, when it happens within less than 4 weeks, that's called an acute necrotic collection. And then after it reaches over 4 weeks, or when it becomes mature and forms a wall, that's called walled off necrosis. These are just some images, some CT scans showing what these collections can look like. The top scan is showing what interstitial edematous pancreatitis looks like. You can see a lot of fluid and inflammatory changes around the pancreas. And the bottom CT scan here shows what's called a pseudocyst. You can see now this fluid collection has walled off. It's near the tail of the pancreas, and it's something that potentially could be drained if the patient was symptomatic. In terms of pancreatic necrosis, the top scan on the left here shows the pancreas here in the middle. Normally the pancreas should enhance the same as the liver. So you can see the tail of the pancreas here and the liver enhance about the same. But when you look at the top portion of the pancreas here in the body, neck region, you can see that it's darker than the rest. That's an area of necrosis. When this forms a fluid collection, usually at about the 4-week mark, and contains debris within it, that's called walled off necrosis. Usually it's an abnormal large collection that sometimes on CT scan or MRI you can actually see the debris within. Other times you may not know that there's actually debris within this collection until after it is drained. So how do we manage these collections? So some fluid collections, like acute pancreatic fluid collections and pseudocysts, may resolve on their own. So no intervention is needed in those situations. But if the patient is symptomatic, then they require drainage. And when we say symptomatic, if they're having continued abdominal pain, they develop biliary obstruction, they have evidence of nausea, vomiting, early satiety, or even gastric outlet obstruction, or there's a concern that the collection is infected. Those are all reasons to move forward with potential drainage, depending on the patient and their clinical status. So drainage can occur multiple different ways, and this has evolved over time. This can be done surgically, it can be done percutaneously, and it can be done endoscopically. Endoscopic drainage has become the mainstay of therapy nowadays at most tertiary care centers. At those centers where they don't have the expertise of advanced endoscopy, percutaneous drainage is the second most common drainage form. And then in those cases where that's not successful, surgical drainage is also possible. So a lot has changed in terms of endoscopic drainage. When this initially was thought of, the way that a pseudocyst or walled off necrosis cavity was first visualized endoscopically was via a bulge in the stomach. So this is prior to the advent of endoscopic ultrasound or the widespread use of endoscopic ultrasound. This would require puncturing into the presumed collection, usually with a needle knife, passing a wire, dilating that tract with a balloon dilator, usually a biliary balloon dilator, and then placing plastic stents to allow internal drainage. This was also done with fluoroscopic guidance. As endoscopic ultrasound became available, this was then the most common form of draining pseudocysts and walled off necrosis. In this situation, the collection is first targeted by endoscopic ultrasound. A sample then can be obtained by an FNA needle, a wire can be passed, and the same process is done again. The tract is dilated. So usually the fistula needs to be created with a needle knife or a cystotome, and then plastic stents were placed. As we moved on, the off-label use of fully covered biliary stents became more prevalent. This would be done the same way via EUS guidance. It was a larger drainage catheter. Usually a biliary fully covered metal stent is about 10 millimeters, 8 to 10 millimeters in diameter, much better than 7 French or 10 French plastic stents, which could allow better drainage and quicker resolution to those collections. And in the last picture here, we moved to using lumen-opposing metal stents. These are biflanged stents that prevent migration and are available in a variety of sizes. Here's an example of using that lumen-opposing metal stent delivery system to drain a fluid collection. This is a patient that has an infected pseudocyst, and what's being used here is a cautery-enhanced lumen-opposing metal stent delivery system. This allows the procedure to be done freehand. There's no need to perform an FNA and place a wire. This potentially can be done without fluoroscopy. So you're going to see this is the pancreatic fluid collection here, the pseudocyst. You're punctured freehand with the cautery-enhanced LAMS delivery system. The tip has cautery and allows the passage of the stent, so there's no need for multiple instrument exchanges. The internal flange is deployed there and then pulled up to the gastric wall, and then the internal flange or the gastric side is then deployed endoscopically, and you can see there's a drainage of purulent material from this collection. This is a very quick procedure, and with these large fluid collections can be performed in just a few minutes. The fact that you don't need multiple instrument exchanges makes this procedure much quicker than it had been in the past. So, what do the studies show us? This is a study that looked at comparing fully covered self-expanding metal stents versus lumen-opposing metal stents versus plastic stents for the endoscopic drainage of pancreatic walled-off necrosis. It was a multi-center retrospective cohort study. 313 patients underwent endoscopic drainage of walled-off necrosis. 106 patients were in the double pigtail stent group, 121 in the fully covered self-expanding metal stent group. Those are those fully covered biliary stents. And then 86 were in the lumen-opposing metal stent group. There was no difference in the technical success rate. There was a higher rate of resolution at 6 months in the fully covered self-expanding metal stent group and the LAMS group when compared to just the double pigtail group. It was 95 and 90% rate of resolution in those two groups versus 81% in the double pigtail group. There were a lower number of procedures necessary to resolution in the LAMS group as well, 2.2 procedures versus 3 in the fully covered self-expanding metal stent group and 3.6 procedures in the double pigtail group. So that study showed that using metal stents may be beneficial when compared to using double pigtail stents in terms of resolution, time to resolution, and the number of endoscopic procedures necessary. These lumen-opposing metal stents, again, are these biflanged, dumbbell-shaped stents that have pretty much changed advanced endoscopy and how we perform pancreatic fluid collection drainage, and specifically when dealing with walled-off necrosis. What this allows us to do is also enter the cavity and perform endoscopic necrosectomy in a much easier fashion than it had been previously. This biflange design helps prevent migration as well. These stents are available in multiple sizes now, a 10 millimeter, 15 millimeter, 20 millimeter diameter in the United States. The length of the majority of these stents is 10 millimeter. There are stents that have a length of 15 millimeters now. There are some smaller lumen-opposing metal stents that are 6 millimeters and 8 millimeters in diameter. but those are not oftentimes used for walled-off necrosis. They could potentially be used for pseudocysts that are which is an all-fluid collection. So the current dogma is that endoscopic drainage with necrosectomy or debridement is better than open surgical necrosectomy, and there are benefits in terms of morbidity and mortality. We're going to look at a few studies comparing endoscopy and IR versus surgery. This is a study that looked at interventional radiology percutaneous drainage of symptomatic pancreatic pseudocysts versus endoscopic drainage. There were 81 patients. It was a retrospective cohort study. There was equal technical success and adverse events in both groups. The patients in the endoscopic drainage group, though, had decreased reintervention rate, a shorter hospital stay, and decreased number of follow-up abdominal imaging studies to follow these pseudocysts. In terms of surgery versus endoscopy, this is a study from 2013 that showed there was equal efficacy of endoscopic and surgical cystgastrostomy for pancreatic pseudocyst drainage. This was a single-center, open-label, randomized trial. 20 patients were in each group. There was no difference in pseudocyst recurrence at 24 months, no difference in complications, and no difference in reinterventions between the surgical and endoscopic group. The hospital length of stay was lower in the endoscopy group, 2 days versus 6 days, which was statistically significant. And the mean cost was lower in the endoscopy group as well, a little over $7,000 versus a little over $15,000, more than a two-time difference in the cost of the endoscopic, the surgical drainage. This is a landmark study out of the Lancet. It looked at endoscopic or surgical step-up approach for infected necrotizing pancreatitis. It was a multi-center randomized trial. 98 patients were enrolled. What they found was there was no difference in patients that underwent endoscopic drainage versus those who had a surgical step-up approach, which involved placing percutaneous drains initially and then moving on to a surgical necrosectomy for those patients. What they did find was there was a higher rate of pancreatic fistulas in the surgical group, which makes sense. There was a longer hospital stay in the surgical group as well. What's interesting in this study is that this was done earlier on. The lumen-opposing metal stents had come onto the market, but in this study, these larger diameter lumen-opposing metal stents were not used. The question comes up, when can we drain these collections? And normally the dogma has been, wait until about 4 weeks until the pseudocyst or walled-off necrosis has walled off. This was a study looking at early, which is less than 4 weeks, versus standard greater than 4 weeks endoscopic step-up intervention for necrotizing pancreatitis. It was a retrospective study which compared transluminal drainage plus minus necrosectomy plus minus perc drain. Surgery was only used in terms of in patients that failed this approach. 193 patients were included, 76 in the early intervention group, 117 in the standard intervention group. And what they found was that early intervention almost always was done due to infection. Early intervention was associated with acute kidney injury, respiratory failure, and shock, which were all statistically significant. There was a difference in mortality, 13% in the early intervention group versus 4% in the standard intervention group. Rescue surgical necrosectomy or surgical necrosectomy was necessary in 7% in the early intervention group versus 1% in the standard group. And there was a longer median hospital stay, 37 days versus 26 days. It's important to understand that this study, for those that underwent earlier intervention, those patients most likely were sicker, but the study did show that early necrosectomy is feasible and may be needed in those patients that are sicker, with the understanding that they're at a higher risk for developing complications and most likely will have a longer hospital stay and may potentially require surgical necrosectomy as well. So direct endoscopic necrosectomy, this is a video showing this process. This is this endoscope in the walled-off necrosis cavity. A lot of this necrosis is very mud-like. It's difficult to grasp. So this is a long, arduous process and procedure. It can take a very long time, usually spend at least an hour doing this, if not longer, during these endoscopic necrosectomy sessions. Oftentimes, multiple sessions are needed. The instruments used are those instruments we have available for other things like foreign body removal using snares and retrieval nets. forceps, and biliary baskets. What can be done, so the question is, what can be done to decrease the time and number of sessions necessary? The video here is again showing what this necrosis looks like, and a retrieval net is being used to try to grasp some of this tissue and then pull it out into the GI tract and release it there. So what else can we do to aid in necrosectomy or aid in resolution of these walled-off necrosis cavities? First, we'll talk about proton pump inhibitors. There's a thought that the gastric acid may help with chemical debridement of walled-off necrosis. There was a 2019 study by Powers, which was a multi-center retrospective study that enrolled 272 patients who underwent walled-off necrosis drainage with lumen-opposing metal stents. What they found was there was no difference in technical or clinical success in the group that was on PPI versus those that were not on PPI. There was a lower number of procedures necessary in patients that were not on PPI, 3.2 versus 4.6 endoscopic necrosectomy sessions. And those that were not on the PPI had a lower stent occlusion rate, 9.5% versus 20.1%. This shows that if the patient does not need to be on a PPI, it may be beneficial to keep them off of a PPI while they have a cisgastrostomy stent in for walled-off necrosis. What about hydrogen peroxide? So hydrogen peroxide interacts with organic tissue and can help break down necrosis. Hydrogen peroxide is broken down into oxygen and water by catalase, and it's usually diluted in a 1:5 or 1:10 solution, usually mixed with normal saline. In a 2019 study by Masalam et al., looking at hydrogen peroxide, 204 patients were included, and they found that a higher clinical success in those that underwent hydrogen peroxide lavage versus standard endoscopic necrosectomy, 93.8% versus 78.9%. There was earlier resolution of the walled-off necrosis cavity, and there were similar complications between the groups: post-procedure bleeding, perforation, and infection. There's always been this thought that using hydrogen peroxide can potentially lead to a gas embolism, which has been shown when using full strength hydrogen peroxide. This is one of the reasons that diluted strength hydrogen peroxide is used. What about nasocystic drains? The studies looking at nasocystic drains occurred really prior to these larger caliber lumen-opposing metal stents. These are basically drains that are placed transnasally and then via endoscopy into the walled-off necrosis cavity, and then a continuous lavage with normal saline is allowed to occur. Siddiqui et al. In 2013 showed in a retrospective study that the risk of stent occlusion was higher in those without nasocystic drains, 33% versus 13%, and the complete resolution of the collection was higher with patients that had a nasocystic drain, 79% versus 58%. As I mentioned, this study was done prior to the widespread use of fully covered self-expanding metal stents and lumen-opposing metal stents. In all these patients, they had plastic stents placed. There aren't any recent studies looking at the use of nasocystic drains in combination with lumen-imposing metal stents, but it's something that should be looked into in the future. So what about collections that go into the paracolic gutter? So you can perform percutaneous drainage and even percutaneous necrosectomy. The 2019 AGA Clinical Update on Management of Pancreatic Necrosis states that percutaneous drainage should be strongly considered as an adjunct to endoscopic drainage for walled-off necrosis with deep extension of the paracolic gutters and pelvis, or for salvage therapy after endoscopic or surgical debridement with residual necrosis burden. In these situations, at least at our facility, we will work with our IR colleagues to place a percutaneous drain into a collection that is not accessible endoscopically. That drain is then able to be removed over a wire, and a fully covered esophageal stent is then placed into the walled-off necrosis cavity percutaneously, and then an endoscope can be advanced to the percutaneous stent, and percutaneous necrosectomy can then be performed using the same instruments we would use for endoscopic necrosectomy. This we take from our surgical colleagues who do video-assisted retroperitoneal debridement, or VARD, where a percutaneous drain is placed into a necrotic cavity, and then the surgeons use laparoscopic instruments to basically perform surgical necrosectomy, which is a less invasive form of surgical necrosectomy when compared to open surgical necrosectomy. There's a new device that's on the market. I'm going to let this play while I discuss it. It's something called EndoRotor. It's a novel automated mechanical endoscopic resection tool. There's a fixed outer cannula with a hollow inner cannula that rotates over 1,000 rotations per minute. There's an opening in both cannulas that allows suction to pull tissue or necrosis within the device. And then the rotating inner cannula, again moving over 1,000 rotations per minute, is able to cut this tissue, and the suction that's applied allows the tissue to be collected and then discarded. This is very similar to a surgical morcellator, which is used in fibroid surgery sometimes. And this device, as you can see, is suctioning and basically cutting off small pieces of this necrosis, and is able to do it in a quick manner. The device itself in this video is a smaller initial device that was first introduced. We'll discuss the larger device that's available nowadays as well. This is the study looking at the safety and efficacy of this EndoRotor device. It was a single-arm prospective multi-center international device trial. The walled-off necrosis was greater than 6 centimeters in size with at least 30% necrosis. There were 30 patients included in this initial study, and they found that 50% were able to achieve complete debridement in one session, 67% achieved complete debridement in 2 sessions, and there were no device-related adverse events. What's new about this device is that a larger caliber device is now available called the Necromax, which is a larger diameter, allows better suction, allows better cutting of larger areas of tissue. The smaller device needed a therapeutic endoscope to use. The larger device would require the older, very large clotbuster type scope, which is not always available. There is an outer sheath that goes on an endoscope where this device is passed alongside the scope through the sheath, and necrosectomy is then performed using this. What about patients that have a disconnected pancreatic duct or pancreatic duct leak? So disruption of the pancreatic duct results in a pancreatic duct leak, and the most common causes are due to necrotizing pancreatitis, trauma, or postoperative complications. This can lead to recurrent pancreatic fluid collections. MRI with secretin can be helpful to delineate the pancreatic duct and determine if there's evidence of a leak or evidence of a disruption. The image on the right-hand side is a pancreatogram showing a disruption with a fluid collection and upstream dilated pancreatic duct. So how do you manage a disconnected pancreatic duct? The definitive management is surgical resection of the disconnected segment. This is a surgery that carries very high morbidity. For the fluid collection itself, transmural drainage can be performed, and then ERP and transpapillary stenting of the pancreatic duct can also be performed. What this does is it alters the pressure gradient. It sometimes even allows complete bridging across the area of the fluid collection in a partially disrupted duct. You can also consider permanent transmural stenting of a fluid collection to create a permanent fistula between the collection and the GI tract, which can decrease the risk of recurrent fluid collection. Obviously, that would mean that there would be a foreign body that would permanently be in the patient. Pancreatic duct stenting is controversial in these situations. I think most advanced endoscopists agree if there is a partial disconnection or if there's evidence of pancreatic leak, but the duct itself is not transected, placing a pancreatic duct stent may help in decreasing the recurrence of pancreatic fluid collections. In those patients that have a true disrupted duct, where it's difficult to access the upstream duct in the tail, views vary a bit. Some would agree with transmural drainage and pancreatic stenting with an attempt in the future to try to bridge that disruption, and others would suggest that these patients, once they're better, should go for surgical resection. So in conclusion, a pancreatic fluid collection should only be drained if the patient is symptomatic. The management of pancreatic fluid collections has evolved and is now mostly managed endoscopically, which has shown there's fewer adverse events, it's more cost effective, and leads to shorter hospital length of stay. There's no set algorithm for how pancreatic fluid collections, especially walled-off necrosis, should be managed. As I discussed, there's a lot of ways to perform drainage and then perform necrosectomy. It really depends on the size of the collection, location of the collection, the consistency of the necrosis within the collection as well. And the tools and technology available continue to grow and helped us perform endoscopic necrosectomy in a safer and easier fashion. Thank you very much for your time.
All right, good morning, everyone. I want to thank our speakers this morning, Dr. Kal Patel, Ken Chang, Prashant Kadia, Mark Barté, Amy Tyberg, and Haroon Shahid. It's really some phenomenal presentations that were this morning. I would remind all of our viewers that please feel free to utilize the chat box for Q&A. We're happy to answer any questions that you may have. Prashant and I will co-moderate this Q&A session until we start the next live cases. So we're really, really happy that we have an outstanding panel here. Some of the experts in the field. I'll start, Ken, with you first. You've been one of the pioneers with endohepatology and portal pressure measurements. I'm just curious, what do you say to hepatologists that may be a little bit more skeptical about endohepatology and us using endoscopic ultrasound to assess portal pressure measurements? What's sort of your elevator pitch with them about why they should convert from probably a more standard IR approach?
I think one of the compelling reasons to consider endohepatology is the fact that we can do really a one-stop shop for the liver So endoscopy, for varices, portal hypertensive gastropathy, US imaging, looking for lesions in the liver, ascites, and then shear wave elastography, which has really been super helpful in us getting a sense of the amount of stiffness and fibrosis. We can also do shear wave of the spleen, which may be even more accurate than shear wave of the liver. And then when indicated and needed liver biopsy, we're really perfecting the liver biopsy so that we can get incredible number of portal tracts, high quality, and that's become the preferred from our liver pathologist. And portal pressure measurement is very easily performed when indicated. So we're not telling the hepatologist when to do it, but if they need it, we can do it all in one or, any of the above. So I think we're seeing more and more hepatologists kind of understand and embrace this, but they're a tough crowd.
Dr. Chang, those are all really good points. We've had a little bit of challenge, in our center trying to get the upswing and buy-in from our hepatologists. One of the reasons that I've heard is that, when they want a liver biopsy, they want it in the next 48 to 72 hours or whatnot. And sometimes coordinating an EUS schedule and a busy practice, getting that patient on schedule can be a challenge. And so I wonder whether some of it is logistical as well, because I agree with you. A lot of the technical aspects of EUS and hepatology seem superior, and the one-stop shop, getting it all done is great. But are we ready to take on the volume in a time-efficient management for the hepatologist to make them buy into it? And that's part of the program as well, which I feel.
No, totally agree. And sometimes IR is backed up, and they're busy with other things, and they would rather not do. They really don't like to do diagnostic HVPG and even liver biopsy. They sometimes when they're busy, they can't get to it as well. So yeah, it's access, right? So all of our endosonographers do endohepatology, so the access is pretty reasonable.
Great points. Dr. Borte, I want to ask you, with respect to EUS-guided gastrojejunostomy, do you have a preferred technique that you use, direct access puncture, or do you use any ancillary devices? Are you using glucagon to reduce, motility? What's your preferred access technique in terms of EUS-guided GJs?
So just first I have to apologize because we have in my hospital a complete data processing rupture and also web disconnection. So I'm working with my cell phone, my own cell phone and my personal computer. So I cannot hear very well your question. I hear your question is about the preferred way to perform EUS gastroenterostomy. So first I use only the direct technique, but as I told you in my presentation, we have different direct technique. The first one is one I show you with the needle and injecting through the way of the needle contrast and saline inside of the lumen of the jejunum. The second one is I think this is the best one and the safer one, using a nasobiliary catheter. So you push, for adult gastric obstruction, you push your guide wire inside the jejunum, and after you push over the guide wire, the nasobiliary catheter, and after you connect your nasobiliary catheter with a pump, and you inject contrast and saline through the nasobiliary catheter inside the lumen of the jejunum. And so you fill completely the lumen of the jejunum. And after you use a hypokinetic drug, I use the glucagon and use usually 3 milligrams of intravenously of glucagon. And after you can perform directly the EUS-guided gastroenterostomy. And I don't use a guide wire, because if you use a guide wire, first, you push away the small bowel and you have a long distance between the stomach and the small bowel. So you do the direct technique inside, as I show you with the video, inside the lumen of the jejunum. And after, when you are inside the lumen of the jejunum, you can push the guide wire.
the same than you. So this means you preload the guide wire, the same than for choledochoduostomy, for instance. And so this is a safe technique because you are not pushing away the small bowel with the guide wire. And after you release your distal flange, you go close to the stomach and you can release the proximal flange. I think this is the most reliable technique and I think the safer technique.
Fantastic. There's a question from the audience here. I think it's for Haroon. I'm not sure if he's on the chat here, but it is, can endosponge play any role to drain and collapse a Waffen after initial necrosectomy? An interesting question. I don't know if anybody on the panel has thoughts on this. I guess I'll start since Haroon is not here. So you know, endosponge is a newer technology used to debride and resolve fistula tracts or perforations from the GI tract that can be accessed at least, and it's been shown to be very successful in recalcitrant leaks and fistulas that are not able to be treated conventionally with closure. Its role in wall-up necrosis, from what I know, has not been studied in any type of significant fashion. I wonder, you know, whether it would be necessary though, because generally an endosponge, if you place it in there, you're not going to allow for so much debridement, right? You want that tract to be open to allow for necrosis to efflux through your stent. And then once that collection has been debrided, like Haroon did today, generally you'll be able to predict how that collection is going to behave based on the pancreatic duct status. So if you have an intact pancreatic duct, the chance of that collection recurring is going to be kind of low. And if it's not going to be intact and you have a transected duct, the recurrence rate may be higher. And in those cases, leaving a cutaneous double pigtail catheter usually will kind of prevent recurrence of collection. So I don't think you would be able to leave something like this in too long or in between cases. The question is, you know, in between cases, would it help with pull things out? But I'm not sure if it's going to block the outflow of that tract. Any other thoughts from the panel? This interesting question.
Yeah, I agree, Prashant. I think, you know, the debridement is, you know, or the ongoing necrosis is what's going to prevent closure of your cavity. And so I think the focus remains on debridement. I think most of these, as you know, pointed out, without duct leak, once it's fully cleaned, they close pretty nicely or diminish. So it's an interesting idea, but I agree. I'm not sure it's, I'm not sure what the utility is yet.
Great. Another question from Dr. Largy for Amy. I'm not sure if she's on the chat. Which new indications for endoscopic gallbladder treatment are you envisioning in the future?
I'm not sure if Amy is on the chat. I think she might be setting up for a case. So we'll pose that question to our esteemed panel. What new indications for endoscopic gallbladder drainage are you envisioning for the future?
I don't know if there's too many indications outside of acute or chronic cholecystitis that we would be using it for, but there have been some early studies using gallbladder drainage to palliate malignant outlet obstruction in which the bile duct is difficult to access. And so there have been studies showing that draining the gallbladder in that setting, which may be more easily accessible than, say, an intrahepatic bile duct, may allow for biliary drainage palliatively in those scenarios. And so that could be something that could be a new indication. But yeah, I don't know if there's any other interesting thoughts on the panel for that.
I think one area is just like percutaneous, I think the endoscopic drainage can be limited by recurrence once you remove the stent in our case. And so there are, I think, very early stages of looking at gallbladder ablative therapy to try to I don't know, denature or even, diminish the size or so on. So maybe some combination therapy to prevent recurrence is one area this can go in.
Yeah, and I think a key point about using the gallbladder to decompress the biliary tree in the setting of biliary obstruction is that you must have a patent cystic duct. If you have malignant invasion of the cystic duct, your gallbladder is not going to be dilated enough, and it's not going to be, even if you put a stent into the gallbladder, you're not going to be able to really decompress the more proximal biliary tree if that cystic duct is taken. Question for you, Carl. So there's a lot of new innovations that you mentioned. I think one of the biggest disruptors in society and certainly in healthcare and now coming into GI is the advent of artificial intelligence and how that's going to be able to help us. What can you forecast over the next few years of this disruptive technology? You spoke about some of the cysts, and there have been an explosion of papers over the last 5 years in AI. Do you think we'll be able to have a more standard application for AI to help us identify suspect lesions, sampling? What are your thoughts sort of from a global view with AI and EUS?
Yeah, thanks for the question. And it's interesting. We've struggled with other sort of adjunct diagnostics and widespread acceptance, right, in our field, whether it's endomicroscopy, OCT, et cetera. But AI is different, right, because there's sort of a popular acceptance of it, and it's oddly it's more relatable probably than some of the things we've come up with in the past. So I actually do think there'll be more lasting acceptance. And, I think the role of it is taking the subjectivity out of endoscopy and making it more reproducible. And that, I think, has always been our challenge for especially imaging-based diagnosis. So I think, adding, whether it's automated interpretation, read, et cetera, just like in the Mayo paper I showed, giving you a probability of diagnosis combined with your something that you can report to the, at the end of the day, most of these, the end user is not us. We're not offering the treatment or doing the surgery or so on. So I think having a widely validated, tested, system for cysts, cancer, whatever, I actually think this is more promising than some of the other approaches we've had in endoscopy.
Yeah, I agree, Kyle. I think a lot of these red flag imaging technologies, we need to reduce human error and increase reproducibility, and that's what AI gives us the opportunity to do in the future. But I think that we're going to close off the Q&A here and jump into some of the live cases. And I think we're going to start with Dr. Tyberg's room here. Thank you all for your involvement in awesome lectures and being on the panel here. I appreciate it.
Thank you. Well done.
All right. Thanks, guys. Take care.
So the next case that we have here, this is a 63-year-old woman, initially seen in our clinic for evaluation of right upper quadrant abdominal pain and a dilated duct. On ultrasound, showed to have a dilated duct up to 9 millimeters with some intrahepatic dilation measuring up to 4. This was followed up with a CT scan of the abdomen and pelvis not too long after that showed that she did have that biliary dilation up to 11 millimeters and at the level of the porta patis. But then it ended up tapering down to around 4 millimeters down at the area of the pancreatic head. And the PD also measured up to 3 millimeters. This was followed up by endoscopic intervention, ended up having an EUS not too long after that showed that she did have an hypoechoic oval-shaped mass, roughly around 20 millimeters in the periampullary region. This was biopsied, and it did confirm adenocarcinoma. Of note, she was recently seen and noted to have significantly worsening liver enzymes and also CT concerning for worsening obstruction. So today we're planning on doing the ERCP with a hepatogastrostomy. This here is the EUS image just showing kind of that 20 millimeter lesion which I had previously discussed. Biopsies did confirm of that area, the mass lesion, and then also took some biopsies of the ulcerated parts that did confirm adenocarcinoma. And then as you can see her LFTs here, about 3 weeks prior, AST-LT were normal, bumped up to 4 and 600s respectively with a significant increase in her alk phos.
Hi, can everyone hear me? Okay, perfect.
We can hear you, Harun.
Perfect. Thank you very much, guys. Welcome back for our second case. Paul did an excellent job of showing that information about our case. I wanted to see whether or not we can show you the CT scan. I'm not sure if we can move the camera over to the screen to show you what the CT scan looks like. I don't know if you can show that coronal image up there and scroll through the coronal image for me. You can see that what you see is that very dilated bile duct, significantly more dilated than it was when I even did the endoscopic ultrasound. This unfortunate lady has a periampullary cancer and actually was recently just diagnosed with a primary lung cancer as well. The periampullary tumor technically may be surgically resectable, but now she's dealing with this lung cancer, so she's undergoing workup for that as well. So, her LFTs started rising. She has some mild scleroicterus now as well. So her LFTs are probably a little bit worse than they were previously. So I want to show you just quickly the endoscopic view. Normally, I would attempt to do a traditional ERCP here. The problem is that this whole ulcerated area is significantly worse. And if you see my endoscopic view now, let me put in a little bit of air so you can see. I can't really advance my scope further, and it's pretty narrowed here now. So I don't really have a good view of the opening to the bile. Like you can see the whole area is ulcerated. And my scope position, I don't really have any maneuverability to advance further to try to cannulate and attempt traditional ERCP. I think it would be risky to attempt to, just blindly pass a tome and wire through a pretty significant ulcerated area. This is so much worse than when I did her endoscopic ultrasound about a month or two ago. I'm actually worried she's going to develop duodenal obstruction here as well and may need some type of management for that. Right now, she's not acting like she's obstructed, but we're gonna actually go ahead and do an EUS-guided hepaticogastrostomy for her. She does have significantly dilated bile ducts, including intrahepatics. So I just wanted to show you that endoscopic image. What we're gonna do is, I don't know if they're ready in room 1. We're gonna go back to room 1 with Amy for her case while I get the EUS machine set up, and then you guys will come back to me when we're ready to do the EUS hepaticogastrostomy.
That sounds great, Harun. We'll move over to the other room, and then we'll come back for the EUS guided biliary drainage. Let's switch over to Amy's room. Amy, can you hear us?
I can. Hi, everybody. Can you hear me? Mm-hmm.
We can hear you.
All right, great. Thank you so much for joining us today. I'm so excited to be here. So we're going to start off with the presentation of the case, and then we'll go through the steps to set it up and start the procedure.
All right, so moving on to the next case, we have a 58 years old female patient, known medical history of diabetes, pulmonary embolism on Coumadin. She was being followed outpatient for 1 year for acid reflux, not completely responsive to medical management. Last upper GI endoscopy was performed in September 2021, which actually showed normal esophagus, and at that time, the gastroesophageal flap valve was classified as Hill grade 1. Because of her persistent symptoms on PPI therapy, she underwent a BRAVO study, which showed pathological acid reflux with Demeester score of 20.2. Subsequently, despite being on PPI therapy, she wanted some definitive management, and she went between surgical and endoscopic therapy discussion, and she wanted to proceed with a TIF procedure. So today, she's here for EGD with transoral incision-less fundoplication, also called TIF.
Okay, thank you so much for that great presentation. So I'm going to start by just going through kind of the steps for how we set up the TIF procedure. So I think hopefully you can see the table here behind me. So this is the device here. You can see there's two components to the device. This is the part that goes in the patient and actually performs the wrap. And then this portion over here is what's controlled by the proceduralist that allows you to maneuver the other part to do the wrap successfully. So the first step whenever we're doing a TIF procedure is to lubricate everything, and we actually use mineral oil for lubrication instead of lube because it allows the lube actually dries out and can then lose its lubrication effect as the case goes on. So we use mineral oil always in these cases. So we've already injected mineral oil through the middle of the device, and now you can see this actually just a standard scope is able to fit through the device, and it goes right through here. I hope you guys can see what I'm doing. There's a little hole right there, and it just goes gently through here. Okay, and we're keeping it nice and straight. Okay. All right. The other thing.
And Amy,
yeah.
Before you introduce the device, do you do a dilation?
I don't. You know, there's definitely some people do. I find that it's usually not necessary. I always do my own endoscopy first and just double check the hiatal hernia and the patient's anatomy. And certainly if there's any issues intubating the esophagus, then I would do a dilation. But in this case, I had no issues intubating, and I usually don't do a dilation. But certainly it's there are definitely some people that do. I don't know what you guys do.
Nikhil makes a good point that is often one of the biggest challenges of the procedure is intubation with this large, thick 60 French device, and especially if you have a smaller person, anyone with head and neck disease or osteoarthritis of the cervical spine, it can be challenging. And so when advancing it through, obviously all of that lube, spray, or mineral oil is very, very important. Other tips that you can consider pre-endoscopic dilation to 60 French, or sometimes actually having the anesthesiologist take down the cuff, the ET tube cuff temporarily during intubation and then reinflating afterwards with extreme extension of the jaw and neck, doing a jaw thrust. Those can be helpful in getting these devices down.
Yeah, absolutely. So we're gonna find out if this patient needs a dilation or not. I'm gonna start here. So I have definitely lubed up with a lot of mineral oil, and I'm getting a nice jaw thrust from Greg here, who's helping me a little bit. And you can see this is exactly the area where there's a little tight, but just a little resistance, and I was able to get through no problem. So I agree, definitely sometimes it's an issue, but I find in most cases it's feasible to pass. So you can see now I've advanced the device into the stomach. I'm going to actually retroflex now, and you can see if you have the endoscopy image, okay, good. You can see that I have the device fully in the stomach. I'm actually going to advance it in just a little bit more to make sure that it's fully in the stomach before I unretroflex it. And now one of our advanced fellows is going to come and join, because this procedure actually takes 2 people to perform. It's one person that's actually operating the TIF device itself, and then another who's controlling the scope. So Arslan is going to come join me, and he's going to take over controlling the scope so that I can do
Amy,
the device.
I have a question for you.
Yeah.
So the world of, endoscopic world of therapeutic advances in reflux disease has been, up and down in terms of the battle of, different interventions, techniques, and whatnot. Even TIF, had a lot of interesting data coming out years ago, and now, it's questionable, just the long-term outcomes and stuff. Personally, I feel that patient selection is maybe the biggest key in terms of having good long-term outcomes for these patients. How do you select a patient for TIF? What are your criteria in terms of who you choose to do this procedure on?
Yeah, it's a great question, and I totally agree. I think patient selection is key. I will say I get a lot of referrals for TIF, and only a fraction of them I determine are good candidates. I think absolutely the biggest and most important thing is that the hiatal hernia needs to be assessed, and I actually rescope every single patient of mine before I'll agree to do a TIF on them, because even a report of a small hiatal hernia is not adequate information. I will actually insufflate the stomach completely in the retroflex position and sit there for a good 20 to 30 seconds, really staring at the GE junction, because it's very easily to be fooled. A GE junction can look like a Hill grade 1, and then after 10 seconds and full insufflation so that all the rugae are flattened out, you can see it's actually more of a 3 or a 4. And I feel like the worst thing for a patient is to put them through an endoscopic fundoplication only to have it not work because there was a hiatal hernia that was not appreciated ahead of time. So for me, that's the most critical part of patient selection. But I also, think it's really important to be sure that the symptoms are in fact related to acid reflux. And so, having some objective evidence that there is reflux disease and it does correlate with symptoms is also, I think, a key piece of information. Yeah. Some people do a manometry ahead of time. I generally don't unless there are symptoms of dysphagia, but it's certainly, I think, not wrong to do it on every patient. So I'm actually going to pull the scope back into the device here, okay, so that I can open it up. So you can see I'm pulling back all the way until I get to the metal lines, okay? And then
While
I'm
you're getting
gonna,
into position, Amy, can you talk about the setup that you have? Do you have a second CO2 insufflator there in terms of your suction as well for the invaginator? Can you talk about the other setup of the device?
Yep, I do. So this device requires a little bit of special endoscopy setup. As you mentioned, it does require 2 CO2 insufflation devices, and it also one that connects regularly to the scope, and then another one that helps to insufflate. So here you can see the scope is, the device is in position. The other thing that's very important is it requires 2 suction areas. I'm going to actually hand the scope now to Arslan here, and so I can do this part of it. But so the second suction is very important because it controls what's called the invaginator, which is a critical part of the TIF procedure. When you're doing the wrap, you really want to make sure that when you're deploying your sutures or your fasteners, that you are not accidentally going or involving the diaphragm. And so what the invaginator does is it allows you to suction the wall of the esophagus to the device and then adjust the device and sort of pull the esophagus below or above in order to make sure that we're not involving the diaphragm. So Arslan is going to insufflate here, and then you're going to see we're in the device is going to be. Oh. Yeah, we're just we're just setting up our CO2 here. 1 second.
Mikhail, are you employing TIF in your practice, or are you considering other endoscopic anti-reflux intervention?
Yeah, so we are using TIF. I think the key point that Amy had made is that you really have to make sure that you assess for the hiatal hernia. It needs to be 2 centimeters or less. If it's bigger, then then really they need to have a lap hernia repair first. And repair of that crural defect in particular. You can do combination lap hernia repair and TIF. Ken Chang has done that a lot and has published on that in the past. There are other endoscopic modalities that have been described for anti-reflux measures. So ARMS, where you do essentially a mucosal resection, a mucosectomy. There's another endoscopic option for anti-reflux treatment where you can use endoscopic suturing to try to, again, in combination with EMR, to try to sort of create a valve at the GE junction. But I think the more mainstream version, at least in the States right now, is the transoral incision splint application. So we'll hand it back to you, Amy, watch you do a few of the fasteners, and then we'll shift back over to Haroon after you place the first few.
Yeah, I think actually we're going to switch back over because we're just having some issues with our CO2 insufflation. So while we troubleshoot a little bit, we're going to go over to room 2, and then when you come back to me, I'll have everything ready and we can start the wrap.
Perfect. Let's switch over to the other room.
Hi guys, welcome back. So I have the linear EUS scope down now. I'm looking at the left intrahepatic ducts, which you should be seeing now. This, I use flow to see where the vessels are, and we have a dilated intrahepatic duct here, which looks like a good target for me for hepaticogastrostomy, and it's about a little over 3 millimeters in size. I don't know if you can see fluoro right now. The fluoro image, if we can switch to for a second. Yeah, so this is my position in the stomach I am very proximal in the stomach, but I am below the GE junction. We obviously try to make sure we're below the GE junction when we're doing a EUS guided biliary drainage from the proximal stomach. You don't want to drain it from the esophagus as long as you can avoid it. If you go back to my EUS images, you'll see we're proximal, and this is the right side of the screen is obviously the heart. So we can be very close to some pretty significant organs, so we need to be very careful. So I'm going to target this vessel here, this bile duct again, and I think I have a pretty good trajectory. So we're going to advance our needle. I'm going to take off flow for now, since I think I have an idea of where we're going to be. And
can we see a split screen of the EUS and fluoro, please?
Are we able to do that, guys? I'm not sure what. Are they on the? Okay.
It's okay, Arun. As long as we have the EUSB, I think we'll be okay.
Yeah, I'm gonna go ahead and try to puncture this and hopefully get it in that vessel. Okay. So. I think I'm right proximal to it. And I might be in there, trying to get a better view on there. Okay, let's try pulling the stylet out of the needle, and then we're going to inject some contrast, a little bit of contrast, to get an idea if we're in the duct. Live fluoro.
Often when I'm in these situations where I'm not sure where the needle is in the duct or not, I'll actually aspirate first before I inject contrast, because sometimes the contrast will affect your view on the EUS screen.
You're right, which is what's basically happening now.
And then it makes it a little bit harder to find the ducts again, and sometimes just a little aspiration, if you get your bile, you hit gold, whatnot.
I agree with you. It looked like I was in the duct, that's why I went ahead and attempted.
And Harun, what's the minimum diameter of a duct that you ideally want to use for hepatocogastro? Obviously, the bigger the better, but is there a lower cutoff that you use?
Okay. I'm sorry, I missed the question there for a second.
No problem. The question was, what's the lower end of the cutoff that is an acceptable diameter of the bile duct for you to do hepatocogastro?
Yeah, I mean, usually the wider it is, the better it's going to be. Give me 1 second, sorry. Yeah, I mean, if it's at least 3-4 millimeters, I think it's usually a pretty good target, which is where we're kind of at right now.
Yeah, I don't think there's any minimum size criteria that
can you try aspirating here?
Would preclude you, but being able to see the duct is one thing, because sometimes these ducts are just not dilated. If you can't really see the duct, then you're not going to be able to do it.
Okay.
Some tips and tricks when you're trying to access these things. Harun found a very nice spot in the sense that it's in the periphery of the left lobe, right? When you're trying to access these left intrahepatics, you don't want to go too far centrally into the duct, because when you do that, you have a lot more liver tissue that you're going to have to get through to make a dilated tract through, vessels to get through, and then put your stent through. So there's more risk. But if you hit it more peripherally and then pass a wire through, that's usually a better angle. And then the other thing he did which was also intelligent, was to look at the fluoroscopic image before. Obviously, the position of the scope, esophageal, gastric, we want to make sure we're below the diaphragm, but also just the angulation of the scope.
I think we're getting something.
Sometimes when you're doing these procedures, you have a huge bend on the tip of the endoscope as you're angling up to see the liver. And when you do that, your chance of success goes down in the procedure because you lose your mechanical advantage of advancing wires, dilators, and stents. So having a much straighter scope position, just like in any procedure, it gives you a little bit more mechanical advantage to advance things. And that's always important to check before you do your initial needle puncture, because you want to set yourself up for success. I don't know if Nikhil, if you have any other tips or tricks when you're trying a technique like this.
Yeah, I think you hit some of the big ones on the head. I personally like a bile duct diameter of at least 4 or 5 millimeters because I want to have a reasonable target to hit with my needle. Sometimes I'll actually go through and through with the needle, and then as I pull back, make sure my needle is within the duct. And I agree with you, if I'm not entirely convinced, I will certainly aspirate bile first, because if you inject right away and you're not in the duct, you'll have sort of an intraparenchymal injection, and then you'll have distortion of your EUS image. You'll see sort of a hyperechoic contrast, and it may affect your ability to puncture, in a similar plane. If you have a good view, you may have to adjust. Typically, these punctures are done, either into segment 2 or segment 3 on the left side of the liver. You need to make sure that you're underneath the GE junction. And as you alluded to, you want to try to be more on the periphery as opposed to central. I do like to see at least a centimeter or 2 of liver, though, because I do want there to be a bridge of liver between the duct that I puncture and extending back to the stomach. I don't want there to be any bile leak, so I do want to make sure that there's a little bit of liver, in between the stomach and the bile duct.
We got anything? Yeah, we're gonna go back to Amy for a second while I try to access this duct here. Go ahead, undo.
Okay, everybody, welcome back.
Okay, Amy.
Yeah. Hi again. So we've sorted out, we were having some issues with the insufflation, and it just goes to show how important the double insufflation is. We weren't able to insufflate properly through the second insufflation device, but we have fixed it. And now if you can see the endoscopic image, I'll show you that I'm in position and I'm ready to start doing the wrap.
Can we get the endo image, please, for this case?
Okay, perfect. Okay.
Okay.
So you can see now I have the device right at the GE junction in good position
Beautiful.
here. So I'm going to start my wrap. So the first step is actually to grasp the tissue with this special helical retractor here. So you can see it coming out there, and I'm going to screw it right in and get a really nice bite. And what this does is it allows me to pull the tissue in between the jaws of the scope in order to get a really good wrap. And I'm just separating it here from the channel just a little so that I can really pull it in. And so now I always start in the 11 o'clock position. So I'm gonna wrap towards the 12 o'clock position. So what's gonna happen is I'm gonna pull my tissue between the jaws of the device, and Arslan is gonna suction down the lumen as I twist towards the 12 o'clock position. And you can see the wrap starting to be formed here. So he's gonna keep suctioning, suctioning, suctioning. I'm going to keep going until I feel like I have a good wrap to start. I think I'm pretty good here, so I'm going to go ahead and tighten it up and hold that in place. And now we've already loaded our first set of fasteners, so this device allows you to actually deploy 2 at a time. The next critical thing, though, before I deploy is that I'm going to make sure that I'm in a good position so that I make sure that I avoid the diaphragm. So I'm going to go ahead and turn the invaginator on, which suctions the device to the esophageal wall. We've already measured previously before we were on camera that the G junction is at 40. So the device actually has markings on it, and I can see that actually I am exactly at 40. So I'm in a good position. So I'm going to go ahead and deploy my first 2 fasteners. And all I have to do is squeeze this handle just like that. We're going to now turn the invaginator off. I'm going to go ahead and reload so that when I take my next bites, I'll be ready to fire at that time too. And I'm going to have
Great demonstration, Amy. We have a question from Professor Eduardo Demura from Brazil. He wants to know, what's the minimum number of sutures? Is there any work comparing the number of sutures for transoral incision splint application?
Yes, it's a great question. So in the initial data, there were fewer than 20 sutures used, and it was found that really you need to have at least 20 to have a really nice, durable wrap. So the device actually comes with 20 sutures or fasteners already a part of it, and I make sure that I always use at least 20 for every TIF. And then sometimes, depending on what it looks like, I'll do some inspection afterwards, and I may put a few more. I'm going to have you suction down the lumen again, and I'm going to wrap again here. Yeah. So here you can see I'm again wrapping in the same position. I'm just twisting a little bit because I don't want to deploy both on top of each other. Let's invaginator on, okay? Again, I'm checking to make sure that I'm right at 40 centimeters, and I can always adjust my device in and out a little bit to make sure I'm within a centimeter, and I am. So I'm going to go ahead and fire. And my practice is I put 6 at a time on each of the 11 o'clock and 1 o'clock positions, and then I elongate the wrap at the 5 and the 7 o'clock position with 4 each, and then I reassess. So Arslan is going to re-insufflate here and follow me just around the other side so we can see. Okay, so you can see we're already forming the wrap. So actually my helix has come back around this way a little bit. Okay, so yeah, there we go. Good. Okay. All right, so I'm going to re-engage my helix, which fell out a little bit here. You can see now it's no longer in the tissue.
And so your overall goal here, Amy, is you're going to try to create an omega-shaped 270-degree wrap that's both tight up in the corners at 11 and 1, and then is the goal with the 5 and 7 o'clock orientation that you're trying to create length to your valve?
Exactly, yeah. So usually the wrap part is done at the corners as you were describing, and then the length is really at the 5 and 7 o'clock. So I'm not so happy with my wrap here, so I'm going to just tighten this a little bit, and then Arslan is going to suction down again, and I'm going to twist here. So you can see actually.
Amy, do you ever consider using EndoFlip before and after these procedures to measure, get an additional measurement as to whether how effective or how long or lengthening of the wrap has occurred in terms of creating a higher pressure zone?
You know, it's a great question. There's been a little data on that. I don't, because with the TIF procedure, it's actually almost impossible to make it too tight because you're wrapping around this long device. So I don't think it's as critical to double check afterwards, but it's definitely an interesting idea. Are you doing that?
So, I haven't done as much TIF lately as I've been doing wrap, which Nikhil alluded to earlier, the resection implantation technique. But on the last few TIFs that I did do, we did employ EndoFlip before and after, and what we could notice actually was the lengthening of the high pressures, which I think is actually useful for this technique because sometimes we're wrapping but not lengthening, and that it may be part of the key in terms of longevity of the TIF procedure. So there may be some worthwhile data in terms of seeing how much longer or how long the high pressure zone is being created in the procedure itself, and whether an extra suture or two would affect that and change your management interprocedurally. But as you said, this is very kind of early anecdotal data and more systematic kind of things need to be done. It's kind of like the opposite of home, right? We're using EndoFlip to make sure that we're getting adequate myotomy, and in a TIF, we're doing the exact opposite thing, trying to tighten things up. And so is there any other empiric data, intra-procedures that we can use to make sure that we're doing a good job?
Yeah, no, I think it's really interesting. And I think it's just an example of how we, as new technology becomes available, we're finding more and more ways that it can be useful to help us improve our techniques to take care of patients. So I like
Just a reminder to all our viewers that are watching, feel free to utilize the chat box function to pose any questions live to the endoscopist. Amy, can you review with us what your protocol is? Beforehand, do you give these patients antibiotics? And then post-procedure, can you talk a little bit about the diet that these patients have to be on after the TIF?
Yeah, absolutely. I think it's really important actually to have a good discussion with the patients ahead of time because there are certain dietary adjustments that are really important afterwards. So I always, have a full visit dedicated to talking about the procedure ahead of time so that they know what they're getting into. So I actually don't give antibiotics around the procedure, but I do put them on a very strict diet afterwards. I put them on a 6-week diet with the first 2 weeks being primarily liquids and then slow reintroduction of food over the next month or so. And there's also some exercise restrictions that they need to be aware of, especially in the first couple weeks after the procedure. I do find, when I first started doing this procedure, I was admitting patients overnight for a night just for observation, but I've actually now started sending most of my patients home. I find they do really well. Some have a little bit of chest discomfort or chest pain afterwards, which I warn them about, and I do generally give patients some liquid Tylenol with codeine just to manage any pain, and I keep them on antiemetics as well. And then I usually keep my patients on their PPI dose at least for a couple weeks after the procedure, and then when they're doing well, I start to taper it off. So that's the protocol that I use, and that I give patients a diet ahead of time so they can shop and be ready to bile their supply. So you can see I'm now at the 1 o'clock position. I've just started the wrap over here. I'm gonna fire my fasteners, and I think you're ready to go back to the other room. So I will send you there and see you in a bit.
Yeah, great job, and we'll come back to you. But for now,
Can you give me
we're
another
over
wire?
to Haroon. Haroon, how are you doing?
Okay.
I have access to the bile duct. I don't know if you guys can see fluoro. Stop for a second.
Fluoro, if we can.
You guys see the fluoro? I'm injecting contrast into the duct.
Fluoro.
Inject. You can see fluoro?
Yes.
All right, good. So that's the bile duct there. Stop injecting. We can inject some saline now. You can see it's actually open, pretty open down by the bile. You see the small bowel already. And I wonder if that's like a fistula or something, because it seems like very wide open down there. Obviously, I didn't see anything obvious. It's ulcerated. What we're going to try to do now is try to pass a wire down the duct here. So we initially inject some contrast to confirm that we're in the bile duct, and then we flush it with some saline because contrast can be pretty sticky. And then after that, we try to pass a wire. So it's important.
What kind of wire do you like to use?
I use a hydrophilic a VisiGlide wire. This is an 035 wire. Stop, pull back. Okay, hold on
And
one
what
second.
needle are you using here, Haroon?
It's a 19 gauge Cook access needle. Fluoro here for a second. Can you go ahead and try
So the nice
advancing?
thing about the Cook access needle is that there's no sharp tip right at the
Yeah,
end of it,
exactly.
which prevents shearing. And then the other good thing about the VisiGlide wire is that there's no coating.
I need to come back.
Because it's a hydrophilic uncoated wire. So it's nice that it doesn't shear as well. So that wire can be used even with sharp tip
Right here.
needles.
Fluoro? No.
A little chance of shearing, but you definitely need to have
Right here.
that entire system pretty wet, as Haroon's
Exactly.
saying, flushing it with water so that you're not sticking it through contacts, otherwise you will have a lot of
Right here.
friction. But it's interesting. You can see the shape of this biliary
Go back.
system here, right? It's convoluted.
Yeah.
It's how deviated the axis of the bile duct is because of this
Yeah.
obstruction. It's almost like making a U-turn to get back into the if you're going to get this
Fluoro?
transampullary. But if it were hepatogastrostomy, hopefully you won't have to deal with that. But trying to do an antegrade procedure in this scenario could be challenging.
Yeah. So the
Haroon,
issue we're
can
having
you
right
talk a little
now.
about the decision between doing a choledochoduodenostomy versus a hepatogastrostomy?
Yeah. So this is a patient that potentially may go to surgery, and we don't. Sorry, give me 1 second. I'm just advancing the wire here, trying to see if I can get a little bit
Nice job.
deeper. Hold on 1 second. I'm not ignoring you guys. Flora?
I think you're doing some important things. It's okay.
So we're having a little bit of difficulty. Kelly, can you pull back the wire a little bit? I think it's a little bit taut. No, pull back. Try again here, Flora. See, the wire is trying to go upstream rather than downstream here, which is why I'm trying to play with the wire here to get better access.
Do you ever consider using angle tip wires in these scenarios, Haroon?
What was that? I'm sorry?
Do you ever use angle tipped wires,
Yeah.
angle tipped hydrophilic wires? When the wire doesn't go where
Yeah.
you want it to go, use a little bend on the tip to see if it can change its direction.
Yeah, I think that it can be helpful sometimes, Flora. Is that it? No. Hold on 1 second. Yeah. I'm gonna. I think Amy is ready in the other room. They're asking me, so we're gonna throw it back to her for right now while I play with this wire a little bit, and hopefully we'll get it down towards the ampulla. So we can switch back to Amy.
Okay, sounds good.
All right. Hi, everybody. Welcome back. So we are now on the lengthening part of the procedure. So you can see my device is in the 7 o'clock position. I've just pulled the tissue into the jaws of the device. I have my invaginator on, and I'm right around 40, so I'm going to go ahead and fire here.
Can we see the endo view, please?
Oh, yes, sorry. Okay. Okay. All right. So I'm reloading. So you can see the what we've done so far up in the 1 o'clock position there. This is my first firing at the 7 o'clock position, so I'm going to do one more here. So again, I'm just going to loosen up, and really this is about length. So I'm pulling the tissue and really burying the device in order to get some nice length here. And this is the time when it's critical to make sure that we're below the diaphragm. So we're going to invaginator on, and then I'm just going to gently ease the scope in to make sure that I'm within a centimeter or two of 40 centimeters. So without, losing too much ground on the device. So I'm now just about there. So I'm going to go ahead and fire. Okay. Okay. Invaginator off. We're going to reload. So I have 2 more left with this cartridge, and that will be 20 fasteners that I fired. And then I'm probably going to have to put a few more. You can see there's still a little bit of a gap there at the 1 o'clock position. So I can already tell I'm going to need to put some extra fasteners over in that area.
Amy, we have a question, another one from Professor Demora from Brazil.
Yeah.
When the post-TIF procedure isn't adequate, the patient doesn't have a good response, do you redo the procedure? Do you use PPIs? Do you send them to surgery? How do you approach the management of a patient post-TIF that maybe has not had the best response?
Yeah, another great question. I think it's a case-by-case basis. I don't think, if the patient's just having mild symptoms after the procedure, I definitely think it's okay for them to be back on medication periodically, as long as they're taking it intermittently. If that controls their symptoms, I still consider that a success. If they're still having predominant symptoms after the TIF, then usually I start by rescoping them, look to see if it's tight and intact. If it's loosened, then, you can offer them either a repeat and a retightening, or potentially thinking about doing a surgical intervention. Sometimes, even as thorough as you can be checking for a hiatal hernia ahead of time, it is possible that it can be missed. And so if that's the case afterwards, then I generally will talk to them about hiatal hernia repair as well. So it's a case-by-case discussion with the patient. I think they're ready for you again in 2, so we're going to head back there. And hopefully when you come back to me, I'll have a nice, beautiful wrap to show you.
Biopsy cap, here you go. We're back. All right, guys, so I was able to maneuver the wire down. I did not have to change the wire I was using. Sometimes persistence is helpful, and other times it's just luck. So we're in a dilated portion of the lower bowel. It's actually not the small bowel. It was so dilated I thought maybe we were in small bowel, but it's not. We're not actually opacifying any small bowel here. So, once you have access, the next part is usually dilating the tract or creating that fistula tract, because the 19-gauge needle is usually not wide enough to be able to pass a hepatogastrostomy stent in. So what we're doing now is I'm going to try to see if I can just get a balloon dilator to go through and not need to use something like a cystotome or a needle knife to create that fistula tract, which can obviously cause injury and bleeding. So I'd like to try to just get the balloon dilator across. Can you just straighten this out for me? Thank you.
So, Haroon, there's a question from the audience. What are the criteria for deciding between hepatogastric and choledochrodia?
Oh, yes. Fluoro for a second, sorry. I think most of the time what ends up happening is that, this patient is potentially a surgical candidate, and our surgeon asked me to avoid doing a colodocoduodenostomy in the situation. So, that's why I'm not doing that. I think, potentially we would have had a much easier access with that dilated of a distal bile duct to do a colodocoduodenostomy. Personally, I prefer doing hepatogastrostomy just because if you end up in a situation where you misdeploy a stent, I feel like it's easier. You're less likely to lose your wire, and I feel more comfortable putting a hole through the stomach than I do putting a hole through the duodenum. So that's pretty much it. So if you can go to fluoro for a second. So I was able to luckily pass my balloon dilate into the bile duct without needing to use a cystotome or a needle knife. And what I'm going to do now, this is a 4 millimeter hurricane balloon that we're going to dilate this tract, and then we're going to be using a 10 by 8 fully covered Gore viable stent. Give me 1 second. We're going to dilate here. So you'll see on fluoroscopy. I mean, right now you're not seeing much on EUS as much. It's mostly by fluoro. I usually try to go in a decent amount into the duct and dilate, and then make my way back, balloon down. Fluoro. And balloon dilate here again. I like to be pretty aggressive about balloon dilating just because I don't want to end up in a situation where I can't pass the stent. If you look at my EUS image now, you can actually see where the balloon is dilated. Can we switch over to EUS image for a second? So, you have the split screen. So that's my, that there is a balloon dilator. Balloon down. And I'm going to bring this in.
I agree with measuring twice and cutting once.
Yeah.
It's a smart thing to do.
100%.
Dilate as much as you can.
Dilate here again.
Tell us a little bit the Gore stent that you're going to use. Why did you choose Gore, and what's the diameter and length and whatnot?
Yeah, so the Gore is a fully covered biliary stent that has some fins on it that prevent migration. And that's the reason I like to use that stent in these situations, because the likelihood of the stent migrating is much less. Also, when this stent is deployed, it tends to deploy in the exact position that you place it, as opposed to kind of jumping forward or foreshortening that you may get with some of the other biliary stents. Balloon down. I'm going to dilate again. This is just me being very anal about making sure that this is going to be enough of a dilation. Balloon up. So that's why I like to use the Gore stent. I like to use a longer side stent because I like to have a decent amount in the bile duct just to prevent that stent from coming out in case eventually the stomach obviously contracts. So if the stomach was to contract and pull away from the liver a little bit, you have enough of it in the bile duct that that stent will come apart. Balloon down. Sorry. Hold on 1 second, guys. We're gonna, the bile duct is actually not that dilated. We're gonna use an 8 millimeter diameter instead of a 10 millimeter diameter. You think a 10 is better here? Can you measure for us? So this is where it's great having, Junior is in the room. He's one of our radiology technicians. He's able to assist us with a lot of these therapeutic EUS cases. And one of the things that's very helpful is being able to measure, how far you are. Obviously, this is a two-dimensional image you're looking at. So it's possible that we're going posterior or anterior, and this is not going to be an exact measurement. But I like to measure basically from the scope to the area where I want to deploy the stent to get an idea of, how long of a stent I'm going to need. This is probably going to be about 5 centimeters, it looks like, but it's probably a bit longer because I think we're probably going a little bit posterior. So you think I think an 8 by 8 might be okay, no? I think 8 fully covered Gore is what we're going to use. Obviously, I want to have some amount of stent in the actual GI tract. So balloon is down, correct? Yeah. Okay. The other thing I want to mention is, we're doing this, and fluoro, my wire's still good. We're doing this, you're dilating. We've created a fistula with the bile duct. You're going to have a little bit of leaking of bile, and you're going to get a little bit of bile peritonitis here. You need to give these patients antibiotics. They're probably going to have a little bit of pain after the procedure as well. Thank you, Kelly. Junior, wire is still okay?
Yeah. All good points. There's some other questions from the audience about antegrade stent placement from Dr. Largi. I think that these routes of biliary drainage, transmural fistula creation by hepatocogastro or colodoco versus antegrade, they have to be weighed out, and I think that in a scenario where a patient is a
surgical candidate, I think that it's a good idea. It's a good idea to use natural anatomy to drain these patients. So an antegrade stent placement is a very reasonable thing to consider in these scenarios. I actually prefer it. If I can get the wire all the way into the duodenum, I'm always doing an antegrade stent placement for the most case in cases where they're potentially surgical candidates. And if they're not surgical candidates, when you're trying to consider these hepatogastrus and choledochoduals, one thing to consider is that the data hasn't shown that there's much difference in terms of success and adverse events between the two routes of access. When you do these choledochoduals and hepatogastros, remember that you're draining the bile back into the stomach or duodenum.
Exactly.
And if there is a gastric outlet or a duodenal outlet obstruction distally, all that bile is going to be stuck in the stomach or duodenum. So you should think about that point as to when you're going to do an antegrade versus a fistula creation, because the antegrade will at least allow for the bile to get distally into the enteric system.
I agree with those points. We're not able to get the wire across into the small intestine. I didn't play with the wire that significantly. I did have difficult time accessing this, so that's part of the reason that we're going to be doing a hepatogastrostomy in this situation. Even if the patient did go to surgery, it's important to note, we are out of the surgical field for someone who's getting a Whipple surgery, and our surgeons have had done this Whipple in someone who has hepatogastrostomy. And they go into the operating room and they don't even know it's there. Sorry? Okay.
That's all great points.
We're going to be, Avik, do you want us to deploy the stent and then go to one? I'm gonna switch over to a little bit of endoscopic view to have an idea what's going on. You can see my stent is pretty deep in. The distal end of my stent is not fully out yet, Flora. I'm gonna try to keep some of it into the stomach and go ahead and start deploying. I want to make sure that you can see my endoscopic image here. This is the end of the stent here, right? Fluoro? Yep, there you go. Keep deploying. Keep deploying. We look good. Keep going. Keep going. Stop. Perfect. So you see my endoscopic image, guys? So that's the hepatogastrostomy. I'm gonna switch back over to room 1, where I think Amy is finishing up her case. We're gonna pull this out.
Great job, Arun. Great job.
Thank you.
All right.
Can you do an exchange for me?
Hi, everyone. Welcome back. We are nearly done here. Invaginator off. Let's reload. So I'm just doing some touch-ups now. I've deployed the first 20 fasteners, and then I just tightened a little bit in the 1 o'clock area, and then I just tightened a little in the 11 o'clock area now. And then we're going to just do some inspection now. If you have the endoscopic view, you can see it's much tighter up there now in the 1 o'clock area than it was before. It looks like nice and tight against the device there. So I'm just going to release my tissue helix here.
So how many fasteners have been deployed at this point, Amy?
I have deployed 26 so far. So I always deploy at least 20. Great. And then usually the next 20 I sort of deploy based on what everything looks like. So we're just going to do a little bit of inspection now. So I think it's pretty tight most of the way around. You can see some of the fasteners are a little bit loose, and that's why, we deploy extras, just because, some inevitably are going to deploy a little bit looser than we would like them to. So I think this side looks pretty good. What do you guys think?
It looks great. Definitely can see some lengthening of this wrap, and you've got some tight corners up the 1 o'clock position. Yeah. So it looks like you're doing a great job.
Yeah, I think I'm happy with that side. So now I'm going to rotate my device around here to look at the other side. So Arslan is going to come around so we can see this corner. And that also looks pretty tight to me. So I think we might be done here. What do you guys think? I think it looks pretty nice.
26 sounds good to me.
Yeah. So I'm pretty happy with that. So I think we're going to go ahead and take the scope out. So obviously, the device here is retroflex. You can't pull it out through the esophagus like that. So we'll need to straighten it out. So I'm going to just rotate the device so that as I open it, it's going to be opening into the dilated part of the stomach. And now we're going to keep the device in place and actually pull the scope into the device here. We're going to unlock all the dials, and you can see I'm all the way back in, and now I'm going to gently open up the device and basically straighten it out. And then just to be sure that we're straight, I'm going to go back through here with the scope So you can see now I'm all the way out and I'm back in the stomach. So I know that everything is nice and straight as I'm coming out. The other thing to keep track of is that you want to make sure that the retractor is fully retracted into the device so that you don't have any damage to the esophagus. And now we're going to slowly come out, and Arslan is going to keep insufflating so that we can see, as we come across the GE junction, you'll see the fasteners in place, where you can see them nicely deployed right around the GE junction. All right, so I'm coming out again, bringing everything together, looking at the esophagus on my way out to make sure there's no trauma. And then usually, once I'm out, I go back in with just the scope and take a look, and also suction out any remaining blood or liquid that might be in there, because that could certainly cause a little more nausea post-procedure. So I think that's basically a wrap. So thank you so much for joining, and I'll send you back to room 2.
Okay, fantastic.
How's it going, guys?
Arun, we're back with you.
I was able to play with my wire after placing the metal stent, and it looks like I might be in small bowel flora. It's a little bit.
Can we see the fluoro image, please?
Oh, sorry. Fluoro?
Yep. Yeah, you're definitely in the small bowel there.
Yeah. The only issue that I'm having is that there's I don't have leverage right now with the balloon to get across. This turn to basically where the hilum is, I'm having an issue advancing instruments. Ideally, it'd be great to get a long double pigtail across there. I just don't want to, we just placed this metal hepatocogastro, so I don't want to do anything to jeopardize that. Flora?
Yeah.
So I think what we're going to do is probably just dilate here and then dilate the hepatogastrostomy stent and place a pigtail. We'll see whether or not that pigtail goes further in. It may not. Go ahead and dilate. We're going to just dilate. The area where the hepatocogastro comes into the stomach is oftentimes narrow, so I like to dilate that area just to facilitate passage of a double pigtail stent. So that's kind of where we are right now.
Great. We're just seeing some images of the final wrap procedure, the rib tip on the right, and you can see in retroflexion how nice Amy's wrap was. You got that omega shape kind of wrap there. So, so Haroon, you generally will place that double pigtail almost after every hepatogastrostomy stent that you place, just for anchoring, to kind of keep it in place.
Yeah, I do. Is that your guys' practice as well when you're doing hepatocogastro?
Yeah, absolutely. And we use the same kind of stent. We use like these anti-migratory stents. A tip on how to get across that ampulla when you're doing these cases is usually after you get the wire in the bile duct, it will do a similar thing that would happen to Haroon, where it curls at the level of the stricture, right? The wire does not want to go across the stricture. But when you form that dilation tract with your balloon, your 4x4 hurricane or whatnot, whatever you're using, if you pass that balloon all the way down to the level of the stricture and then play with your wire, you've created another secondary point of mechanical leverage. And that, when you push through from that point, as opposed to pushing in from the tip of your scope, then you can access through the stricture, and it's almost like just you push the wire all the way through. And then that gives you the option. You have the wire coiled in the duodenum. Hey, do you want to go hepatocogastro or do you want to go integrate? And you can kind of make your decision at that step. But this was clearly a successful procedure. You got that stent in, and you had some liquid gold coming out of it.
Yeah.
So good job.
Thank you very much, guys. We're just going to dilate and then place the plastic stent. Obviously, this was a little bit ballooned down. This was a little bit more difficult because we didn't have great access initially. So our other option was, we could do a colodocoduodenostomy in this patient who had a very dilated distal bile duct. So we weren't out of options. Balloon dilate here again.
Yeah, that point is also interesting about the colodoco versus hepatico or integrate. There is some data showing that the colodoco duodenoscopy will stay patent longer than an antegrade or a transpapillary stent, which makes sense, right? Because you're creating a fistula tract where there's going to be less junk and potentially tumor ingrowth, because you're creating a a pathway separate from the tumor and not going through the tumor itself. And so for these palliative cases,
maybe we switch to a stiffer
these
wire.
fistulas like a colodoco may be a one and done kind of procedure as opposed to requiring revisions of an antegrade stent that goes through a tumor itself. So those are all important points to take into consideration.
Balloon?
Each case can be challenging and unique.
Can you do an exchange here for me? Hold on one second. Exchange. Excellent points, guys. What I'm trying to do now is actually I'm gonna, and again, this is probably not as important, but I would love to be able to get a stent across the stricture below. Then you have drainage of bile not only into the stomach but also into the duodenum, and you know, potentially if she develops gastric outlet obstruction, as you were mentioning previously, and you're gonna have to deal with all this bile that's gonna be coming into the stomach. But if you have some drainage going to the duodenum, that may, you know, help that issue. So what I'm going to do, you know, I'm using a VisiGlide wire, which is the wire I normally use in these situations. I'm going to switch. I'm going to advance another device over the wire, and then switch out my wire to a stiffer wire to see whether or not the stiffer wire may help facilitate passage of instruments down across that bifurcation and down across the ampulla. So stiffer wires can be helpful.
Before
in
you
these
do that,
situations.
Haroon, can you get that balloon, that 4x4 balloon, to go across the wire and get across into the duodenum?
No, that's what I was trying earlier. It wouldn't go. Usually
couldn't get
that's
it across.
Yeah, usually that's what I would do. Is I would use that just because it is very tapered on the end and tends to go through areas of narrowing or stricture much better. But unfortunately, that was not advancing. And part of it is I don't have as much pushability where I am right now. So I'm wondering if I have a little bit of back tension on a stiffer wire, whether or not that may assist me a little bit more. So we're gonna do that now. I think we are close to maybe going over to the lectures. I'm not sure just yet. I'll double check with
we're going to go over soon. We'll just hang with you for a few minutes here until they're ready to get that going. But we'll see whether we can double stent this patient.
Can you give me a back tension on the wire? Just stop for a second, Flora. Can I see wire, guys? Thank you. Okay, I have wire. I'm going to advance, and then we'll switch over to a hydrojag.
Very key point is having enough wire in the duodenum. Curling that wire in the duodenum gives you that safety margin. So when you're pulling back tension or forward tension, or even if you try to just push something over the wire and it's not going, you won't lose wire access.
Oh, so that went easily. That's surprising. We didn't even switch the wire, did we?
Using a balloon here.
We didn't switch the wire, but we were able to get the balloon across, which I'm very surprised by, given the fact that the...
Yeah, there you go.
Fantastic. So hold on one second.
Yeah, once you've done this, you should be good, because the balloon catheter is a lot more floppy compared to the Hurricane, so that's a good sign.
Let's just confirm. We're going to inject some contrast, confirm we're in the small intestine. Balloon down? Yeah, balloon down. I think I'm not far enough in. I think I'm in the distal duct still. I think, hold on one second. Let me pull the wire back and try to straighten myself out. It's kind of going back, which should still be in the bowel. Go ahead and try injecting here. So it looks like we're getting some small bowel. That's good. Stop injecting. Flora? What do you think, Junior? I'd like the wire to go the other direction if possible. Yeah, that's what I'm trying to do, Flora. Yeah, let's switch to a hydra. Let's switch to a stiffer wire anyway.
There's a question here about, secondary gallbladder drainage if the bile duct tree is not accessible. I think we kind of talked about that a little earlier. Do you have any comments on that, Haroon, about draining the gallbladder if you can't get into the bile duct?
Oh, yeah. I mean, if you can't drain it, you're talking about for biliary decompression, correct?
Correct.
Yeah,
correct.
Yeah. I mean, you can. I mean, you can do EUS-guided gallbladder drainage, and hopefully, as long as the cystic duct is patent, you can potentially get secondary biliary drainage that way. The cystic duct is obviously very small, so you're more likely to run into issues, I feel like, if the cystic duct is not completely patent or there's a lot of stones. But that's definitely a viable option. Flora?
Yeah, I think there's less data on it. It's been used, it's been
Pull back
attempted,
the wire.
and it's been
Now
had some
advance.
reasonable results. I think if you have a really
We're probably
dilated
okay there, no?
gallbladder, like a really
There you go.
distended gallbladder, that is an
Exchange.
evidence that there is fluid and,
Oh, yes,
bile
sure.
going into that lumen.
Thank you.
And it'll
Exchange.
probably be a reasonable route for drainage. If it's not that large, your cystic duct may already
Can
be
I
involved
ask you
with
to
the
do the
tumor.
exchange
It's just
because I'm
not going
having
to be
difficulty
effective.
passing it?
So doing this, what you're doing is obviously definitely preferred.
Yeah. So we're just exchanging. We're okay there? Balloon is down. I think we have wire in the small intestine now. Hold on, I have wire.
What type of stent do you want to place across this ampulla if you can get there?
Yeah, I mean, so you have options here. You could place a metal stent across this area, and open it up that way. You're almost, you'll ensure that the bile drains preferentially down into the small intestine. I do want to anchor this hepatogastric as well. So most likely I'll end up placing a long double pigtail stent in this situation. It will be across the ampulla and across the hepatogastrostomy. Yeah. So, the stents that we use, this is a very long, bile duct, obviously. You need a stent that's going to be long enough for this. A lot of the biliary double pigtail stents that are available are usually, I think the longest are like 15, maybe 18 centimeters, which may not be long enough. As you can see, Junior's already measuring for me to try to figure out, I don't know if that's coming up on the image, but to figure out, how long of a stent we need. So we do use off-label urology stents, which are longer, double pigtail stents. I don't know if you guys have done that as well. Sometimes we don't have stents long enough, especially in a situation like this, even sometimes when you're doing, necrosectomy in large walled-off necrosis cavities, sometimes you need long stents down deep into cavities, and, the biliary stents that are available are not usually long enough. So we'll actually borrow these double pigtail stents from urology and use those, which are very similar to actually our biliary stents. Junior, what are we looking at?
Right. So I think in this scenario, if you use a metal stent, you have to be a little cautious about, the delivery system of a metal stent, how stiff it is, and how large the caliber of that delivery device is going through your stem. There, you're inflate your stent to make sure it doesn't drag it forward. Right?
Yeah.
You just don't want to move that position. You have about 1 centimeter or so of leeway in the stomach side. So you want to make sure that whatever goes through it is not going to change the position of your stent. And then, as you mentioned, with plastic stents, they'll be easier to get through, but are they long enough? In this scenario, I think you have to have a very, very long stent to bridge it all the way to the stomach. You could opt to just place one across the ampulla. You have access to the ampulla. No, not truly, but you have some visualization there. You could just place a 10 French or whatnot across the ampulla just for to get some biliary drainage from that scenario, like a 10-5, 10-7, because you can measure this picture there, and then use that as a bridge to get them to surgery. And you still have your hepatogastro to prevent cholangitis. So a lot of different options.
Definitely a lot of
options.
Give me some negative. Sorry?
Do you ever place this without a SEMS? Do you ever just place a double pigtail? One of the questions in the audience, do you have hepatogastro with just a double pigtail with no metal stent?
No, I don't think I would, just because I think you're a higher risk for having a leak. It's also harder to sometimes just place a double pigtail through the stomach wall. Stop for a second, Flora. So, I've never done that. I always end up using a metal stent. And now I'm going to be placing a double pigtail. I'm actually using one of these urology stents. It's a 20 centimeter double pigtail stent. So, so we should hopefully get across. And Kelly, you give me some back tension. Perfect. Excellent. I think we're getting close to it. That's one of the marks. And we have one more mark.
Yeah, I agree with you on that. I wouldn't do a double pigtail by itself just because of the risk of occlusion.
Go ahead,
and then
stop
also
pulling.
just kinking of the stent itself. The metal is going to give you a better chance of being paid.
And there
Fantastic.
you go. You see part of it is across the ampulla into the small intestine, and we have the other side here endoscopically that's in the stomach. So we've bridged that area, and it should drain well. Any other questions, guys, about anything? I think initially we started off a little bit rocky with this case, but I think we were able to accomplish what we wanted to accomplish. You're seeing a lot of bile draining now, which is obviously what we want.
Yeah, I think you nailed it.
Perfect. Thank you very much, guys. Her belly's okay. She's doing okay. Anesthesia.
All right, we're going to switch over to lectures here.
What do you think, Junior?
Thank you all for these
belly feels fine. There's a little-
fantastic cases and great demonstrations. We'll jump over to the lecture series.
Hello. Thank you for the opportunity to present today on innovations in biliary endoscopy. I'd like to thank Drs. Kahala and Dr. Tiber for the opportunity to speak to you today on innovations in biliary endoscopy. My name's David Lauren, coming to you from Philadelphia, Pennsylvania. We'll get right into it. EUS-guided lumen-opposing metal stents have seen really a tremendous proliferation in their use throughout the GI tract. But with regard to the biliary tree, we've recently had the evolution of smaller diameter stents becoming available in the United States, and these are being used for colodoco-duodenostomy. The idea behind this is to simplify the procedure, decrease complications, and improve outcomes. And we in the United States can now benefit from a multi-center report from the UK regarding the use of these unique stents for biliary access. This is a retrospective review from 2016 through 2020 of 8 centers and 14 different endoscopists. The lambs diameter that were used were 6, 8, or 10 millimeters, and this was determined at the discretion of the endoscopist, although smaller ducts would typically get the smaller lumen-opposing metal stents. And they looked at outcomes of technical success, meaning the ability to place the lambs and create the colodoco-duodenostomy, and clinical success is defined by the decrement in bilirubin of 50% within 14 days. They describe 2 different techniques, the first of which is that a 19-gauge needle is advanced into the duct, followed by contrast injection, and then guide wire passage, and to use guide wire support throughout the procedure to advance the lumen-opposing stent and then advance it into the duct. In the second, a freehand technique is performed with biliary access directly by the electrocautery-enhanced lambs without a guide wire, although guide wire may be placed within the lambs prior to puncture and then is advanced after access is obtained. Additional stents were placed at the discretion of the endoscopist as needed and clinically indicated at the time of the procedure. I would note that in this study, there was no comment on the method or technique of deployment and fixation of the deployment hub, which can be a challenge for these procedures. They report on 120 patients. This is a large multi-center study, and identified a technical success over 90%. And of those in whom technically successful colodoco-duodenostomies were performed with the lambs, 95% had clinical success with resolution of jaundice and improvement in their bilirubin. Adverse events were what would be expected, around 17.5% for transluminal lumen-opposing metal stent placement and transluminal biliary drainage procedures. Over time, 8% needed a reintervention, most often because of food being lodged within the lumen-opposing metal stent. And it's worth really focusing on these complications because there are alternatives to these procedures, and we need to be familiar with them. Many of the complications were mild or moderate. However, 2 severe complications, including 2 duodenal perforations, one which also had a biliary injury. Both required laparotomy, surgery, biliary bypass. So this procedure is not without its complications and possibly severe complications that can be life-threatening. While similar to biliary access, which is done through the duodenum, there's also been the evolution of transhepatic biliary access, and reports on these have typically been small, but we now have the largest U.S. report of endoscopic transhepatic biliary drainage. This is a single-center, single-physician report, but is very insightful and can really guide us in thinking about this procedure that many of us do who practice therapeutic endoscopic ultrasound-guided procedures. For this procedure, they describe the technique in which all patients have antibiotics and have general anesthesia. The endoscopic ultrasound is used, the linear scope is used in order to identify an adequate caliber duct, and that's somewhat subjective, but I would note in the report larger ducts were more successful than smaller ducts. Doppler flow examination is performed to identify intervening vessels and choose a site for puncture with a 19-gauge needle that has had contrast placed into the needle prior to puncture. Once opacification has occurred and access to the duct is achieved, a guide wire is advanced through the needle. They use 0.2 5-inch guide wires, and then the needle is exchanged for a dilation balloon. When the dilation balloon cannot be advanced, a tapered 543 catheter is used in order to allow for biliary balloon access. Initially, they had abandoned the use. Initially, they had used wire-guided needle knives for this procedure. However, that was abandoned due to complications. Balloons are initially inflated within the duct and then progressively and serially out, including the wall of the lumen that is being used to access the duct. Fully covered self-expandable metal stents are then deployed across the hepatico-enterostomy, and importantly, the stents that they use have anti-migration struts, and these needed to be visible within the lumen to achieve successful placement. Plastic stents were then placed through the metal stents for anchoring and to facilitate drainage of the metal stent. Indications were a combination of malignant, although a significant number of benign patients, about a third of the patients in this large report of 215 patients had benign disease. Many had surgically altered anatomy, as one would expect, as a reason that transpapillary access could not be achieved, and a significant number had prior attempts at alternative methods of accessing the bile duct rather than this EUS-guided approach. Technical success was observed in 99% of patients with placement of a metal stent, and the decrement in bilirubin was seen in almost 90% of patients. Adverse events were somewhat as expected in the 20% range, although serious adverse events did occur, including prolonged ICU stays and a perforation. Biloma was observed as well. What I found particularly interesting in this report was the increased adoption of this procedure over the years of the study, and you can see a significant rise in the number of procedures, but that's not paralleled by the number of complications of adverse events. And this really speaks to the learning curve involved in this procedure and having it performed at a high volume center and gaining the experience to perform this well for patients. And I'll show you this video now out of gastrointestinal endoscopy that demonstrates this technique. What you see is a dilated biliary radical being accessed by the needle. The needle is inserted into the bile duct, and then opacification is performed. And in this case, this patient had had hepatico-jejunostomy with a stricture and stones above. And you'll be able to see the stones opacifying right here. And you can see the stones being opacified. The opacification is continued and a stricture is identified at the hepatico-jejunal anastomosis with only a trickle of contrast getting through. After opacification, a guide wire is advanced through the needle, followed by directly the dilation balloon. Dilation begins within the duct and then is serially performed from the duct out, including the gastric wall. I'll pause here for a moment. You can see the metal stent has now been placed well within the duct, and that's important for maintaining stability, and then out into the lumen. But what you see here is a fair amount of pneumoperitoneum, and this is somewhat common in this type of procedure. You need to be aware of that and recognize this. But we have a bridge into, in this case, the gastric lumen. We'll see what that looks like here in a moment. And on this image, you can see the stent here, although it's not very far into the stomach, and I would be concerned that this would migrate internally. And as a result, a second stent is placed within the first in order to extend it further into the lumen. Now, what is the right way to think about patients? Should we be thinking about biliary access or gastric access? Well, clinical success, they tend to be similar between colodocal access and transgastric or transhepatic access. Similarly, technical success, also similar between the two. However, complications are more common in the transhepatic access group than in the colodocal biliary anastomosis that's performed. And so we should bear this in mind as we consider what we can do for our patients and the approaches that we should use. Now, I'd like to present a report that was recently presented in Video GIE, and this is a really interesting use of biliary magnets. This has been presented rarely in other forum, but we see the evolution of this that's very exciting. This is a 60-year-old patient who had a cholecystectomy complicated by a bile leak from what was thought to be a direct biliary injury, and a fully covered stent was placed into the main duct. However, a biloma developed and there was ongoing concern of drainage. Imaging showed that there was a transected right hepatic duct at the site of the surgical clip, and that's because of this rare anatomy, 2.5% of patients, where the right anterior sectoral ducts come directly into the extrahepatic biliary tree. And so I'll show you this video now of how the authors approach this problem. By showing you the correct video. And now you can see here we have a percutaneous drain coming in with extravasation and opacifying only the right anterior sectoral ducts. On ERCP, the other ducts are able to be opacified, but what you don't see is any communication with this right anterior ductal system. And so we have transection of this duct with a significant distance between the end of that duct and the common bile duct. And so in order to address this, a magnet compression anastomosis technique was used. These are rare earth magnets that have been developed. They're 4 millimeters in diameter, 8 millimeters in length. There's a silk that comes out with a knot at the end, really a suture, and these are used for placement and for retrieval, as you'll see here. And so the device is loaded into a snare. The snare is opened, and the silk knot is grasped with this device, and it is then retracted into the scope for deployment. The magnets will find one another inside of the patient, and that will actually hold them in place. And you can see, even from a distance, that they are attracted to one another. This is the percutaneous deployment. It's placed percutaneously and then followed by a balloon in order to keep it in place with contrast injection afterwards. And then through the previously placed metal stent, a snare is advanced up into the duct above the proximal aspect of the metal stent. That snare has, you could even see it there, the snare has the other magnet attached to it. That's been grasped by that knot, and then it is ultimately deployed under fluoroscopy. You can see it being pushed up here and then released from the snare, and then ultimately those will stay in place by the magnet itself. Abdominal radiographs are obtained for 6 weeks at 2-week intervals, and you can see that they have opposed one another. And then ultimately at 6 weeks, the decision is made to remove these. A scope is advanced through the percutaneous tract, and opacification is performed. The one side, the percutaneous side, is grasped and removed, and then a guide wire is used to try to advance into the duct through the fistula that's now been formed. And you can see that wire advancing here right next to the second magnet. That magnet will ultimately be removed endoscopically as well. And you can see a little bit better that the anastomosis or the fistula that's been created from that excluded injured duct that is now being recanalized here. So the luminal magnet, the one that was placed from transpapillary, is removed with an alligator grasping forceps. Wires are advanced. A stent is placed into the left hepatic duct, and a fully covered self-expanding metal stent is placed into that right duct. This is to avoid any issues of drainage in that left ductal system and avoid that being gelled off. And the right hepatic ductal system is able to be, that anastomosis is able to be dilated now. And you can see initially, again, opacification, stricture, no communication, and now we have a wide open communication at the biliary hilum with recanalization and establishment of a new conduit for drainage of that right sectoral duct. That will conclude my presentation. Thank you for your attention.
You can actually appreciate the vessels and the pit pattern inside the lesion, and actually even see red blood cells moving, actively moving inside those tiny vessels.
Okay, everybody, thanks for having me here. I wish I could be there in person. Again, we're going to be talking about indeterminate biliary strictures, what to do. And again, I'm Doug Adler. I'm the director of the Center for Advanced Therapeutic Endoscopy here in Denver, Colorado. So even in 2022, indeterminate biliary strictures are relatively uncommon. Most biliary strictures have a clear cause. Remember that 85% of all biliary strictures are in fact malignant, and most of the time the cause of a biliary stricture is pretty obvious. Surgery, chronic pancreatitis, right, inflammatory strictures from stones, right? So if you see this, you know that you've clearly identified the cause of a biliary stricture. This is going to be in a patient with an inflammatory stricture. So obviously what we're always wondering, is it cancer, right? So what we're usually coming down to, is it a cholangiocarcinoma or is it pancreatic cancer? Obviously, if it's a cholangiocarcinoma, you're going to be looking for a history of PSC, elevated CA19-9, imaging findings or systemic symptoms that suggest it. Pancreatic cancer in 2022 is pretty easy for us to reliably diagnose, and we're all very comfortable with that. But just recognize that some pancreatic cancers can defy all of our imaging modalities, and every once in a while I will come across a patient with a pancreatic cancer that really was not seen well on any imaging study. This is obviously a video of a large pancreatic head mass with portal vein invasion. You can see that the mass involves the superior mesenteric vein and the portal vein at the confluence there. There's a stent in the bile duct. This is not a diagnostic dilemma. Still, if you are faced with a diagnostic dilemma, you want to use multiple tools for investigation, right? Obviously, we're all going to be using ERCP and all of the modalities that go with it, EUS as well as our cross-sectional imaging studies. That says FNA, and obviously in 2022 that would include FNB. But I think if you're looking for a disease to study indeterminate biliary strictures, there's no better disease than PSC, because it's really the #1 cause of indeterminate biliary strictures. And I will tell you, in my practice, I see a huge volume of people with PSC, and we are always wondering, do they or do they not have bile duct cancer? Obviously, PSC is strongly associated with cholangiocarcinoma. It's also associated with gallbladder cancer, and to a lesser extent, hepatocellular cancer. And unfortunately, we have very little treatment options for these patients. Basically, resection or liver transplant are the only curative options. So when we talk about PSC patients, right, again, our model for the indeterminate stricture, we often talk about the so-called dominant stricture. But if you look in the literature, this is really a nonspecific term that can refer to intra- or extrahepatic strictures that sometimes are and sometimes aren't associated with biliary obstruction. And there's a lot of technical definitions in the literature that I personally don't find helpful at all. This is my definition of a dominant stricture, and that's a dominant stricture is the cholangiographic finding of a stricture that stands out amongst all others in a patient with primary sclerosing cholangitis. And really, right, like anybody should be able to look at a cholangiogram and say, like, well, that's the dominant stricture, right? It's intuitive, it's applicable, it's a little bit subjective, but not so much. So for example, these are all PSC patients I'm going to show. Like, my eye immediately goes to this narrowing in the common hepatic duct. That that was a cholangiocarcinoma. Likewise, in this patient, this is a pretty obvious one. There's a high-grade stricture here with a blowout of the left ducts. There's extensive pruning on the right side. This was also a cholangiocarcinoma. This is unfortunately, this was a young boy whose initial presentation of his PSC was with this cholangiogram, and he had this sort of focal narrowing in his left hepatic duct. It was also a cholangiocarcinoma. Unfortunately, this patient had lung metastases at the time of diagnosis. This is a really interesting one. You can see very extensive pruning and extrahepatic duct dilation, this very ominous stricture here. However, this was benign for the 7 years that I followed this patient. So, when we're thinking about tissue acquisition, right, we have brushings, which I still use in terms of routine cytology. I also do FISH, forceps biopsy, and then I have here EUS-guided FNA, and obviously that should also include EUS-guided FNB. Brushings, as we know, are often neither positive nor negative, but very frequently result in atypical cells. Brushings have a low sensitivity but a high specificity, but they may in fact be less than helpful. I still take brushings all the time because if I get it on the brushing, I've crossed the finish line. Atypical cells, for example, in people with PSC, probably the most common results. Our pathologists recognize that malignancy can be difficult to detect in the setting of severe background inflammation, and you often find yourself chasing your tail and resampling or reevaluating these strictures in these patients again and again while you're worried that they are walking around with a bile duct cancer. Some years ago, Ben Witt and I created the AB score. This was the atypical biliary brushing score, and we showed that a score greater than 4 was statistically associated with malignancy. You can see the score there. So you've got a lot of different ways to get to a score of greater than or equal to 4. So just recognize that, the AB score doesn't prove anything, but if you have an AB score greater than 4, there is a statistical likelihood that the patient does have underlying biliary malignancy. FISH, as you guys all know now, is widely used to evaluate pancreatic biliary cancers in terms of brush cytology. Originally developed for urothelial cancer, obviously this is looking for aneuploidy or trisomies of chromosomes and atypical numbers or anisochromia of certain chromosomes or loci in chromosomes. So this is a negative biliary FISH study, right? The chromosomes marked, 2 reds, 2 greens, 2 blues, right? This is a normal cell. And obviously this is a positive FISH study where there are odd numbers or extra or deleted chromosomes in the cells. So it's amazing to think that FISH studies have to be read by people looking at individual actual cells. FISH can detect polysomy before other tests. About 70% of FISH-positive patients will ultimately be found to have cholangiocarcinoma. Polysomy is pretty decent in terms of sensitivity and specificity. Trisomy and tetrasomy are about similar. I personally think that most, not all, but most patients with PSC should undergo FISH testing at the time of their ERCPs. It's simple, easy to get, and it's cheap, and if your institution can't do it, you can send it out to LabCorp, ARUP, or Mayo Rochester. Cholangioscopy has, in my career, gone from something that we never did to something that we do all the time. We've gone from fiber optics to digital systems, and I think pretty much everybody is using digital spyglass or cholangioscopy in 2022. Here's a nice example of a patient with PSC, and you can see, like, it's really hard to know looking at that. Like, is that a benign stricture? Is that a malignant stricture? And I will tell you that looking at this, I can see features of maybe both. This one's a little easier. This is a patient with PSC who had these sort of concerning papillary projections. Those can sometimes be seen in inflammatory conditions, but this patient did in fact have cancer, and you can see I'm using the miniature forceps to go ahead and do biopsies. Cholangioscopy has pros and cons. It can be very helpful. It allows us to really hyper-target our biopsies or brushings. and it can reveal concerning areas that were unexpected or undetected on cholangiogram. It's pretty quick. We can do it in about 15 to 20 minutes, and you can get reimbursed. And the biopsies are up to about 80% accurate, but in other people's studies, they haven't been quite that good. The downside is it does require additional hardware. There is a learning curve, and many people, when they first get out of training, aren't so comfortable with cholangioscopy. Sometimes, even if you're really skilled at this, it's hard to get ideal imaging. And there is a fair bit of variability in terms of inter-observer agreement regarding findings suggestive of malignancy. Again, if the lesion is obviously a fungating lesion with tumor vessels, so to speak, it's not a diagnostic dilemma, but many of these patients have features of benign and malignant strictures seen cholangioscopically, and it can be tricky. The small forceps biopsies may simply be too small to be able to get enough tissue to allow your pathologist to make a comfortable diagnosis. This is a really old study from Young Chen, who's departed now, and Doug Pleskow, but what they showed very early on in the spyglass era was that there was concordance between visual and biopsy diagnosis in about 75% of patients. And this relates back to the AB score to some extent, meaning the endoscopist impression is important. And if you think something is malignant based on how it looks, there's a really good chance it's malignant. Roy Liu and I published a paper way back in 2014 where we looked at patients with biliary strictures who underwent cholangioscopy looking for malignancy. We found that if you looked at all patients who had pretty good sensitivity and specificity, but positive predictive value was poor, negative predictive value was good. If you just looked in PSC patients, you got an even worse positive predictive value, although your other parameters were about the same. And in non-PSC patients, you did a little bit better. You had 100% sensitivity, 50% positive predictive value, and 100% negative predictive value. So we actually showed that, I think, you've got to look at these patients is whether or not they do or don't have PSC when you're thinking about indeterminate strictures, and recognize that, even cholangioscopy with a digital scope, you may still be wondering after the procedure, well, is it cancer or is it not? EUS for indeterminate biliary strictures, something we use to some extent, mostly to allow for diagnosis and sampling of lymph nodes. That's actually something I just did today. It can allow for diagnosis by FNA or FNB. If you see lymph nodes, it often provides additional data regarding relationship of the bile ducts to the tumor. Cholangiocarcinoma can be difficult to EUS if it's very proximal, and you may have a hard time seeing the lesion well from the proximal duodenum or the stomach. We generally advocate against biopsying primary cholangiocarcinomas for fear of tumor tract seeding. Here's a nice video of a very, very thick bile duct wall in a patient who had an indeterminate stricture in the setting of PSC. This was ultimately found to be cholangiocarcinoma. You can actually see that there's a little bit of ascites around the duct, but as good as this looked, I did not perform FNA or FNB at the time for fear of seeding the needle tract. So stricture management, and indeterminate stricture management and evaluation continues to evolve. I think that, again, unless you have an obvious cause, the threshold for suspicion of cancer should be very low. Consider FISH for any concerning lesion and take those results seriously. Use cholangioscopy. Recognize that it provides a lot of meaningful information, even if it doesn't quite get you a tissue diagnosis. EUS is very helpful in these patients, but FNA or FNB may not be for everyone, i.e. if you just see a primary mass, you think it's cholangio, don't stick it and look for another target like a lymph node. You guys may have noticed that I didn't really bring up things like OCT, right, or some other endocytoscopy technologies. And it's because I didn't want to show you a bunch of data on technologies that never crossed over. And 5 or 10 years ago, everybody was talking about those techniques, and now nobody is because we're just not using them in our practice. They didn't really have enough inter-reader reliability. They never really got reimbursed, and unfortunately, as promising as those technologies were, they didn't cross over. So that's all. I'll mention them there. Thank you again to everybody for inviting me. And again, I wish I could be there with you in person, but perhaps next year. Thanks again.
The EVA 15 insufflator and smoke evacuation system is easy to use, easy to integrate, and cost-effective, and it requires minimal workspace.
And today we will talk about management of bile duct stone burden. These are my disclosures. When we address patients with bile duct stones, we're going to be looking primarily at two characteristics. One is the outlet, and the other one is the stone itself. In the outlet, we will primarily focus on the shape of the bile duct, especially below the stone, as well as that of the ampulla. And in consideration to that, we'll also look at whether the patient has a naive biliary ampulla, or if a sphincterotomy has been performed, and we will also address whether we need to extend the biliary sphincterotomy if it's already existing, perform a sphincteroplasty, etc. When we look at the characteristics of the stone, that will dictate whether we do through the scope or out of the scope lithotripsy, or if we do targeted therapy, and this will be primarily performed once extension of the bile duct or the ampulla or sphincteroplasty have been performed and were not useful. This diagram depicts the outlet that we're going to address in order to manage stones. And below here are defined by circles what would be the papilla, and above are the stones. This can be single, this can be rounded, this can be semi-elliptical, but they are usually small and they are confined to the size of the bile duct without causing any particular occlusion. These are the stones that will be managed primarily with routine methods. These images represent multiple stones that were removed with standard methods, including biliary sphincterotomy, without the need for sphincteroplasty, and the use of either retrieval balloons or retrieval baskets. There will be cases that the stones appear to be relatively simple, but it's not going to be as simple, either because the patient has an intradiverticular papilla, the shape of the stones are odd, there are multiple stones, or there is a possibility that it might be a relatively mild suprapapillary stenosis. However, even in instances in which it appears to be not so simple, like the cholangiogram that you see here, it is possible to perform standard methods even when there are so many stones as shown in this image. And the reason for that is because the shape of the stones in relationship to the distal portion of the bile duct and the suprapapillary area allow for the performance of balloon retrieval or balloon dilation of the papilla or the distal bile duct in order to accomplish the task in hand, as seen on the right-hand cholangiogram that reveals complete removal of the stones. This video shows the cannulation of the bile duct that is completely inside the diverticulum, and cholangiogram reveals a markedly dilated bile duct with a suprapapillary stricture as pointed there by the arrow, and then you see the filling defects. These particular scenarios, they're well treated with sphincteroplasty, which will include a balloon that is inflated to at least 12 millimeters. And this will be performed until the distal portion of the bile duct is completely ablated, so there is no waste. And the sphincteroplasty will be carried out for a minute or two. In my practice, I do for 2 minutes. And then a retrieval balloon will be used to remove the stones. And this usually is accomplished with not too much of an effort once the sphincteroplasty is performed, because the distal portion of the bile duct is completely ablated by the sphincteroplasty. Here you can see the endoscopic image of the stone removal. So if you do ERCP and you are good at it, you will succeed 80% of the time removing bile duct stones using standard methods. When you have difficulty, you can get to pick from: one is what you have available, number two, what you know to use and do, number three, to recognize what you can do, and if necessary, you can seek help. In order to recognize the problem before you do anything, think twice before you act. Number one, assess the size of the problem and outlet, as mentioned before. Set up an action algorithm in your mind to succeed, and anticipate what to do if you do not succeed. This diagram represents the 20% that you may not be able to resolve with standard methodology. And as you can see, this may be either because of the locations of the stone is in the cystic duct or in the intrahepatics. The shape of the stones is odd with jagged edges and sharp, or there are multiple stones in a variety of shapes and sizes. In addition to that, you assess the distal portion of the bile duct as pointed with the larger arrow. Factors associated with complicated biliary stones include periampullary diverticulum, a largely dilated or sigmoid-shaped bile duct, or if the bile duct is angled, altered anatomy, usually surgical, but it may be from duodenal stenosis, patients that have numerous stones greater than 15 millimeters in largest diameter, associated stricture distal to the stone, intrahepatic or cystic duct location, and unusually shaped stones. As you can see in this image, there is a cholangiogram that reveals a dilated bile duct with a distal stricture, multiple stones of different shapes and sizes, and this will be clearly associated with a difficult procedure. One can determine if the index procedure, sphincterotomy and sphincteroplasty, will be sufficient, and then if it's not, it is likely that the patient will require a second intervention, which may in some instances include also mechanical lithotripsy, as pointed in this pyramid. And then it is possible that not until the third intervention that someone may think of including digital cholangioscopy as a form to address these stones that were not being able to be managed otherwise by previous procedures. The difficulty with this approach is that the use of accessories is significantly greater. There is increased cost and there is increased time. Contrary to the pyramid that I showed you in the preceding slide, what I would propose to you is that we invert that approach and we include digital cholangioscopy from the index procedure. By doing so, in addition to the use of extension of sphincterotomy or performance of sphincteroplasty, is that the probability that we will address the stones on the index procedure will be greater, thereby decreasing the use of accessories, decreasing cost, and decreasing time, and expediting the care of the patient and their satisfaction. In order for you to perform cholangioscopy with the idea of doing lithotripsy, you have to have either electrohydraulic lithotripsy, as depicted on the left side of the image, or laser or holmium laser lithotripsy, as the image depicted to the right side. These are the interfaces of the devices that you will utilize, and you can address both separately, but in general, you will adjust the pulses and the power to reach a certain wattage that will reach lithotripsy. In this video, you can see a very large square stone located in the common hepatic duct just before the hilum. Distally, there are larger stones, multiple in size, and there is an associated suprapapillary stricture as pointed there by the arrow. The cholangioscope is inserted over a wire and is advanced to the most proximal of the stones. In this case, we're going to use holmium laser. The fiber is placed in front of the stone and located approximately 1 to 2 millimeters from the tip of the fiber to the stone. And we can fire this either constantly or intermittently by pushing the pedal. We will aim the fiber to the stone, and we're going to fragment this to the smallest possible size. So this will facilitate performance of additional methodology to remove the stones. In a case like this, multiple stones are all fragmented to the smallest possible. We then perform a biliary sphincterotomy. This is after the lithotripsy, and then we can use either standard retrieval balloons to remove the most distal of the stones, and or we can as well perform balloon dilatation of the papilla. You can see here extraction of an initial stone independently, then a sphincteroplasty is being performed, and we will do this for 2 minutes. Then we dilate the suprapapillary portion of the bile duct, and then we will do retrieval of the stones using a standard balloon until the balloon is completely removed, and then until all the stones are cleared from the bile duct, as shown in this cholangiogram, using an occlusion balloon, and all the stones have been removed. And you can see by the arrow that the previously identified suprapapillary stricture has been completely ablated. This case reveals a very large stone that is located at the junction of the cystic duct and the extrahepatic bile duct. You can see a retrieval balloon is being advanced to and fro from the junction of the cystic duct. Proximal to the large stone in the cystic duct, you can see the gallbladder remnant with multiple stones. A cholangioscopy is performed, this time without wire guidance, and it is angled to go into the cystic duct, as shown in this image. The stone is identified, and a lithotripsy is performed with laser. Again, the stones are going to be fragmented to the smallest possible. In this scenario, we are removing, after one session, we are removing distal stones in order to facilitate further lithotripsy with reinsertion of the cholangioscope. Once this is done, then the cystic duct is cleared, and as you can see here, the cystic duct itself, as well as the extrahepatic bile duct, have been cleared, and a large stone in the cystic duct remains. This is a case of, it's an unusual case of a migrated stent and a stone. 32-year-old woman who had a biliary plastic stent for stone disease 7 years prior to this visit. She was lost to follow-up, and she came back with elevated liver enzymes. Cholangiogram revealed a 5 centimeter long stone located in the common hepatic duct and in right hepatic duct with a filling defect in the center of it. Cholangioscopy was performed, and the cholangioscope was advanced to the proximal end of the stone. You can identify here a very large stone, and we're going to use holmium laser lithotripsy starting at 10 watts, and we increased this by 0.2 until the stone was fragmented, and you can see there the distal portion of the stent surrounded by stones. What I did then was to follow the length of the stent and break the stone that was surrounding the stent, and this was carried all the way proximally. In this cholangiogram, you can see that there is significant improvement in the area where the stone was, but the stent was proximal to the stone and could not be removed during this initial procedure. Because of logistics, the patient was brought back 10 months later, and again, cholangioscopy with lithotripsy was performed. When we did this procedure, we did not have available any through the cholangioscope tools to remove objects, so we used a grasper that we guided fluoroscopically, and you can see here removal of the bile duct stone and removal of the stent with a grasper. Once this was performed, an occlusion cholangiogram was performed, and you can see that the stone has been resolved, and there is no further stricture. To ensure that there was complete clearance of the bile duct, we then reinserted the cholangioscope into the right hepatic duct. As you can see here, there is evidence of a very small stone that will pass by itself without the need of any further intervention. You can see the area where the stone was located, which characteristically causes some epithelial injury, and this is where the stone and the stent were impacted. And you can see that epithelial injury, which is acute and will resolve by itself. Since the removal of the stone and the stent, the patient has been asymptomatic. To conclude, when you address patients with biliary stones, regardless of location of the stone, one is address what you have available. Number two, what is clinically present, what the cholangiogram is showing you, and what you are able to do for this patient. That will equate to the intervention most appropriate to address the scenario. Number three, consider all options before you act, and always have a rescue plan available. Thank you for your attention.
Thank you very much, Mr. Chairperson, and thanks to Michelle and Amy to having me again. It's a great honor to join here. As always, we really enjoy to meet, discuss, and drinking each other. Cholangioscopy provides direct visualization of the biliary tree for diagnostic and therapeutic procedures. New types of cholangioscopy is a single operator system like a spyglass or direct POC. Increasing diagnostic performance of POC can be possible by high quality endoscopic imaging, ease performance of enhanced endoscopy, and effective tissue sampling. Narrowband imaging shows detailed images of the surface structure and microvessels. This video shows a luminal obstructive mass lesion on the proximal CBD. Looks like a colon cancer. MBI clearly showed the margins and the surface structure of the lesion. This case remained as indeterminate biliary stricture even after POC. But after MBI examination, it revealed as malignant biliary stricture. Adenocarcinoma was confirmed after biopsy. Very recently, we did a study for the efficacy of MBI during POC to predict malignancy of indeterminate biliary strictures. As a result, MBI showed higher accuracy and visualization quality than white light imaging for the evaluation of biliary strictures. As you know it, the prognosis of cholangiocarcinoma remains poor. It is necessary to diagnose early-stage cancer for curative surgical resection. As like a routine gastro and colonoscopy, screening for cholangioscopy can be helpful to detect neoplastic bile duct lesions, including early-stage cholangiocarcinoma, especially for high-risk patients. Let me show a case. For this patient having CBD stones, direct POC was performed after stone removal. Multibanding ultra-slim scope is inserted inside the bile duct without accessories. During POC, luminal protruding papillary mass lesion was seen incidentally. MBI and forceps biopsy on direct visualization was done. Histopathology result revealed adenocarcinoma. So we did a study whether direct POC could be used to screen for neoplastic bile duct lesions in patients with bile duct stones. The primary outcome was the detection rate of intraductal neoplastic bile duct lesions after bile duct stone removal. As a result, 31 patients exhibited abnormal intraductal mucosal lesions. Among them, 7 patients diagnosed as intraductal neoplastic bile duct lesions, including 4 cases of cholangiocarcinoma. Curative surgical resection was performed for the 5 patients. Abnormal intraductal mucosal lesions were classified as like these by white light imaging and MBI on POC. This case showed a polypoid neoplastic bile duct lesion on POC after bile duct stone removal. Targeted biopsy was done on direct visualization. Biopsy on the direct visualization showed an adenoma with low-grade dysplasia. This patient had a flat elevated lesion on the CBD, such as a flat adenoma on the stomach. MBI shows better imaging of the margin and the surface structure. Histopathologic finding shows high-grade dysplasia. Next case shows granular lesions on the bile duct. MBI demonstrates better images of the surface, microvessels, and margin. Histopathology revealed adenocarcinoma. However, blood and bile juice can interfere with MBI observation. Comparing with MBI, digital enhanced endoscopy like eye scan and FICE are less affected by the bile or blood. This video shows very beautiful endoscopic imaging of normal bile duct around the hilum. This is an eye scan image. You can see fine surface vascular network shows clearly. Digital zooming is also possible like this. Very nice view. And also, eye scan can be performed during zooming. Let me show a case. You can see a luminal obstructive mass lesion on the proximal bile duct. And this is eye scan image. You can also see normal inner surface of bile duct. Eye scan provides detailed findings of the surface structure and microvessels and margin of the lesion. Some interventions can be possible on spyglass. Endoscopic lithotripsy can be the most common interventional procedure. Morici syndrome type 2 can be managed by POC in selected cases. Let me show a case of typical Morici syndrome type 2. Direct POC was performed for laser lithotripsy. Endoscopic view shows luminal obstructing eroded stone from cystic duct. For this time, Freddy laser lithotripsy was performed. And then fragmented stones were extracted under conventional ERCP. Intrahepatic duct stones is difficult to manage by POC, but POC can be possible to some selected cases. This patient shows huge CBD and also intrahepatic duct stones. At first, CBD stone was fragmented by EHL. But intrahepatic duct stones are still remained. And we did the POC for the removal of intrahepatic duct stones on direct visualization. Endoscopic ablation using phorodynamic therapy can be possible on spyglass DS. Cholangioscopy shows a obstructing mass lesion in the proximal bile duct. And PDT was performed on POC. Also, RFA on spyglass DS can be possible in near future using Habib catheter from Boston Scientific. Therapeutic interventions can be expanded beyond lithotripsy. With the newly developed spikeless retrieval basket or snare, therapeutic interventions will be increased. Let me show a case. After removal of stone with mechanical lithotripsy, spikeless POC was done for any remnant stones. You can see fragment stones in bile duct, and stone was captured with a basket on direct visualization and removed it slowly from the bile duct. The endoscopic view shows removal of stone with basket on spy scope. Interventional performance of POC can be increased by larger walking channel and new accessories. Therapeutic interventions of direct POC can be more expanded than other types of POC. Endoscopic drainage can be performed by using a 5 French or 6 French stent, especially for patient needs selective guide wire access. Endoscopic metal stenting also can be possible on direct visualization. Endoscopic view shows insertion of small version of metal stent over guide wire. And you can see the deployment of metal stent on direct visualization inside the bile duct. It showed a beautifully deployed metal stent. Endoscopic resection for biliary tumor may be feasible by POC in the future. For this patient, a small polypoid lesion was revealed on the proximal CBD. MBI applied immediately and clearly showed the margin and surface structure of the lesion. Polypectomy on direct visualization was performed. Very rarely, but this report by Dr. Boehner showed endobiliary snare polypectomy by direct POC. There was a case of endoscopic mucosal resection for bile duct cancer under direct POC. Endoscopic ablation therapy is another promising procedure for the treatment of biliary tumor under POC. Algon plasma coagulation, APC, is an effective ablation method. For this case, APC was performed for endoscopic ablation for this flat elevated biliary tumor. Cholangioscopy shows a lumen obstructing mass lesion in the proximal CBD. First trial PDT was performed under direct POC. During follow-up, the tumor mass remained, especially the distal part of the lesion. We therefore performed a second round of the PDT. And finally, follow-up cholangioscopy showed the complete ablation of the mass. Also, we are developing 6 French RFA catheter for oral cholangioscopy control of RFA. You can see luminal obstructing mass lesion on POC. RFA catheter is inserting on mass through the walking channel. RFA can be done on direct visualization of cholangiocarcinoma. In conclusion, for oral cholangioscopy is useful endoscopy for managing biliary lesions. With the introduction of single operator cholangioscopy, diagnostic and therapeutic roles of POC is expanding. The future of interventional biliary endoscopy can be done on direct visualization. Thank you for your very kind attention.
S-Path Pre-Mounted Biliary Stent System by EndoGI, the simple way to facilitate multiple stent deployment.
Okay, first of all, I would like to thank the opportunity to be part of this fantastic MAGIC event and mostly to talk about one of my favorite topics, which is advanced imaging for the management of pancreatic cancer. What is important is to take into account how important is pancreatic cancer today in a clinical practice, mostly to all of us that are managing AUS cases, treating patients with pancreatic diseases, because this is a dismal disease. We know that it's one of the most important tumors, advancing incidence with a low expectancy of life. Today is considered to be the fourth cause of death by cancer in Europe, and the survival is really terrible. And of course, we need to do a lot of things to try to increase the expectancy of life and the quality of life, and how to manage patients with this real problem, which is pancreatic cancer. And in this setting, one of the biggest things that has started to make a little change, but a good change, to try to optimize the management or the outcome of these patients is endoscopic ultrasound. And we know that these four main areas in which AUS has really made an advance in the management of this disease. One is because it is considered to be the best technique for the detection of solid pancreatic tumors, the most accurate one, mostly when we want to detect the small lesions. That is our goal, to try to detect resectable lesions. Then because it's key, today is key for the differential diagnosis and to differentiate between different types of solid pancreatic tumors. And in this setting is the key role of tissue acquisition, that we all know that AUS-guided tissue acquisition is the way to go when we try to sample a pancreatic tumor. And in this setting is one of the key points for advanced imaging. Then we can move that not only for the detection and to differentiate between different types of tumors, that's also key for the local staging, and it's absolutely complementary to multi-detector CT scan. And this is another of the things that we will manage with advanced imaging. And finally, with the latest advances in the scopes, in the systems, but also in the devices, it is bringing a therapeutic option for biliary drainage, for gastrointestinal anastomosis, but also for local therapies. But we'll focus on what is the role of advanced imaging associated to AUS in the management of pancreatic cancer in this whole setting, where it will be in differential diagnosis and in local staging of pancreatic tumors. But what is advanced imaging? Advanced imaging is mainly two techniques. One is elastography, that is going to be able to evaluate the stiffness of the tissue by its response to the compression that we do with the scope, but also with the surrounding organs, maybe for the aorta, we will see. And also about vascularization. So we know that we can also give contrast agents that is going to increase the diagnostic capabilities of AUS related to advanced techniques and advanced softwares that we have available. And look, just to give you an idea on what has been the evolution of this technique over the years, when AUS started in 1987, 1986, is when Maradona scored the goal with the hand. Today, with the VAR, 2022, this would be absolutely impossible. And this is how technique has evolved over the years and how imaging, advanced imaging has evolved over the years. But let's try to talk a little bit about what is advanced imaging and what is the background of this advanced imaging. And we will start with AUS-guided elastography. We know that we have two types of elastography. One is a strain elastography that is going to evaluate the relative stiffness of tissue by its response to compression. So this is going to be translated into different color patterns. And we know that when we see a blue color, it's going to correspond to hard tissue, whereas when we see a soft tissue, this is going to be a red color. So this is not only the patterns, which we consider as the qualitative elasto, but we also are able to quantify by the strain ratio and the strain histogram. So it's very nice that we have the combination of the color patterns, very important to interpret it, but also with the possibility to quantify. Of course, you are listening that there is a new technique on elasto coming into the field of the US, which is the shear wave elastography. But I think honestly that we have scanned data to try to place this new elasto technique as a standard of care in the management of pancreatic tumors, or probably on any indication. We still need to work, and we will see that we do not have enough data today. But what are the patterns? How do we interpret the elasto evaluation when we face a pancreatic tumor? And this is summarized in this figure. So this is how we are going to see the normal pancreas as a homogeneous blue pattern, green pattern, sometimes with a little bit of red inside. And look, the difference with an inflammatory disease is an heterogeneous green predominant pattern with some slight hard areas inside, but not predominantly. So we can move to malignancy, and malignancy is when we see this blue predominant pattern. So this is the interpretation when we do an elasto evaluation. When we go to the quantification, we know that the benign diseases are mostly related to an strain ratio below 10 and an strain histogram over 50. And in the other hand, when we face a malignant lesion, we are going to see a high strain ratio, but in the other hand, we are going to see a low strain histogram. And these are the interpretation that we need to do when we look into an elastographic evaluation facing a pancreatic solid tumor. But what is very important is to understand what is the technique. And I just brought some examples that are key to be able to try to increase your capabilities when you use this technique to detect or to differentiate between different tumors. Look, you can see in B mode that this can be any lesion, but it can absolutely be a pancreatic malignant tumor. But when we move to elasto, we see that this is a green pattern. So listen, this was finally a G1 benign endocrine tumor, and this is defined by the presence of a low proliferation index. That means that we do not have so many cells. That means that the density of cells is low, so we can really compress the tumor, and that's why we consider this lesion to be soft. On the other hand, we see this lesion here that tend to be blue. We make a biopsy, tend to be a G3 neuroendocrine tumor. That means malignant. That means high proliferation, high number of mitosis, and what happens? If you have a lot of cells, it is going to be almost impossible to compress, and the behavior is going to be as a hard lesion, and this is related to this malignant potential. And then we move to the benign condition, which is chronic pancreatitis with calcifications, which is probably the lesion that is most complicated to understand when we manage. But why? Because when we see calcifications, this is going to be very hard. And how are we going to see calcifications? Blue, of course. There is nothing harder than calcium, and calcium is going to be blue. So in this condition, we just need to focus in the interpretation of the areas without calcifications. And this example is very nice because this is a small blue spot with no calcifications. We target with FNA, and these tend to be adenocarcinoma, small adenocarcinoma in the setting of a chronic pancreatitis. But the important area is this one, not the calcifications that, of course, are going to be blue. So with this background and this understanding of the patterns of elasto and the management that I told you before about the quantification, the next step is go to contrast enhanced harmonic KUS. So this is a technique that is going to allow real-time assessment of microcirculation and perfusion. So the main goal is to better align focal lesions, to be able to do a microvascular evaluation, and at the end, we are going to be able also to assess some therapeutic procedures. I just brought here the contrast agent that we mainly use in Europe, which is Sonoview, and just two important messages. What we need to interpret is just 1 minute. The first 30 seconds will belong to the arterial phase, and the second part will belong to the venous phase. And remember that when we are managing, in this case, pancreatic tumors, we are not going to have the portal phase. So this is just the evaluation of 1 minute to see how the tumor uptakes contrast and how the contrast is washed out. A very important trick for optimizing the imaging is that we need to administer the contrast directly into the vein, avoiding any kind of curve that it would be potentially have the problem of destroying the bubbles. And what we are going to see mostly is 3 different patterns. One is the hypovascular, that is mostly related to pancreatic cancer. The second one is the hypervascular uptake. This is mostly related to neuroendocrine tumors, but also to some metastatic diseases. And finally, the isobascular pattern that is mostly related to inflammatory conditions, to chronic pancreatitis, and among all the cases of chronic pancreatitis is very typical for autoimmune pancreatitis. And these are the patterns, the vascular patterns that have been defined when we do a contrast-enhanced harmonic AUS. But come on, what are the role, what is the accuracy, how it behaves when we manage pancreatic tumors? Look, when we talk about AUS-guided elastography, these are the patterns that we have already commented. Here we have a couple of examples of pancreatic adenocarcinoma. This is an example of the previous case of a G1 neuroendocrine tumor. This is the typical heterogeneous green predominant pattern for chronic pancreatitis. Another case of chronic pancreatitis, the previous case of a small foci of carcinoma in the setting of chronic pancreatitis. These are some of the examples on how we manage pancreatic tumors based on AUS-guided elastography. And with these patterns, we found in a lot of data coming from the literature that this is a very sensitive technique, both with the quantification, but also with the qualitative evaluation based on the patterns. But there is still a little bit of lack of specificity, but this is mostly related for the interpretation of the cases that I previously commented, which is calcific chronic pancreatitis, and the other one is for this as the interpretation of the neuroendocrine tumors. But if we summarize the accuracy of this technique when managing solid pancreatic tumors, look, qualitative AUS-guided elastography has a sensitivity ranging from 80 to 100%, really very good for the detection of malignancy, and still we need to improve in terms of specificity. When we move to the quantification, for the quantitative elasto, this sensitivity remains very nice, ranging from 67 to 100%, but mostly close to 90%. And again, a little bit of lack of specificity that we still need to work to try to improve. And I cannot bring enough data on shear wave elastography because I think it's a too young technique that deserves more studies to be able to place it in the management, in the clinical routine of solid pancreatic tumors. But it's not only to differentiate between benign from malignant tumors, but it's also its role for the staging, but mostly for vascular staging. And you can see here in these examples from the study from Yamada, how very nice we can see the separation between the vessel and the tumor in this case, and how we can see the tumor growing into the vessel in this other case. And we know that when we use AUS-guided elastography for staging, we can increase the accuracy as compared to beam mode, but we can even increase the accuracy as compared to the dynamic CT, to multi-detector CT scan. So this really increases our capability for the vascular staging. So for determining the resectability of the tumor as compared to other techniques. But probably the best thing is not to compare, it's just to put them together to try to increase our accuracy in this setting. If we move to the accuracy of contrast enhanced harmonic AUS, we know from the literature that the accuracy for the detection of the diagnosis of pancreatic adenocarcinoma, when we see an hypovascular pattern, the sensitivity, specificity, and accuracy is around 90%, really very good, in some cases even higher than what we obtain for the AUS-guided tissue acquisition. But also the patterns that we commented before and are also very helpful to try to classify the different tumors. So as commented, hypovascular is mostly related to pancreatic cancer, but NETs are usually hypervascular. Metastases are also very common hypervascular. So in this setting, it's very important to know the clinical picture, the clinical history of the patient. And inflammatory masses are mostly isobascular when we use contrast enhancement. In fact, if we bring the data of the latest meta-analysis, showed a sensitivity of 93% and a specificity of 80% as the ability for the diagnosis of pancreatic cancer. So really very good values, very good information obtained with this technique, try to optimize the detection and the diagnosis of pancreatic cancer. But it's not only the role for the detection or the diagnosis of pancreatic cancer, again, also for staging. And this is a fantastic study published in GI Endoscopy 2021, including more than 400 patients, trying to evaluate the accuracy of the different techniques for staging. But for me, the big message of this study, look, 2% of patients with a theoretically resectable tumor, just contrast-enhanced AUS detected the presence of metastasis in the liver. So today, in a clinical routine, we are starting to use contrast enhancement to try to evaluate the liver when we stage a pancreatic cancer, trying to increase the detection rate for very small lesions like these ones that you can see in this example. So we can really change completely the management of the tumor, providing the better treatment option in each case. But what happens if we have two techniques and we put them together? So this is the message that I try to bring with these fun images from the Avengers and Star Wars and DC Comics and the Warriors, that if you put efforts together, you are going to succeed almost in every single case. And look, we have been part of a couple of studies. One is absolutely conducted in my center, and the other one, we've been part of a multi-center trial in Europe. And when we combine elasto and contrast enhancement, our accuracy to differentiate between benign and malignant tumors in the pancreas really increases a lot, providing the best approach in the differential diagnosis of solid pancreatic tumors. And probably we will work and try to show up that this combination is also going to be very helpful in the staging strategy. For instance, just to bring some examples, this is a blue lesion, but combining with the contrast enhanced evaluation, we decided to switch, and this lesion turned to be finally a metastasis from a lung cancer. This is the typical pattern of a benign neuroendocrine tumor when we combine both techniques, and this is the typical example of a blue lesion with an hypovascular pattern, typical for pancreatic cancer. So what are my take-home messages? I think that AUS is an essential technique for the management of pancreatic diseases, among them for optimizing the management of pancreatic cancer. AUS-guided advanced imaging, and we're talking about the last one, contrast enhancement, have even improved the usefulness of this technique in pancreatic solid lesions. And there is always an improving with new options and new technologies associated to the techniques, and I'm sure that we will have some new ones coming in the field of the US in the near future. But probably one of the most important messages, it is very important, this needs to be learned. So this needs to be trained. It's not like pressing a button, I have the colors. There is a lot of need to train to try to obtain the best from these techniques. And just invite you to Santiago, invite you to the upcoming events in the field of the US. That is a very good opportunity to learn more and more and more. And again, thank you very much for your attention, and open for the Q&A.
My name is Mandeep Sawhney. I'm a gastroenterologist at the Beth Israel Deaconess Medical Center and Harvard Medical School in Boston. It's my pleasure to talk to you about pancreatic cancer screening, overview, and emerging role of biomarkers. These are my disclosures. We'll talk about pancreatic cancer screening with regard to who should and who should not undergo screening, how should screening be performed, what are the outcomes and limitations of our current screening protocols, and then end with the emerging role of biomarkers in pancreatic cancer screening. Presently, pancreatic cancer is the fourth most common cause of cancer death in the United States for both men and women. The overall 5-year survival of pancreatic cancer is a dismal less than 10%. The lifetime risk of an average individual developing pancreatic cancer is about 1.6%. It's more common in men compared to women, blacks compared to whites, US and Western Europe than in East Asia and Sub-Saharan Africa. And it's really the only common cancer for which we don't have an early detection or screening strategy. And if that was not depressing enough, it's expected by the year 2030, pancreatic cancer is going to become the second most common cause of cancer death in the United States. And that's a combination of an increase in the incidence of pancreatic cancer coupled with a decrease in incidence of most other cancers. These are cancer outcomes for the last 40 years, and you can see that with most other cancers, we've made good progress. But unfortunately for pancreatic cancer, we've barely budged the line. So a skeptic would ask, would it even matter, or would it even help to screen for pancreatic cancer? One of the reasons why our outcomes with pancreatic cancer are so poor is that by the time patients develop symptoms, they already have advanced disease. And at the time of diagnosis, almost 80% of patients will have advanced or metastatic disease. But there is some good news. These are data from the Japanese study group of early detection of pancreatic cancer. This is a study of over 7,000 cancers. And the two things that I wanted to show you was, one, is that early cancers, stage 0 cancers or carcinoma in situ, account for only 0.7% of all cancers, and then stage 1 cancers, where the tumor size is less than 2 centimeters, account for only 3% of cancers. But if you were to catch pancreatic cancer at this stage, excellent 5-year and even 10-year survival is possible. So if we were to be able to diagnose pancreatic cancer at a very early stage, we could have excellent outcomes. So these are the challenges that we face when we're screening pancreatic cancer. The first major challenge is that the precursor lesion cannot be clinically detected. It's a very rapidly progressing cancer. The window of opportunity to diagnose a treatable cancer is very small. And then finally, pancreatic cancer, despite its very large footprint with regard to cancer deaths, is in and of itself a fairly rare disease. So the first challenge we'll talk about is the pancreatic cancer precursor lesions. There are 2 pathways by which patients develop pancreatic cancer. The vast majority of patients, almost 90% of pancreatic cancers, will develop via the PANIN pathway, and then about 10% of pancreatic cancers develop via cysts or the IPMN pathway. So when you look at the precursor lesion PANIN or pancreatic intraepithelial neoplasm, it's microscopic. Patients are asymptomatic, and the lesion is so small that it cannot be detected by any of our imaging procedures today. We recognize PANINs as low-grade PANIN and high-grade PANINs. Low-grade PANINs are very common after the age of 50. They're almost ubiquitous. And only a very small fraction of these low-grade PANINs would progress to cancer. So even if you had a marker for PANINs, it would have to be specific for high-grade PANINs. Otherwise, it would wash out in the sea of low-grade PANINs that we see in almost all patients as they grow older. The second challenge is that it's a very rapidly progressing disease, and there are several models that have demonstrated that. This is a very nice study by the Mayo group, Dr. Chari's group. They took 128 patients who happened to have had CAT scans done up to 3 years prior to the diagnosis of pancreatitis, and then they had a radiologist look back in hindsight at these CT scans to see how often they were abnormal. So the first thing they noticed was that when a CT scan was done 2 to 3 years prior to the diagnosis of pancreatic cancer, it was abnormal only 16% of the time. However, when it was done 3 to 6 months prior to the diagnosis of pancreatic cancer, in almost 85% of the CAT scans, the radiologist was able to pick up signs of pancreatic cancer that were not picked up by the initial radiologist. So based on that, they computed a model to determine how rapidly pancreatic cancer progresses through its various stages, and it looks like within 12 months it goes from being barely visible, where all you can see on a CAT scan is mild dilation of the main pancreatic duct, to 12 months later when it becomes metastatic disease. So the window of opportunity to diagnose pancreatic cancer at an early treatable stage is well below 12 months. The third problem is that pancreatic cancer is a rare disease. So if you look at the current prevalence of pancreatic cancer, which is 13 per 100,000 population, and even if we had a test that was 100% sensitive and 99% specific, if we were to screen 100,000 patients, we would get 13 true positives, but unfortunately we would get 1,000 false positives. If somehow we were able to narrow this population down, select a more high-risk population where the prevalence of disease was 13 in 10,000, and we used the same test, then things would be a little more manageable. We would get 13 true positives and 99 false positives. And if we hit a home run where we were able to do very targeted pancreatic cancer screening where the prevalence of disease was almost 1.3%, we would have excellent outcomes. So unfortunately, in our current population where the prevalence of disease is extremely low, the U.S. Preventative Services Task Force in their 2019 guidelines gave pancreatic cancer a D recommendation, which is an unequivocal recommendation as to not to screen. So currently, we do not screen asymptomatic average risk adults for pancreatic cancer. So the way we approach pancreatic cancer screening is to identify high-risk populations and then further enrich that high-risk population for pancreatic cancer. This is the DEF model that Suresh Chari's group has as proposed. And the idea here is DEF, D-E-F. D stands for define a high-risk group. E, enrich it further using biomarkers or other tests for pancreatic cancer. And then finally, when you land up with a group that is at very high risk of pancreatic cancer, then you can deploy an imaging modality and then biopsies to confirm the disease. So the way we stratify the population for pancreatic cancer is those who are at average risk, and that's the general population. Then you have patients who are low to moderately increased risk of pancreatic cancer. These are smokers, those who are obese, those who have long-standing diabetes. Each of these conditions will about double the risk of pancreatic cancer compared to the average risk population, but even these conditions do not rise to the level where pancreatic cancer screening is feasible. It's only the high-risk group, which are patients who have genetic susceptibility to pancreatic cancer, or those who have very strong family history of pancreatic cancer, or those who have new onset diabetes along with some other risk factors that fall into this very high-risk group, that will benefit from screening with the imaging modalities and endoscopy. So what is the status of pancreatic cancer screening in 2020? So currently, pancreatic cancer screening is limited to only high-risk individuals with genetic susceptibility to pancreatic cancer. As we talked about, the lifetime risk of pancreatic cancer is about 1.6% for an average risk individual. And so currently, screening is recommended only for those where that risk is 5-fold higher or where the lifetime risk exceeds 5%. And only 5 or 10% of all pancreatic cancers have such genetic susceptibility. So even if the screening programs that we're talking about work perfectly, we would only be able to impact 5 or 10% of all pancreatic cancers. So currently, pancreatic cancer screening for high-risk individuals is approved, is endorsed by several of the GI societies, including the International Cancer of the Pancreas Consortium. So who do we screen for pancreatic cancer in 2022? So we screen patients with Peutz-Jeghers syndrome and familial atypical multiple mole melanoma syndrome. Patients with these two conditions are at very high risk of pancreatic cancer. We screen them regardless of whether they have a family history of pancreatic cancer or not, and we start screening at the age of 50. Patients with Lynch syndrome are also at increased risk of pancreatic cancer. We screen them only if they have a family history of pancreatic cancer, and we typically start at the ages of 45 or 50. Patients with BRCA1 or 2 mutations is somewhat controversial. Most guidelines recommend screening only those who have a family history of pancreatic cancer, but the most recent American Society for Gastrointestinal Endoscopy guidelines have changed that and have recommended that all patients with BRCA pathogenic variant should be considered for pancreatic cancer screening regardless of family history or not. And just to complete the list, we also screen those who have ATM mutation and those with hereditary pancreatitis. The other major group of patients that we screen are those with familial pancreatic cancer syndrome. It's often abbreviated as FPC. So this is an inherited predisposition based on family clustering. The specific gene for this condition has not been identified. So this condition, FPC, is defined clinically as a family where there's a pair of first-degree relatives with pancreatic cancer in the absence of a known genetic mutation. And you can see the more first-degree relatives there are with pancreatic cancer, the higher the risk of this family of developing pancreatic cancer is. So how do we screen for pancreatic cancer? We screen using endoscopic ultrasound and MRI. Endoscopic ultrasound is highly accurate, especially for solid lesions that we care about the most. As you know, it also has the ability to obtain a tissue biopsy. However, it's invasive and operator dependent. An MRI is also accurate, especially for cystic lesions, and it's non-invasive. Unfortunately, you cannot obtain a biopsy, and it's like EUS, an operator-dependent modality. CT scans are not recommended for pancreatic cancer screening due to radiation and low accuracy for small lesions of the pancreas. We currently recommend that pancreatic cancer screening be conducted annually, and then most experts would alternate between endoscopic ultrasound and MRI on an annual basis. So what is the diagnostic yield of screening high-risk individuals? This is a meta-analysis by Mike Wallace's group, and they looked at high-risk lesions like pancreatic cancer, high-grade dysplasia, or high-grade PANN. 19 studies were included in the meta-analysis, and the yield for these high-grade lesions is 0.74 lesions per 100 patient years screened. Number needed to screen to detect one high-risk lesion is 135. The number needed to screen to prevent one pancreatic cancer death is between 253 and 281, and that stacks very favorably when you compare to mammography and stool hemocults screening tests that we are routinely doing in current practice. There are several studies that have showed that screening results in a stage shift. This is a meta-analysis that was published by the U.S. Preventative Services Task Force. They looked at 13 studies in which over 1,000 high-risk patients underwent screening. The yield of finding pancreatic cancer was 1.5%, and the proportion of cancers as a result of screening that was surgically resectable was 66%. And if you remember, if you look at the symptom-detected pancreatic cancers, only 19% are resectable. However, 66% of screen-detected pancreatic cancers are resectable, suggesting that screening does result in a stage shift and hopefully in improved outcomes. And finally, we do have some studies that have looked at the outcome of screen-detected pancreatic cancers, showing that they are improved. So this is one of the largest and longest-running studies, the CAP study, 354 high-risk individuals who underwent pancreatic cancer screening. Follow-up here is about 5.6 years. Progression to cancer or high-grade dysplasia occurred at about 1.6% per year. There were 10 screen-detected pancreatic cancers in the study, and then 4 sporadic cancers developed in patients who stopped screening or were non-compliant with screening. And you can see that the 3-year survival of screen-detected pancreatic cancers was 85% compared to 25% of patients who stopped screening. The overall 5-year survival was 60%, which is many-fold higher than what's reported in the literature for symptom-detected pancreatic cancers. And then earlier this year, this group published their follow-up data of this cohort and reported that the 5-year survival of screen-detected pancreatic cancers was 73%, and the median overall survival of patients who were diagnosed with screen-detected pancreatic cancer was 9.8 years, which are all excellent results. These are results of pancreatic cancer screening in individuals with familial atypical multiple mole melanoma syndrome. These are patients who have the Dutch founder mutation in the CDKN2A gene, also called the P16 Leiden. And these patients have been followed for 5.6 years. This is a large cohort of over 300 patients. The incidence of pancreatic cancer in this cohort is extremely high, as one would expect with a CDKN2A mutation. 20% of patients, almost 1 in 5 by the age of 70, develop pancreatic cancer. And the results of this screening study is very positive. 83% of all pancreatic cancers that were diagnosed as a result of screening were resectable, and almost 1/3 of all pancreatic cancers that were diagnosed with screening are stage 1. And then you can see survival of patients with pancreatic cancer. The line in red are the patients who were diagnosed in the last decade, and you can see the overall survival is 40%. Not as good as the CAP study, but again, many-fold higher than what has been reported for symptom-detected pancreatic cancers. Several studies have also pointed out the limitations of our current screening protocols. In this particular study by Overbeek and colleagues that was published in Gastroenterology this year, looks at interval cancers, cancers that develop within a screening population. These authors followed over 2,000 high-risk individuals who were undergoing pancreatic cancer screening at 16 international sites. 1% of these patients progressed to cancer or high-grade dysplasia at 29-month follow-up. Of these cancers, 46% of cancers had a normal prior exam, and that exam was done only a median of 11 months before they were diagnosed with pancreatic cancer. The median size of the pancreatic cancer lesion was 15 millimeters, and most of them were solid. And unfortunately, in this study, over 70% of the screen-detected pancreatic cancers were already beyond T1, N0, M0 stage by the time they were diagnosed. So these authors concluded again, like previous authors, that pancreatic cancer is a rapidly progressing disease, and the window of opportunity to diagnose an early, highly treatable pancreatic cancer is very small. And they also suggested that our current screening techniques may not be sensitive enough to pick up these very early, subtle pancreatic cancers. Another study looked at late-stage pancreatic cancers that were diagnosed with screening. This is a meta-analysis published in 2022 in Gastroenterology by the Yale Group. This is a meta-analysis of 13 studies in patients undergoing pancreatic cancer screening. Over 2,000 high-risk individuals were followed in the study. The cumulative incidence of all pancreatic cancers diagnosed as a result of screening was 3.3. The cumulative incidence of late-stage pancreatic cancers was 1.7. So you can see more than half of all screen-detected pancreatic cancers were late-stage. 58.5% of all screen-detected pancreatic cancers were beyond the T1, N0, M0 stage. And then you can see over here that 41% of cancers discovered as a result of screening are early, but all the other cancers are at least T2 or more delayed stages. So let's talk about the role of biomarkers in pancreatic cancer screening, and we've already alluded to some of the role that biomarkers could play. Biomarkers could be very helpful in identifying individuals who are at high risk of developing pancreatic cancer. They may be helpful in enriching these high-risk cohorts so we can highly target our pancreatic cancer screening modalities. These may identify high-risk precursor lesions like a high-grade pannin, which currently we cannot identify by any of our imaging modalities. And finally, in conjunction with EUS and MRI, these biomarkers may reduce the incidence of interval and late-stage cancers that we're seeing with alarming frequency in our screening population. So the first biomarker we'll talk about is CA19-9. This is carbohydrate antigen, and we're all familiar with this. This was first identified in 1979. For all pancreatic cancers, this is relatively modest sensitivity and specificity of 79% and 82%. For early stage pancreatic cancer, the sensitivity is quite poor, somewhere in the range of 25 to 50%. And then we're also well aware that it can be elevated as a false positive in non-malignant biliary obstruction. Another disadvantage of this biomarker is that 5 to 10% of the population lacks genes encoding for Lewis blood group antigen, and therefore these patients do not elevate their CA19-9. The second biomarker we'll talk about is fasting blood sugar or hemoglobin A1C to diagnose new onset diabetes. This is based on elegant observation done by Suresh Jari's group from Mayo Clinic, when they recognized that as early as 3 years prior to the diagnosis of pancreatic cancer, patients who went on to develop pancreatic cancer developed hyperglycemia at a much higher rate than controls. And so, as we're well aware, that new onset diabetes can sometimes give us a clue to an impending pancreatic cancer diagnosis. And they have further refined this by adding to it the NPAC score, which suggests that along with new onset diabetes, patients who experience weight loss, who have severe diabetes in that they have rapidly progressive disease, they have marked elevation in their blood sugars, and patients who are over the age of 70 are at much higher risk of developing pancreatic cancer, suggesting that we should really target our screening therapy to this group of patients. And there's currently an NCI-sponsored large clinical trial looking at the role of new onset diabetes as a biomarker for the diagnosis of pancreatic cancer. Now, only 20% of all pancreatic cancers present as new onset diabetes. So even if this biomarker works perfectly, we still have a lot of work to do with the other pancreatic cancers. An exciting new development in this field has been the FDA approving a biomarker specifically for high-risk individuals undergoing pancreatic cancer screening, and that's by a company called Immunovia, and the test is called the IMRE PanCan-D test, and this is a combination of 8 serum biomarkers and CA19-9. The proteins in these biomarkers come from multiple functional classes. Some of them are tumor-associated proteins, other are hormone transport, bone metabolism, complement, coagulation, and protease inhibitor targets. And the goal of this biomarker is to risk stratify high-risk individuals who are at higher risk of pancreatic cancer and who need further evaluation. So this is a study looking at detecting early-stage pancreatic cancer using this IMBRE PanCan-D test. This was published by Randall Brandt from the University of Pittsburgh. This is the study cohort on which this test was validated. This study cohort consists of 56 early-stage pancreatic cancers, just a little over 100 late-stage pancreatic cancers, and importantly, as controls, they had patients at high risk who were undergoing pancreatic cancer screening, as well as healthy controls. And in this study, this test performed quite well. The sensitivity of this test for early-stage pancreatic cancer was 89%. The sensitivity for all stages of pancreatic cancer was 92%, and the specificity was 99%. So these authors concluded that the IMBRE PanCan-D test can detect pancreatic cancer with high specificity and sensitivity. Another biomarker that looks at not only pancreatic cancer, but a whole array of pancreatic cancers looks at targeted methylation analysis of circulating cell-free DNA. This is the Galleri test. This is based on the observation that abnormal DNA methylation results in changes in gene expression, which in turn can lead to tumor growth. So this test uses next-generation sequencing and machine learning algorithms to analyze methylation patterns of cell-free DNA in the blood. And in the 12 pre-specified cancers in the training cohort, this test achieved a specificity of 99% and a sensitivity of early stage diagnosis for these 12 cancers to be about 67%. Now, specifically for pancreatic cancer, the sensitivity of this test for stage 1 pancreatic cancer was 63%, and stage 4 pancreatic cancer was close to 100%. Another biomarker that's generated enthusiasm is the Cancer-Seq test. This again looks at multiple cancers. This is a combination of 8 circulating protein biomarkers and tumor-specific mutations in circulating DNA. This was validated on a cohort of over 2,000 patients, and I'll draw your attention to the performance of this test with regard to pancreatic cancer. So it was able to detect about 70% of all pancreatic cancers in this cohort. Now, the authors did not report the performance of this test by stage of pancreatic cancer, specifically for pancreatic cancer, but they reported it for all cancers. And I suspect these results would be very similar for pancreatic cancer in that the sensitivity of this test for very early stage pancreatic cancer may be in the 40 to 50% range. And there are other emerging biomarkers as well. There are epigenomic-based tests. This is a particular test, the 5-hydroxymethylcytosine test. This is being developed by Blue Star Genomics. Pancreas risk is another biomarker. This is different from all the other biomarkers we've talked about because this is based on a urine protein. So this is a combination of 3 urinary protein biomarker panel, and the accuracy in one study for this test for pancreatic cancer was 93%. There's another combination of multiple epigenomic biomarker tests. It's developed by Guardant. It's called the SHIELD multiple cancer assay, and they recently reported the results. The sensitivity of this test for stage 1 and 2 pancreatic cancer was in the 73% range. So what is the role of biomarkers in our current screening protocol? So the biomarkers that we're currently using in high-risk individuals who are undergoing pancreatic cancer screening, some people are using CA19-9. The CAPS consortium recommends that all high-risk individuals be screened annually for new-onset diabetes with fasting blood sugar or an hemoglobin A1C. And now the FDA has approved the PanCan-D test for pancreatic cancer screening. Now it remains to be determined as to who are the best candidates for these biomarkers. Does the availability of these biomarkers allow us to expand the cohort of patients to whom we can now offer pancreatic cancer screening? How often are these biomarkers going to be performed? Are they going to replace EUS and MRI in our screening protocols? And one could imagine a system where patients got biomarkers once a year, and then only those who had elevated biomarkers proceeded with EUS or MRCP. Another option would be that these could be done in addition to EUS and MRCP, especially since we're worried about interval cancers in the 6 months between an EUS and an MRCP. A biomarker could be done to see see whether the patient needs to be brought in sooner for their follow-up exam. So none of these issues have been fully ironed out, but we'll definitely start seeing some recommendations in the next few years to come. So I'd like to summarize pancreatic cancer screening in the year 2022. So screening is not recommended for the average risk individual. Screening is recommended for high-risk individuals with genetic susceptibility to pancreatic cancer, and only about 10% of all pancreatic cancers develop in those with genetic susceptibility to pancreatic cancer. So currently we're only impacting these 10% of pancreatic cancers with our screening protocols. Currently screening is recommended annually with EUS or MRI, or alternating between EUS and MRI. Screening likely detects cancers at an earlier stage. Screen-detected pancreatic cancers have better outcomes. Interval and late-stage cancers are common with the current screening protocols that we're using. And finally, the discovery of new biomarkers may improve and expand pancreatic cancer screening. Thank you for your attention.
All right, everyone. So we're going to move on to the next case in our room 1 with Dr. Tyberg. We have a 58 years old male patient who had significant history of NASH-related liver cirrhosis, who previously was admitted for acute cholecystitis. And the CT scan in the beginning of August revealed cholelithiasis and thickened gallbladder. He was deemed a poor surgical candidate considering his decompensated NASH-related liver cirrhosis. So he actually ended up undergoing EGUS-guided gallbladder drainage on 4th of August, and a 10-millimeter Axio stent was placed with anchoring double pigtail stents. He presented back to the emergency department actually just 5 days afterwards with worsening abdominal pain and fevers, underwent another CT scan which revealed increased gallbladder wall thickening, stranding, and internal gallbladder debris. EGD was performed, and the gallbladder was intubated and was noted to have purulent material, and actually there was food material which was clogging the previous stent. So previous double pigtail stents were removed and replaced during that admission. So today he's coming in for follow-up because the patient has a recurrence of abdominal pain. So today the plan is that we're actually going to take out the lumen opposing metal stent, which was previously placed, and replace the plastic stents. So some of the images in the past, as you can see, on the left side of the screen is the previous gallbladder, which was dilated. The right side actually shows the placement of the lumen opposing metal stent. And these were the stents which were placed previously, as you can see, on the index admission. And on the follow-up EGD, as you can see on the left side of the screen, the previous stent was completely clogged with food material, so the plastic stents were replaced. All right, we'll move on to the room.
Okay. Hi, everyone. Thank you so much for joining us. Welcome back. So as Arslan was describing, this patient had acute cholecystitis, not a surgical candidate, and he had a successful endoscopic gallbladder drainage. However, he's had a couple instances and been pretty symptomatic of the stent getting occluded. So, my thought was that probably it's getting occluded either with food or possibly even with gallstones or sludge. So the plan today, I did a little bit of work before you guys came into the room. I've already actually gone down and removed the lumen opposing metal stent that was there, and I am now in the gallbladder, and you can see that definitely there's a lot of food debris and thick bile in here. Then this is probably why his stent was getting occluded. So I think I'm actually going to almost treat this like a necrosectomy almost, except that it's food debris, not necrosis, and try to get some of this stuff out. So I actually, in order to get deep into the gallbladder, I had to use a small stricture-sized scope. But now that I've been able to show you what we're dealing with here, I'm actually going to take this scope out and go with a regular upper scope so that I can actually use a Rothnet and some other tools. Here's a little better image here. You can see just lots of debris here. It's hard to even see the wall of the gallbladder. So I'll come back slowly, and then as we switch scopes, I'll show you what the axios looks like. Here you can see the fistula tract itself, and then now we're back in the stomach. And when we took the axios out, it was also clogged with food. And I think it's interesting because here I'll just show you again what it looks like. You can see some debris up here and even further in here. So So as I switched scopes, I thought it would be interesting to talk a little bit about management of these patients that, we can successfully treat the cholecystitis with placement of lumen-opposing metal stents, but then the follow-up care after that, I think there's still a lot of variation. So in general, I usually do try to go back and remove the metal stent and replace it with plastic pigtails, which I feel like can be left indefinitely in place. And if there is debris and food in there, then I oftentimes will try to remove it at the same time. I don't know if, what your guys' practice is. I know some people will leave the metal stents indefinitely. Some will just remove it completely once the cholecystitis has been treated. Well, open for discussion while we switch scopes. Yeah.
Yeah, that's all really important for this discussion, Amy, because you're right, draining it is one thing, but then the definitive management, right, for an end-stage exit for these patients is the other thing. Generally, we do remove our axio stents. The question begs, though, what size stent is optimal for these gallbladders? So when you have a 10-millimeter axio stent, it's nice, it's constrained, but at the same time, if you get an occlusion within 4 days of initial placement, doing debridement on a small stent with risk of stent migration and getting a scope in and out is also a problem. So that's one concern with using smaller size stents. Do larger size stents allow for more food or oral ingestion to get into the gallbladder, or do they allow for more efflux to get out of the gallbladder at the same time? These are all debates and data that need to be looked into. But in general, we're trying to get these metal stents out within a few weeks and then replace them with pigtails. That's our convention for these. And then hopefully not running into the problem that you ran into with this patient. And, one thing I don't necessarily practice or think about, but maybe I should, is advising patients about diets after these kind of procedures. Should we be telling them to go into low residue diets to avoid fibrous debris and things like that can clog up these stents? Thoughts, Nikhil?
Yeah, those are all great points. I think two things that I worry about with long-term indwelling lumen-opposing metal stents in the gallbladder. One is bleeding. So when the gallbladder decompresses, I worry about the back wall closing and rubbing up against the metal stent, and that can lead to bleeding. You can mitigate that somewhat by putting in the plastic double pigtail stent to sort of act as a buffer. And then the second, which is the issue that we're facing here, is food either going into the gallbladder or occluding the stent, leading to a recurrence of cholecystitis. So as long as the patient is not, sort of a terminal patient, I would try to bring them back usually within about 3 to 4 weeks, and then get the metal stent out and then leave plastic pigtails in place to try to minimize those two issues, bleeding and stent occlusion leading to recurrent cholecystitis.
Yeah, so it sounds like we all have similar plans of attack. I think in this patient, you're right, after it became occluded initially, we didn't want to remove the lumen-opposing metal stent right away because it had only been in place a couple of days and we didn't feel like the fistulous tract was mature enough, which is why at that point we just replaced the double pigtail stents and hoped that would treat the occlusion. But now that it's been a few weeks, I felt more comfortable bringing him back and removing the metal stent here. And you can see with the upper scope, I'm not able to get as deep into the lumen, but I do want to try to get some of this debris out. And then my plan is just to put some plastic stents in. And I think, I'm okay leaving those stents in place indefinitely. I don't know what your guys' thoughts are on that. Open?
Yeah, I agree. You can leave them in indefinitely. And while I've I'd also remind our audience that if you have any questions, again, feel free to use the chat box. We're more than happy to relay your questions to our endoscopist.
Close. So you can see I'm just using a Ralph net to get some of this debris out. I don't think there's actually quite as much debris as I initially thought. I was able to suction quite a lot of it, so I got some of the bigger pieces out here. I'm just going to try to clean up this wall. Open. And then just put some plastic stents. But I think it's definitely something interesting to think about because it's, draining is the acute treatment, but the long-term plan is definitely, there's still a lot we have to learn, I think, and not a lot of standardization. Close here.
There's a question, Amy, if you do a lumen-opposing metal stent for EUS-guided gallbladder drainage, and then the patient becomes a surgical candidate, is there any difficulty that the surgeons face in taking the gallbladder out with cholecystectomy and then doing having to close the either gastrostomy or duodenostomy where you made the initial puncture?
Yeah, I think that's a great question, and something we're definitely studying. We actually just presented an abstract at this past DDW looking at that question, looking at patients that had undergone EUS gallbladder drainage compared to percutaneous and how they did when they improved and became surgical candidates open, to see if they could still undergo safely surgical cholecystectomy after having EUS drainage. And what we found was that they did actually definitely no worse and maybe even better, when they had EUS guided drainage of the gallbladder followed by cholecystectomy. There was no concern. So see, I've gotten some debris out here. I'm going to actually bring this.
There was an interesting discussion on this very topic at the Therapeutic EUS meeting back a few years ago at DDW, and we had some surgeons in the room commenting on this. And the question was posed, if we do these procedures and are bridging them to surgery, how would you like us to access the gallbladder from the duodenum or from the antrum? And from a surgical standpoint, it seems that it's technically easier to do an end cholecystectomy after a cis cholecystectomy when it's done from the antrum as opposed from the duodenum. So technically, if you have an entrance point, and this patient may end up getting into the operating room, if you have an entry point from the antrum, it may be better for them surgically down the road. Anecdotal data.
Yeah, I totally agree. And I think, if the patient does become a surgical candidate, my practice is I'll actually remove the lumen-opposing metal stent and close the hole from the gastric lumen, usually with an over-the-scope clip, prior to the patient going to the OR. So then they don't have to worry about closing it on their end. But yes, I agree. If there's a chance they'll be a surgical candidate, I think trying to access from the stomach is probably better. Although I do think you're more likely to get obstruction related to food when the stents are placed from the stomach as opposed to the duodenum.
Sure.
I think
How
actually.
do you decide when the patient should get transmural versus transcystic drainage when they're endoscopic candidates for gallbladder drainage?
For me, I think, if the patient needs an ERCP in addition to gallbladder drainage, then it certainly makes sense to try to do a transcystic drainage. But if the patient has just cholecystitis, I think, doing an EUS guided approach, you get rid of the risk of post-ERCP pancreatitis. I think it's probably a faster and more straightforward procedure in most cases. So I would probably go straight to EUS guided. But it's a great question. I don't think I think there's probably a lot of variability.
Yeah, I think you're kind of correct on those things. These pathways have shown, at least in the retrospective data, since retrospective comparisons, that EUS guided drainage is more effective. The clinical resolution of cholecystitis is much higher than it is with transcystic. Transcystic maybe in the 80% if it's feasible, and EUS guided lance placement higher than 90%. And so it may be a more clinically effective procedure, but you're right. I think if you're doing something for bile duct stones and there's a cystic duct that's right there, and you can access it relatively easily, especially in in patients that have a lot of comorbidities. If you can use a natural route of anatomy rather than creating a new fistula, I think it's a reasonable plan of action. I have patients that have had transcystic stents in place for 3, even 5 years that have never had to get them replaced, and it's almost like their definitive form of therapy.
Yeah, absolutely. So I think I'm just going to spend a little time here cleaning. You can see I got a nice piece here, and then I'm probably just going to put some plastic pigtails in here after I get all this stuff out. So if you guys are ready to go to the other room, you're welcome to. Otherwise, you're welcome to stay with me and watch me clean a little bit. Open.
Yeah, I think while we wait to we get word on if the other room is ready, I think one of the other things that should be discussed aside from, when you talk about the management of non-operative cholecystitis, we talked about transmural gallbladder drainage, we talked about transcystic drainage via ERCP. The other route that should be mentioned is interventional radiology using a perc drain. However, especially in these non-operative candidates, there's a lot of issues with respect to percutaneous drainage. So oftentimes they're using very small catheter sizes, anywhere from 6 to 10 French, and these oftentimes can occlude, requiring reintervention, or they can become dislodged, requiring reintervention. A lot of times the puncture in the transhepatic tract can traverse the cutaneous and musculoskeletal layers, and that can lead to persistent discomfort for the patient while the drain remains in place. And then there's sort of a whole host or bevy of other, complications, whether it's cellulitis or hematoma issues, or non-healing cholecystocutaneous fistulas that can be quite cumbersome for the patient in those that have indwelling perc drains for a long time. So with internal gallbladder drainage, whether by EUS-guided transmural drainage or transpapillary drainage, you're obviating some of those undesired complications that can occur from palliative percutaneous drainage.
Yeah.
I agree with all those points. And these types of forms, percutaneous, they're non-physiologic forms of drainage, right? You're losing bile out of the extrahepatic circulation. The liver is forced to recreate that bile as opposed to endoscopic routes of drainage, which put that back into the system. Percutaneous interventions are mainstay around the world. They're well established. They're first line and a non-surgical candidate. But the data and literature on long-term outcomes is lacking. And all of those catheter-related complications that you've mentioned are real, and patients will tell you that their quality of life are lower with these drains in place. And now the data is slowly coming out. We had a study, 5-6 years ago, and multiple studies now have come out comparing outcomes retrospectively of EUS-guided endoscopic drainage versus percutaneous drainage. And consistently across the board, you're seeing similar outcomes where efficacy is similar, but rate of complications, number of reinterventions are all higher in percutaneous versus the endoscopic routes of drainage. So we need to get this data out there a little bit more strongly and try to change our clinical management algorithms in our hospitals, but that's been an uphill battle.
Yeah, absolutely. So I'll leave with the statement that I made during my talk is we just need to know if there's enough endosonographers to take over all of the non-surgical cholecystic gallbladders, and I think with that we'll move over to room 2 for a bit.
Great job, Amy.
Thanks, Amy.
So the next case we have here in room 2 with Dr. Sarkar is an 89-year-old female. She has a history of ampullary neuroendocrine tumor, and she had an ERCP with an ampulectomy back in September of 2021. That did confirm that it was high-grade neuroendocrine carcinoma, and the margins were positive at that time. Most recently, she had a follow-up ERCP recently in May, and ended up having a standard revision and biliary RFA at that time for positive resected margins. So today we're planning on doing an ERCP with spyglass cholangioscopy and then proceed with RFA.
Hey guys, can you hear me? Great.
Yep, we can hear you.
Great. So I've already gotten started. I'll have Junior show us the scout film, and initially you can see that there was a metal fully covered biliary stent in place with a double pigtail going through it. I think we're still waiting for the fluoro to pop up. There it is, coming up. There it is. So you see the metal biliary stent and you see the plastic double pigtail going through that. Initially I removed both stents, and then I recannulated the duct, and I shot a cholangiogram. So Junior is going to show us the cholangiogram. And so as I was doing the sweep, a lot of stone debris and food debris came out of the duct. Overall, the cholangiogram was not too impressive. There was no obvious stricturing disease. There's, as I mentioned, just some debris that came out. So as we heard in the presentation, there was a neuroendocrine tumor found in the ampulectomy, but the microscopic margins were positive. And so on the last session, the patient underwent biliary RFA, which we discussed a little bit in the morning, can also be used for positive margins after an ampulectomy. So today we're going to do a follow-up exam to see if there's any kind of evidence of residual abnormal appearing tissue at the ampulla site or intraductally in the distal common bile duct. What's also unique about this case is we are using the Exalt single-use duodenoscope as well as a spyglass through that. So currently I have my spy scope in the duct, and we can see that I'm right at the hilum here. Junior, can I get neck? Am I at the hilum, Junior? No, I'm below. So this is probably the cystic duct takeoff. And there's a little abnormal appearing tissue here. I think that's probably stent related, and I don't think that's anything significant. So going closer to the hilum here. Fluoro. So I think I've crossed the hilum at this point. And again, there's some abnormal tissue here. So Junior, can I see the initial scout?
So Avik, we have a question from the audience. Why did you choose to use the disposable duodenoscope, and what do you find in terms of its comparison with the more standard reusable duodenoscope?
Yeah, so we have a protocol that we use to determine cases where we'll use the single-use duodenoscope. Obviously, it's a great scope to use for patients who are bacteremic, have resistant infections or a history of resistant infections, have C. diff, COVID positive. We also use it for patients who are immunocompromised. But we actually use it fairly frequently for patients who need maybe simple ERCPs for stent exchanges and things of that nature. It cuts down on our scope reprocessing time and allows us to be more efficient in the unit. So here I'm at the bifurcation. You can see the scout film. That pigtail was kind of up against that area where I am now. So I'm not too worried about some of this tissue I'm seeing here. I think it's just stent reaction. What are your guys' thoughts on this? Are you guys concerned about what I'm seeing here on Spyglass?
Hey, Avik. I mean, if you had dysplasia at the ampulla or whatnot, it's always a concern that you have a multifocal lesion, and you need to be concerned about that. These findings that you're seeing in front of these kind of like finger-like prawn projections aren't necessarily the most high-risk features we think about on cholangioscopy for something that is malignant. That being said, it's kind of non-contiguous, right? You get like these areas of skip that are normal and not normal. I'm not sure if your metal stent went all the way up into that. I think it's the right intrahepatic or whatnot that you're looking
the metal
at. So
was.
it's a little.
Yeah, the metal wasn't up there. The plastic was up there. I think the metal was right here, where my cystic duct takeoff is, and you can see the same kind of tissue here at the cystic duct area. But I think you're right. I think just for thoroughness' sake, you can actually see that this is all stent related down here. But I think just for thoroughness' sake, we'll take some biopsies with the spy bite to make sure we're not missing anything. I'm slowly working my way down the duct. I want to maintain visualization, so I do instill a little bit of water as I'm going through to maintain visualization, but I try to suck out any excess water. I don't want to overfill the biliary tree as that can precipitate bacteremia. The patient has gotten a dose of Levaquin. We do give pre-procedural antibiotics for patients that we're doing spyglass procedures on. And depending on how extensive the procedure was, sometimes I'll send them home with a course of antibiotics as well.
Hey, Avik, another question from the audience. What are you doing in terms of your algorithm for prevention of pancreatitis in these patients, which you're planning on doing ampullary or distal bile RFA?
Yes, so obviously standard for us is to give patients rectal indomethacin, and we also hydrate them well throughout the procedure with lactated ringers. And then I believe we have an ampulectomy case tomorrow, so we can obviously discuss that more also tomorrow, but we usually gain access to the pancreatic duct and then do our ampulectomy and then place a pancreatic duct stent to prophylax against post-ERCP pancreatitis. But as we know,
But today on your RFA today, after the ampulectomy has already been achieved, and if you're going to do RFA across the ampulla or right above it, would you place a pancreatic duct stent today to prophylax as well?
Oh, yes, absolutely. It's not something I always do commonly, but I usually will give it a few shots. If I can catch the PD easily, I'll put the prophylactic stent. But if it's not going easily, then I will not. What's your guys' practice?
Avik, there's another question regarding placing a metal stent or performing RFA over the cystic duct and risk of cholecystitis.
Yeah, that's a great question. I mean, definitely RFA can have its share of issues with cholangitis, cholecystitis, pancreatitis, infections, fistula formations, pain. So we are very careful when we do RFA, and my goal is to not go over the cystic duct area. But in a lot of these cases, and especially in cancer patients, the cystic duct area is sometimes already taken by cancer, so there's not really that much more risk, I think, of ablating that area. But in a benign patient who does not have cancer, and maybe you're doing RFA for a benign lesion, I'm very cautious not to do an ablation over the cystic duct region. Can I have a fluoroscopy shot?
But there's also a follow-up question to the PD stent. Do you put the PD stent in before RFA or after?
I typically will do it after. But again, if I'm initially trying to cannulate the duct and the wire goes in the PD, I'll take that PD stent at that point.
Yeah, I think that's a great question, because most people, I think, when they're doing their initial ampulectomy for these patients, are trying to access those ducts, as ampulectomy is a high-risk predictor for potential OCSP pancreatitis. So placing a pancreatic duct stent at that time is a very reasonable thing to do. So if you've done that at your initial procedure, you would hopefully have already had in place maybe a small pancreatic sphincterotomy and placement. So on your second procedure, like such as you're doing now, the access will already be there. So as to whether it matters whether you do it before or after, potentially if you're doing a lot of charring at the ampulla, does it affect your ability to get into the pancreas? I haven't really experienced that, but it's theoretically possible. So I agree with Avik. I'm not necessarily doing it before, unless if the wire goes in already, then you can just drop it in and get that done. It's a good question.
So I kind of went through the whole duct, and the distal duct does look a little bit ratty. I mean, I think a lot of that may be from the stent that was there. I'm definitely going to take some biopsies from the hilar area where I see these frond-like projections. I'm going to take some more spy bite biopsies from the cystic duct area where there's some frond-like projections. And then, for the distal duct, I probably will take some biopsies, but I'll also likely do a round of RFA just in case there is any tissue there. So I've got the scope in the position I want to be. I'm passing my spy bite forceps down currently. We're using the spy bite Max, and I found that there's been a huge difference since we changed the spy bite Max in being able to pass the spy bite quite easily through the spy scope. In the past, with the old spy bite forceps, it was sometimes very painful to get the spy bite forceps out. But with the Max forceps, I've not really had any issues with getting the forceps out.
Yeah, that's a good point. Nikhil or Avik, do y'all have any tips on how to make sure you can get that forceps out for endoscopists out there they're trying to do 5x biopsy?
Yeah, I think there's potentially two pain points here with advancing through the catheter. One is in the region of the elevator, so you can make sure to keep your elevator open. The second is sometimes at the tip, and if you have a little bit of difficulty, sometimes it requires moving the cholangioscope either in or out a little bit to try to adjust the area where you might encounter some resistance. So sometimes it does require some scope manipulation or the cholangioscope manipulation and keeping your elevator nice and open. I do find that if you can push the scope sometimes a little bit in a slightly longer position down towards D3, that will also elongate and straighten out the bile duct, and that can sometimes make it easier to get an instrument through the tip of the cholangioscope.
Show the specimen?
You do sometimes have to make adjustments to be able to get the devices out.
Yeah, I agree with that. I think those are great points. The other thing that Kelly just did to help me is she was kind of walking the spy bite with me, so she was kind of opening and closing the spy bite as I was advancing through the scope, and it definitely helps get the spy bite up.
The walking the dog maneuver for sure. Another couple of tips that you can do is just unlocking the dials on the spy bite. That will sometimes reduce some of the tension, because the reason that the spy bite can get through is because of angulated junctures, right? It's a stiffer device trying to make it through such an almost 180-degree angle, if not more, as you can see on the fluoroscopy. And so sometimes when you unlock the dials, that will help it to get through the spy portion. Or if you push the scope in, as Nikhil was saying, because that relaxes the angle on the scope, and then push your spy bite towards the hilum itself, that also reduces angulation on the spy scope. Those maneuvers will generally allow you to advance a spy bite or a laser catheter, whatever device you're trying to get into your there.
Do you guys have experience with using other kind of modes of tissue acquisition in the bile ducts, such as the wire-guided forceps?
Yeah, I think obviously a key area of problems that we encounter are indeterminate biliary strictures. So we know that there's no single, great modality. So oftentimes it's multimodal forms of, tissue acquisition to try to increase our collective sensitivity and specificity and our diagnostic yield. So I think it requires a combination approach. So for approaching an indeterminate biliary stricture, my practice is generally to actually try to dilate the stricture, try to crack or fragment some of the cells, utilize a cytology brush to get cells. I like the use of cholangioscopy for direct visualization and for targeted biopsies, and then you can also use over the guide wire biopsy forceps to take a little bit of a slightly larger sample. And then there are some people who also will use adjunctive imaging modalities. In the past, historically, there's been probe-based confocal laser under microscopy or even volumetric laser under microscopy. However, those are more imaging-based modalities and do not acquire tissue. And the problem that I've seen in that case is that you're never going to convince a surgeon to operate or an oncologist to give chemotherapy just based on an image without having adequate tissue. And then the last potential area for getting sampling is with utilization of fish. So I don't use that routinely at my hospital right now, though we did use it at my old hospital. But I would say right now for me it's a combination of cytology brushes, over the guide wire biopsy forceps, and using cholangioscopy with targeted, directed biopsies. Prashant, I don't know your experience in this area.
Yeah, all great points. As we know, tissue is king in this area, and it's very, very hard to obtain. And convincing anybody that this is cancer is also challenging without a pathologic diagnosis. All of those imaging modalities that you mentioned that varying sensitivities, specificity is not reproducible, so it's really not useful in the real world, in my opinion, doing them. I do very similar things than you. We do utilize more fish at my hospital, so I'll actually get 2 brushing samples on the same stricture after we dilate, one for our cytologist and one for fish. And then we'll do 4 fluoroscopic guided biopsies, and we will usually do cholangioscopic guided biopsies. Because I think, in all of our experiences in the literature, the cholangioscopic biopsies are probably more directed and more high yield than some of the other ones, because you're able to literally see the tissue that looks abnormal, see the vessels that look abnormal, and get that tissue from that area. The other thing that I think is overlooked in this area is US FNA. The controversial area, right, because of the Mayo data about potential risk of seeding, all of that was just one study, and there's multiple studies showing that it may not make that big of a difference. And conceptually, if you're biopsying a stricture in the mid or distal bile duct going through a duodenum, and then the patient is subsequently going for a biliary bypass or hepatojejunostomy or a Whipple even, and these segments are removed, that is exactly the same thing we do for a pancreas head case. We go through the duodenum, sample a pancreatic head, and then they go get a Whipple, and all of the entire specimen is resected along with the site of potential seeding. And EUS FNA samples of bile duct strictures actually has a higher yield than biliary brushings, and so that's something that we will consider doing as well in patients that have had sampling with low yield. Vic, I don't know if there's anything else you would add to that.
Yeah, no, I think that was a great point, and I was going to ask that question to you guys. I think, for me, when we see, unfortunately, quite a bit of cholangio, a lot of times we are kind of left in the dark. Obviously, we'll take a brushing, we'll take a biliary aspirate, we'll do spy bite, but despite doing all that, we don't really get an answer. We get an indeterminate sample, or we get atypical tissue that's not enough for a diagnosis. And, what we're really left with is, can we biopsy this with EUS? Because on EUS, it's very, very nicely seen, very obviously seen close. And so usually our initial approach will be to look for lymph nodes and see if we can biopsy any lymph nodes in the area. But those are not always present, open. And so then comes the question of, can we go, to the hilum with our EUS FNA and take a biopsy there with the FNA close? And, are we going to now make a potentially resectable patient unresectable? So I think different surgeons have different opinions on that. I think for the most part in our institution, we are asked not to do that. But I've heard in other institutions, it's not that much of an issue for the surgeons there. What about your institutions? Are you guys routinely doing EUS FNA of the hilum to diagnose these strictures?
Not routinely, but those hilar strictures, unless they're, unless you're at a transplant program and you're planning on sending these patients for a liver transplant, which is few and far between for hilar cholangiocarcinoma, I think it's rare that we're throwing these patients out of surgical resectability with this technique. I haven't had much pushback, but generally we're very, very cautious about doing anything in that region. I'm much more comfortable in the distal extrahepatic bile duct than I am at the hilum. There's a question from the audience from my friend, Dr. Akhtar. Is there any clinical relevance to the order of the tools for biliary stricture sampling, brush before spy bite or vice versa, et cetera?
Yeah, it's a great question. I actually really enjoy doing my dilation first. I think the dilation really opens up the area. A lot of times when we're not getting great specimens from within the bile duct, it's because the tumor or the malignant cells are actually not mucosally based. They're submucosally based. So by doing a dilation first and just breaking open the tissue there, and then I usually will go in with my spy bite, do biopsies, and then I'll follow that up with a biliary aspirate. With my spy scope, I will aspirate some of the fluid from the bile duct, and then lastly, I'll come out with the spy scope, and then I'll do a brushing of the area. What about you guys?
Yeah, similar. I usually dilate before. I don't think there's any strong data one way or another on this topic. You can see there's multiple studies out there showing number of brushes and number of passes with the brush, and then dilation or not dilation, aspiration of the fluid. We generally will do at least 20 back and fro motions with the cytology brush. There's been enough studies showing that if you do enough back and forth to release that tissue, you may increase your cytologic yield. And it's all because of what you said there. These are desmoplastic fibrotic lesions and cancers, and these are not easily accessible just from mucosa. So you have to get a big chunk of tissue to be able to get these diagnoses made in the scalp. But I don't think there's a really good answer, and I think whichever way you're doing it, for the most part, is reasonable as long as you're doing an adequate brushing sample.
So I'm here now. I took some biopsies by the cystic duct area. I took some biopsies by the hilar area. Now we're going to put up the fluoro image, but I have my spy scope in the distal bile duct here. This is a very difficult area to spyglass because it's quite a bit unstable in this area, but I think I'm fairly stable. So you can see the fluoro image here. I'm at the distal bile duct, and we'll get the side-by-side of what I'm seeing on the spyglass image up in a minute. But yeah, I'm seeing, it's very difficult to tell if this is stent change or not, but definitely does not look normal in this distal duct. So I'm going to take some, you can see the image now. So I'm going to take some spy bite of this area, and then we'll do a aspirate of the fluid within the bile duct here, and then probably when I come out, I'll do a brushing of this area as well.
All right, that sounds great, Alex. So we'll let you get to it with additional biopsies, brushing. In the interim, we're going to move on to the lectures, and then we'll come back to live cases following the first couple of lectures. So keep working. You're doing a great job, and we'll see you in a little bit.
Sounds good. Thank you.
With over 56,000 pancreatic cysts evaluated and classified, molecular testing results are delivered with the experience that matters.
Introducing Endorotor endoscopic powered resection. Determine your resection limits. Endorotor enables resection of scar non-lifting lesions without performing full thickness resection, providing endoluminal preservation and avoiding surgery.
Thank you very much for having me speak at the 2022 Mid-Atlantic Gastrointestinal Interventional course. Thank you to Professor Cahala and all of his colleagues at Rutgers Robert Wood Johnson, and it is an honor to present alongside such a distinguished faculty. Over the next several minutes, I will be discussing innovations in biliary stenting. Many of these innovations are likely familiar to you all, but hopefully by the end of this brief talk, you may discover some small useful tips that may help in your practice. This symposium is sponsored by EndoGI Medical, so I'd like to thank them for the support, but I have no personal disclosures or conflicts of interest as relate to this topic. I will begin by very briefly reviewing general indications for stent placement, as well as reviewing the pros and cons of plastic versus metal stents, and most of the talk I will be discussing innovations in different types of materials for biliary stents. In recent years, there's been significant innovation in metal stents. There's been development of new technology with biodegradable biliary stents, and even developments in the older field of plastic biliary stents. I will only touch on some of the innovations, but there are also other innovations, including improved materials for metal and plastic stents, and allowing for larger lumen diameter in these stents. As you all know, there are several indications for biliary stent placement. And among other indications, the four major categories are presented here. These include management of bile duct obstruction from either malignancy or a benign process such as a benign stricture. Other major indications include treatment of postoperative bile leaks, such as leaks after cholecystectomy, and stent placement until the next ERCP in cases of incomplete stone clearance. But before we go over the types of stents, let's start at the very beginning. The first reported use of a biliary stent was in 1980 in the Journal of Endoscopy by Sohendra, in which an angiographic catheter is repurposed as an internal bile duct drain. Until this time, nasobiliary drains were used after cannulation of the bile duct in cases in which drainage was needed. The authors reported two major advantages of this new internal drainage in comparison to nasobiliary drains, both the physiological flow of bile and improved comfort for the patient. This is one of the major innovations in ERCP, which leads us into our talk today about stents over 40 years later. The two types of stents, plastic and metal, have different uses and advantages. Plastic stents are cheaper, generally easier to remove, and are in numerous lengths. However, even with the various lengths, they have a smaller diameter and need frequent replacement if placed for long-term management. They also may not provide as much radial force for management of strictures, but there is still the method and option of using multiple plastic stent placement in certain situations. On the other hand, metal stents, which are more expensive, have a larger diameter, and can last longer without causing obstruction. However, of course, there are various types of metal stents, covered and uncovered and partially covered, which is perhaps a slightly older innovation in metal stents. But one of the major issues of metal stents is migration, either proximally within the bile duct or distally out of the bile duct. If the stent migrates proximally, it can be a major headache and hassle to remove. And if the stent migrates distally, it does not provide complete treatment, and bile duct obstruction may recur. Preventing metal stent migration is one of the significant innovations in biliary stenting. Studies have shown that the use of anti-migration features of biliary, fully covered, self-expanding metal stents significantly decreased migration rates. The study on this slide is in the cases of anastomotic biliary stricture after liver transplant. Since there was decreased migration with these anti-migration stents, there was also improved stricture resolution and reduced rate of stricture recurrence through the use of this new anti-migration stent technology. Various companies have employed different technology for their stents for anti-migration use, including the use of flares, anchors, fins, improved radial force, and changing diameters, and some stents even have a combination of these various technologies. A second innovation in biliary metal stents are more flexible stents, an improvement in the metals that are used. And these improved flexible stents can be used as Y stents for hilar tumors. These stents may improve the patency of obstruction to provide longer lasting and improved palliation of jaundice in our patients. These are just some examples of these stents. And finally, removal wires have be added to metal stents, and the wires of various length can help in assuring removal of stents. There are now stents which can be employed for individualized treatment, such as anastomotic strictures after liver transplant, and due to the length of the removal wire, after appropriate expansion of the stricture, the stents can easily be removed. Prevention of migration, more malleable stents, and improvement in removal options not only limit adverse events, but also improve the management of biliary obstruction. There's also been recent development of biodegradable stents. Until recently, the polymers were made to degrade at differing speeds, and depending on how long the stents need to remain in the bile duct, different stent characteristics can be utilized. Some stents degrade within 12 days, while others can remain for up to 11 weeks. The endoscopist can choose the stent degrading features based on the clinical situation. Recently, there's an option for a biodegradable stent that can function more like a metal stent. And as seen in various case series, biodegradable stents can be considered in certain clinical situations, particularly in post-surgical altered anatomy, when removal of a biliary stent after placement may be more difficult and time-consuming. If temporary stent placement is needed, then the stent can be placed during one procedure and no repeat procedure is needed for stent removal. This is one of the clinical situations where a biodegradable stent may be appropriate. And although plastic stents have been around for over 40 years, there are also advancements in this area, especially for deployment and maintaining biliary access. The Haber ramp is a catheter which allows for placement of 3 guide wires. This can greatly assist in placement of multiple plastic stents. This device can also be used in situations of difficult cannulation of intrahepatic ducts to help achieve selective cannulation of the area you would like to access. And finally, the SPAT system allows for deployment of plastic stents over a guide wire without having to remove the guide wire after placement of the stent. Access is maintained throughout the procedure as the guide wire stays in place. The system is a short wire system that uses a release mechanism such that the guiding catheter self-detaches from the guide wire without having to remove the guide wire. I would like to now briefly present 2 cases during which our team used the SPAT system to ensure multiple plastic stent placement in the biliary tree and thereby have a more rapid and efficient procedure. In the first case, I present a 54-year-old female who presented with cholangitis and was found to have multiple large CBD stones. Due to the numerous stones, and as the patient was septic with cholangitis, we only removed a portion of the stones during the initial ERCP. In order to ensure adequate drainage and help with extraction of the rest of the stones at the next ERCP, we decided to place 2 plastic stents. Sometimes the 2 plastic stents can help erode the stone and improve the ease of removal of stones at the subsequent ERCP. We deployed the 2 plastic stents in this situation using SPAT system. The SPAT system allowed for quick and efficient stent deployment as the guide wire remained in the CVD at all times and access was maintained. Here you can see the cholangiogram with the 2 plastic stents in place and the 2 plastic stents side by side exiting the papilla. The second case study is a 57-year-old male after liver transplant with an anastomotic biliary stricture that was previously treated with a fully covered self-expanding metal stent with anti-migration technology. Approximately 1 month after placement of the fully covered self-expanding metal stent, the patient presented to the hospital with fever and elevated liver tests. After evaluation and imaging, it was seen that the metal stent, even with the anti-migration technology, had migrated early out of the CBD, and therefore the stricture was still present. You can see on the cholangiogram the persistence of the stricture. The patient was treated with antibiotics and supportive care, and ERCP was then pursued. Our team debated the treatment options, and we could have tried placement of another fully covered self-expanding metal stent. However, given the failure of an anti-migration enhanced fully covered metal stent already in this patient, we decided to pursue multiple plastic stent therapy, which studies in the past have shown in some ways can be equivalent to fully covered metal stent placement in anastomotic strictures after liver transplant. However, it increases the number of possibly increases the number of ERCP procedures. But in this case, because the stent already migrated out, even with the anti-migration technology, we decided that it might be the best option to now switch over to multiple stent placement therapy. Using the SPAT system, we were able to efficiently place 2 10 French plastic stents across the anastomotic stricture, and the patient will be scheduled for future stent exchanges. I would like to show you a video of the stent deployment in this case. Here the guide wire is already in place above the anastomotic stricture. And here, using the SPAT system, you can initially see the advancement of the guiding catheter over the guide wire, followed by stent advancement. Once the stent is advanced all the way up, as you can see shortly, and you'll see the distal end of this plastic stent coming up now, we then initiate the self-detaching mechanism of the guiding catheter. And in a few seconds, you already see that after initiating this self-detaching mechanism, the stent will be released and the guide wire will remain in place. So thereby the stent is in place, providing drainage with the guide wire in place without having to remove the guide wire at all. We will then now advance a second plastic stent over the same guide wire that was never removed. First the guiding catheter, and shortly followed by the stent. You can see the guide wire is maintained in place at all times. First, the proximal stent end is being inserted, and shortly you will then see the distal end all while maintaining guide wire stability and placement across the anastomotic stricture. In a few seconds, we will then see the distal end of the second stent, and we will be able to initiate the self-detaching mechanism right now. So the second guiding catheter self-detaching mechanism is employed. You can see that it's being removed from the second stent. The guide wire remains in place at all time. And at the end of the procedure, you can see that both stents are in place with the guide wire in place. If we wanted to at this time, we could place a third stent, but possibly at the future ERCP after this, when we increase the number of stents, we will then be able to use the same SPATH system to rapidly and efficiently place multiple plastic stents without losing access. So in summary, there have been tremendous improvements in biliary stents over the past 40 years, including significant enhancements to prevent migration, as I showed you with the metal stents. New materials are being used, including biodegradable stents and new metal alloys. And even with plastic stents, there are new technologies to help maintain access, whether it be with the Haber ramp or the SPATH system. And this can only help our patients by allowing for more rapid and efficient procedures. In addition, maybe in the future, we may see even more advancements in biliary stenting. Perhaps on the horizon are drug-eluting stents, which may be used for local chemotherapy agents to help target more locally biliary malignancies. Perhaps drug-eluting stents can help maintain patency of stents in the future. In addition, another potential future innovation may be 3D printing, where we can individualize treatment for patients by 3D printing stents of all different materials and all different sizes, depending on the anatomy of the patient's biliary tree. And possibly even tissue engineering can be used to help improve therapy of strictures or other diseases of the biliary tree. So, of course, the future is always bright for innovation and endoscopy, and it is even bright in a 40-year-old field such as biliary stenting. Thank you for having me present at this symposium and at MAGIC, and enjoy the rest of the conference. Thank you.
The EVA 15 insufflator and smoke evacuation system is easy to use, easy to integrate, and cost-effective, and it requires minimal workspace.
Our first case today is an endoscopic ultrasound-guided fine needle aspiration of a dilated pancreatic duct with mixed features of both chronic pancreatitis and suspicion for main duct IPMN. The first case is a 72-year-old male with a history of non-small cell lung cancer who underwent surveillance imaging which showed a dilated pancreatic duct and evidence of chronic pancreatitis. Here, the J10 series EUS scope is advanced into the stomach, just below the GE junction, showing the left lobe of the liver. From here, the scope is rotated, highlighting the aorta and the celiac artery, which we trace down to the body of pancreas. Within the body of the pancreas, there is noted to be a very large pancreatic duct, which measures up to 14 millimeters. Just deep to that, there's evidence of chronic pancreatitis with multiple parenchymal stones. However, the concern was, given the patient's history, we wanted to make sure there was no underlying occult malignancy within this area. The Doppler image shows the dorsal pancreatic duct at the top of the screen and the vascular structures just deep to it. EUS-guided FNA is then performed with a 22-gauge expect needle after the Doppler exam was completed. You'll see here as I pass the needle into the duct that the hyperechoic duct walls are very calcified, indicating evidence of chronic pancreatitis. This is coupled with the parenchymal stones just deep to the duct. So it was a little bit difficult to pass the needle into the duct here, but I was successful at advancing the 22-gauge expect into the duct. Here you'll notice the very superior image quality with the echogenic tip on that needle. and the overall high resolution image that we're achieving. The FNA was performed and 5 cc's of thick, clear fluid were aspirated. And this was then sent to the lab for CEA and cytology. The CEA came back elevated at 295. The cytology, however, was non-diagnostic. Given the patient's history with a massively dilated main pancreatic duct, it was decided to send the patient to surgical oncology for referral and consideration for a total pancreatectomy. The next case that I'll be presenting is fine needle biopsy of a pancreas mass with an EUS-guided cholangiogram performed in order to facilitate biliary cannulation and stent placement during ERCP. The patient is a 60-year-old male who presented to our emergency department with a chief complaint of abdominal pain, and he was noted to be jaundiced. His alkaline phosphatase was elevated at 508, his total bilirubin was 9.7, and he had an elevated ALT and AST. CT scan was performed, which demonstrated a 4.4 by 4 centimeter pancreatic head mass with intra and extra hepatic biliary dilation. EUS was then performed, demonstrating a large pancreatic head mass with abutment of the portal vein, a dilated pancreatic duct with no other lymphadenopathy and no evidence of liver metastasis. F&B was then performed utilizing a 22-gauge Acquire needle in a single pass fashion. Here we utilize the fanning technique once again in order to facilitate large pathology specimens. You can see here a very classic example of double duct sign with a dilated common bile duct and dilated pancreatic duct, as well as the large pancreatic head mass here. EUS-guided cholangiography was then performed and a full cholangiogram was achieved. The EUS scope is inserted into the duodenal bulb well above the tumor to avoid passing the needle through the tumor in the case the patient is a surgery candidate. Here, a Doppler exam is performed to confirm the common bile duct and avoid the vascular puncture. The 22-gauge expect needle is inserted into the common bile duct under fluoroscopic guidance. A full cholangiogram is then performed by injecting approximately 20 cc's of contrast into the common bile duct. We found at our institution that by performing the EUS-guided cholangiogram prior to an ERCP, we achieve simple biliary access with limited pancreatic trauma, as well as significantly decreased need for percutaneous biliary drains. Essentially, we think of this as a roadmap in order to allow for easier cannulation. Oftentimes, the tumor in the head of the pancreas distorts the distal ductal anatomy, and cannulation angles are often not what you'd expect. After the EUS-guided cholangiogram is performed, an ERCP was then completed. Biliary cannulation is achieved here utilizing an RX39 sphincterotome with an 025 angle tip Jaguar revolution. You can see that cannulation happened very quickly with a single attempt, and a guide wire then follows the track up into the common bile duct. After deep biliary cannulation was achieved, a biliary sphincterotomy is performed to allow some space for the fully covered self-expanding metal stent to be placed, with the hope of avoiding any trauma to the pancreatic duct. Here, a modest biliary sphincterotomy is performed. There's no need to be a cowboy in this situation. We just perform a small sphincterotomy in order to allow a little bit of space here. After the sphincterotomy is performed, we'll be placing a 10 by 60 fully covered wall flex biliary stent. Here's the cholangiogram showing deep biliary access. And next, the placement of the 10 by 60 fully covered wall flex. You can see here that the EUS-guided cholangiogram speeds up the process of ERCP quite significantly. The total time for ERCP here was under 5 minutes, with excellent biliary drainage noted, as you'll see when the stent is deployed. After I deployed the stent here, I noticed that there was still a very tight waist due to the high degree of stricture from the pancreatic head mass. I elected to perform a 4mm hurricane balloon dilation in order to open the duct up and allow for the stent to deploy and open up to its full 10mm capabilities. Given that there was a metal stent in place, a freehand dilation was performed just under fluoroscopy at 4mm hurricane to open this up to 4mm to get it started, so that as it warms up to the patient's body temperature, it will fully expand. This patient was discharged from the hospital with follow-up with medical and surgical oncology and was subsequently started on neoadjuvant therapy with intention to get to surgery. The last case that I'm going to be presenting today is a distal common bile duct mass with an EUS-guided cholangiogram and an ERCP with stent placement. The patient is a 67-year-old male who presented with jaundice and pruritus. He was noted to have a total bilirubin of 6.2, an alkaline phosphatase of 163, and an elevated AST and ALT. An MRCP was performed, which showed intra and extrahepatic biliary dilation with stenosis at the level of the ampulla. Common bile duct was noted to be 1.7 centimeters. The pancreatic duct was 1 centimeter. There were no stones or filling defects noted, and there was no evidence of mass noted on MRI. EUS was then performed, demonstrating an 18mm mass in the distal common bile duct that extended 1.5 centimeters from the ampulla into the common duct. There was no lymphadenopathy noted, no vascular invasion was found, and fine needle biopsy was performed. Here you can see this exam is actually being performed from D3. I find that this scope in D3 is very stable, allowing for the ability to perform FNB or FNA from the third portion of the duodenum. As you can see this, the duct is coming from right to left in the screen in the reverse orientation that you would expect from the duodenal bulb. Here, this is a very nice angle and a nice window to perform fine needle biopsy of this distal mass with the ability to avoid going through any other structures that would be critical and to make surgery problematic. Here, the fine needle biopsy is performed once again with a 22 gauge acquire in a single pass fashion with multiple throws after a Doppler exam was performed. Next, EUS-guided cholangiography was performed with a 22 gauge expect needle, once again making sure to be well above tumor. You'll see here that I'm able to access the common bile duct with the 22 gauge expect and perform a full cholangiogram. Here's insertion of the 22 gauge after the Doppler exam. And a full cholangiogram is performed as demonstrated by the image in the right of the screen by injecting 20 cc's of contrast into the common bile duct. Once again, this allows for significantly easier ERCP, less attempts at cannulation, and avoidance of the need for percutaneous biliary drains. After the cholangiogram was performed with the EUS scope, deep biliary cannulation was achieved with one attempt. A biliary sphincterotomy was performed. Distal common bile duct brushings were performed, as well as distal common bile duct biopsies utilizing a pediatric biopsy forceps through the ERCP scope. After the brushings and biopsies were completed, a 10x60 fully covered wall flex stent was deployed with excellent biliary drainage noted as indicated by the bottom fluoroscopy image. Pathology of the distal common bile duct fine needle biopsy demonstrated adenocarcinoma, as well as the distal common bile duct biopsy performed with the pediatric biopsy forceps and the distal common bile duct brushings all demonstrated adenocarcinoma. The patient was referred to surgical oncology, a Whipple operation was performed, and final pathology showed extrahepatic cholangiocarcinoma with negative margins.
Thank you. Hi, good afternoon. I'm Andres Gelrud. I'm a gastroenterologist from the Miami Cancer Institute and GastroHealth. First, I want to thank Dr. Michelle Cahaller for the invitation, and I want to thank Aviv also for the invitation. I'm be showing a disclosure slide in just a second. Before I even start the talk, I just want to mention that this is a very, very relevant talk. A lot of the cases that you have been seeing today, I hope that are taking pancreatic enzymes because they do have a very strong indication, and you'll see in a couple of minutes the data. Please note that this is a non-CME program is sponsored. I'm doing this on behalf of Aviv. I, the presenter, the speaker, I'm giving this program. I have been selected by Aviv in the presentation of the program material of Aviv behalf. The presentation content, it's consistent with all applicable FDA guidelines, and it's intended for US and Puerto Rico healthcare professionals only. For any additional product-related information, please contact Aviv Global Medical Information. So let's briefly talk about the pancreas, its functions, and I'm going to stop in the slides that I consider to be the most relevant, particularly for a life endoscopy course, particularly for you to remember how important it is to supplement pancreatic enzymes in many of the patients that you have seen throughout the day today. So you know that the pancreas has an exocrine function as well as an endocrine function. We'll be placing our attention today on the exocrine pancreas. Exocrine pancreas accounts for approximately 80–90% of the gland. The endocrine pancreas, it's much less. As you know, if the exocrine pancreas is not working appropriately, these patients develop a multitude of symptoms and complications in the short and long term that we'll go over them in just a couple of slides. I won't stop here too much. You all know that the normal digestion of carbohydrates, proteins, and fat are 100% dependent on the pancreas, particularly fat. Carbohydrate, not as much. Proteins are highly dependent on pancreatic enzymes for absorption. You have other salivary, gastric, and GI sources of proteases, and most importantly, of lipases. So the pancreas still continues to play a major role in anything that has to do with digestion of carbohydrate, proteins, and particularly fat. So again, I'm not going to stop in this part just for the sake of time. We have a lot of slides and I couldn't delete them because I have no real control of this. But just remember that in a normal meal, you or I, when we eat a regular meal, we're going to be secreting approximately 720,000 units of lipase. Every time we talk about the numbers of the content in every pill, we're talking about units of lipase. So what about EPI malabsorption? Again, what is exocrine pancreatic insufficiency, or EPI? It's a condition that is caused by inadequate production or inadequate delivery or inadequate activity of the pancreatic enzymes. We'll go over that in a couple of minutes. And we need that for the normal digestion. Very, very important, the lipase part, all the fats, you don't have lipases, you're going to be maldigesting, and that's going to trigger a lot of the symptoms that we'll be talking about in just a couple of minutes. Amylase and proteases as well, but again, lipase is a major player that we're going to be talking about. These are the three different types of proteins that are made in the acinar cells in order to make absorption possible. EPI may result in maldigestion, malabsorption, and malnutrition. Of course, if you're maldigesting, you are going to be malabsorbing. The malabsorption is going to create a whole milieu of symptoms, and be very, very careful. Malabsorption, particularly of vitamin D. And again, I'm going to stop in the most important take-home messages. If you malabsorb vitamin D, you may develop a metabolic bone disease. Metabolic bone disease may lead to bone fractures. Many papers have already shown that our patients with exocrine pancreatic insufficiency that are not treated with pancreatic enzymes have a very high risk of developing metabolic bone disease and ended up in the emergency department with a hip fracture, among others. And malnutrition, of course, if you're not absorbing what you're eating, and these patients are very hungry, they're not absorbing everything. It's what I always said, going straight to the toilet, they're going to get malnourished. So many of these patients are very thin and are very malnourished because we haven't made the right diagnosis, and we haven't started the right treatment. So what's the etiology of exocrine pancreatic insufficiency? Again, many of the cases that you have seen, including the 3 vignette cases that you just saw, all of them could have exocrine pancreatic insufficiency, particularly the patient that had the dilated duct with chronic pancreatitis. I think it was the first case that it was presented. So I hope that patient is taking pancreatic enzyme replacement therapy. In general, we divide it in 3 different etiologies: decreased production of enzymes, and that's what we tend to see the most. Again, chronic pancreatitis, I'm talking about gastroenterology, as well as certain genetic conditions that we're making the diagnosis nowadays more and more and more. Decreased delivery of pancreatic enzymes. 2 of the cases that were just presented with pancreatic ductal obstructions, the enzymes are not going out into the duodenum. There's no good delivery. Decreased activity of the pancreatic enzymes. Again, it may be a motility problem from the stomach, or it may be an asynchrony. And we'll talk also briefly about patients, for example, with Soliger-Ellison syndrome, that they have the right amount of enzymes. They get in contact with so much acid that the acidity basically is destroying the activity of the enzymes, and you lose the function. What about decreased production? Again, I'm not going to go into too much details, but it's chronic pancreatitis, cystic fibrosis, bad accrued pancreatitis that you've seen already a couple. For example, the patient that had the pancreatic necrosis and the necrosectomy with a CT scan that looked horrible, and it was successfully treated with transgastric necrosectomy. I'm sure that patient may have some important degree of exocrine pancreatic insufficiency. Patients with cancer, they have to be started on pancreatic enzymes, particularly after they have big resection. Those are the surgical guidelines. Those are the GI guidelines as well. And those are the cancer guidelines to start this patient of enzymes as soon as possible. Reduced stimulation, you can see that in celiac disease. You can see that in chronic disease, in Crohn's disease, and you can see that in some type of gastric and duodenal resections. And you can see also in the type 1 diabetes, autoimmune, that there's a group of patients, as you know, autoimmune disease, it's leading to type 1 diabetes. It's leading also to some degree of exocrine pancreatic insufficiency. So this is something that we see actually in the real world. What about decreased delivery? Again, I'm going to say this multiple times. This whole morning and for the rest of the day, today and tomorrow, you're going to see all of these patients that I do hope they're taking pancreatic enzymes. I don't want to be asking those questions, but feel free to ask the moderators if these patients are being treated also, and not only endoscopically, but also with the right amount of pancreatic enzymes, because ductal obstruction, ductal calcifications, etc. Possible causes, of course, it's cystic fibrosis, chronic pancreatitis, and pancreatic cancers. All of these will decrease the function. One that we did not mention, and I forgot to mention during decreased activity, it's this picture that you see here that, again, you have seen multiple times throughout the day, gastric bypass. The amount of enzymes that it's being made, it's correct, it's good. The problem is that the distance and the side where they're joining, there's going to be a significant amount of decreased activity. Not to mention that the food and the enzymes are mixing in the jejunum, some part distal, instead of mixing at the level of the duodenum. So this is another reason why people will develop secondary causes of exocrine pancreatic insufficiency with malabsorption. As we spoke about, solid journal cell syndrome, gastrinoma, too much acid. These enzymes are very acid liable and dependent. If they're exposed to too much acid, they won't work well. They're going to get disintegrated. They're going to get, they won't work. What about the signs and symptoms of EPI? The typical that we all know: diarrhea, abdominal pain, bloating, flatulence, weight loss, weight loss, weight loss. So all of the above could be just simple IBS. But when you start to hear the word weight loss, you must think about exocrine pancreatic insufficiency. The bloating, the flatulence, there's something about fat malabsorption that makes this flatulence to be particularly bad, like a rotten egg. And you'll hear that a lot when you're talking to the patients and particularly the family members. And once you have steatorrhea, fat in the stool, it's a no-brainer. That's a diagnosis. There's very few other conditions, and I'm happy to talk about that in the question and answer section. But once you're talking about steatorrhea, that's advanced exocrine pancreatic insufficiency, and too bad the patient didn't come to us early, or too bad we didn't make the diagnosis earlier. Again, because of the sake of time, I cannot go over all of these. But remember, EPI, you have all of these symptoms, but you have weight loss, weight loss, weight loss. Again, if the patient has steatorrhea, this is the diagnosis should be very straightforward to make. Think about IBS at the beginning. If they're not losing weight, think about small bowel bacterial overgrowth. Crohn's, ulcerative colitis. Our patients with EPI don't have blood in the stool, and that's something that you would see with these patients. What about the underlying conditions and procedures of EPI? Again, we cannot go into too much detail, but think about EPI in cystic fibrosis, chronic pancreatitis, pancreatectomy patients, unresectable tumors that they have a dilated pancreatic duct with an atrophy of the pancreas. We have seen many today. There are more to come today, and there's many more to come tomorrow. Again, I hope those patients are taking pancreatic enzymes. Bad pancreatitis. Some patients with Crohn's disease, celiac disease, the prevalence is much lower, but it's something that we see. And if you don't make the diagnosis, they may not get better. Type 1 diabetes, or patients that have had gastric surgeries. Again, the majority of these patients are going to have chronic pancreatitis. You can make the diagnosis. Many of these patients have had pancreatic resections, and here it's under pancreatic cancer, and the others are like other conditions like we have been talking about. What are the challenges? Frequently, there's a big lag between the time the patients develop symptoms and the diagnosis it's made. So sometimes the diagnosis can be difficult to make, particularly when there's so much overlap with irritable bowel syndrome. Here you see what I just told you. This is actually one of the papers that we published in the past, that you can see that there's a significant lag between the time of presentation of symptoms and when the diagnosis is made. How do we make the diagnosis? Use fecal elastase, clinical, and you can check a fecal elastase. Fecal elastase, it's not the best test, but it's very relatively cheap and easy to do. When you order a fecal elastase, make sure to tell the patient that it has to be a well-formed bowel movement. It cannot be liquidy, it cannot be diarrhea soft. It's going to be falsely abnormal. So make sure it's a well-formed bowel movement. If the patient is taking pancreatic enzyme, it is okay. You can do it because it's a monoclonal human antibody that does not cross-react with the pancreatic enzymes that are porcine in origin. So that's basically how we make the diagnosis. Fecal elastase, the other ones we rarely do nowadays. How do we treat it? Again, we give pancreatic enzyme replacement therapy. We tell the patient to have a well-balanced diet. If they have pain, we tell them to be low in fat. If they don't have pain, they can have a very healthy and very broad diet. We don't tell them to be in a low-fat diet. Vitamin supplementation, it's super important. We spoke already about metabolic bone disease. Please make sure they're being replaced. Please make sure that your patient has a bone density scan and that they don't develop metabolic bone disease in the future. I'm going to pass this slide for the sake of time. this already, we spoke briefly, but to summarize, I want you to remember making the diagnosis. It's a clinical diagnosis. Again, you start to hear about weight loss, you start to hear about diarrhea, gas, bloating, everything that has to do with malabsorption, particularly in a patient that you know has chronic pancreatitis, particularly in a patient that have had pancreatic surgeries. Think about EPI. How do we make the diagnosis? Again, clinical, but also check a fecal elastase. It can be of good health, particularly if it is completely normal, and make sure that you give the right dose. When it comes to Creon, we tend to give 36,000, one in the middle of the meal, one at the end, and one with snacks. And you'll see that within a month, these patients are going to start to feel better, and they're going to start to do much better. So we spoke about the etiologies, we spoke about making the diagnosis, and we briefly spoke also about the treatment. Thank you so much for taking the time on being in this ultra short presentation. We're going to have actually time now for some question and answers. And again, thank you so much for being with us. And thank you so much for participating in this magic, great course. And that has been a beautiful show so far. Thank you again.
It's my pleasure today to be here, part of the MAGIC course, and presenting on an update on pancreatic cysts and risk of neoplasia. The incidence of pancreatic cysts has been increasing over time, with anywhere from 2.5% to 13.5% of the population having a pancreatic cyst. And age is a major risk factor. So in other words, as one gets older, the likelihood of having a pancreatic cyst dramatically increases. Most pancreatic cysts are asymptomatic, and most are diagnosed and found incidentally. Anywhere from 40 to 50% of patients can have a cyst that shows up on imaging for other reasons, and it's estimated that in patients over 70 who get an MRI for non-pancreatic indications, over 40% can be found to have a pancreatic cyst. And why is this important? The reason that it's so important to talk about pancreatic cysts and to be aware of them when they are found on imaging, even if done for other reasons, is that because some pancreatic cysts are pre-malignant or even malignant. And the goal is to differentiate these benign cysts from the malignant cysts. If you look at the SEER database, it suggests that anywhere from 0.25% can be malignant at the time of diagnosis, and another 0.25% become malignant every year. And you may ask then, why not just remove all cysts if there's a risk that they could become cancer down the road? And that's because resection of pancreatic cysts is not such a benign operation. The surgical resection is associated with about 30% morbidity rates and up to 2.5% mortality rates. When we talk about pancreatic cysts, there's several different types. There's the primarily benign pancreatic cysts, or considered the low-risk cysts, and these are the pseudocysts, serous cystadenomas, and IPMN that are side branch type that don't have any high-risk features. The ones that have malignant potential are the mucinous cystadenomas or cystic neoplasms, the main duct IPMN cysts, the side branch IPMNs with high-risk features, and solid pseudopapillary neoplasms. And then malignant cysts are, of course, those that are adenocarcinoma or that are a neuroendocrine tumor. And there's other rare types of cystic lesions that can be seen in the pancreas, which it's important to be aware of when working up these cysts. So a little more detail about the different types of cysts that we can see in the pancreas. Starting with the benign cyst, this is a pseudocyst, or could also be walled-up pancreatic necrosis. These are generally seen in patients who have a history of pancreatitis. They don't have any epithelial lining, and they generally contain pancreatic secretions, necrotic debris, or blood. They can have a thin wall or a thick wall, and they're generally solitary, unilocular, or they can also be septated. When you're working up these cysts, generally, if you send the fluid for cytology and analysis, you're going to see inflammatory cells in the wall of the cyst. You may see pigment-laden macrophages, and the fluid is going to generally show high amylase levels, absence of mucinous material, and low CEA levels. Serous cystadenomas are also considered benign or low-risk cystic lesions in the pancreas. These are seen more in women than in men at about a 3-to-1 ratio. They're generally identified anywhere from the 5th to 7th decade of life. They can be anywhere in the pancreas, and the classic finding is that they have the central stellate or sunburst scar that can be seen in about 30% of these lesions. 70 to 90% of these cysts have a microcystic or honeycomb appearance. They can have a macrocystic or oligocystic variant, and more than 50% are found incidentally, but they can also present with mass effect to other structures around the pancreas or abdominal pain. And generally, as I said, they're considered benign, but they are slow growing and can get to be quite large over time. When you aspirate the fluid and send cytology from these cystic lesions, generally the fluid is going to be thin. It's often going to be blood tinged. Generally, these cystic lesions have a low CEA level and a low amylase level. You may see cuboidal epithelial cells with glycogen. And although they do grow, it's generally a slow growth rate around 1 millimeter per year. Switching a little bit to talk about the malignant and pre-malignant cysts. The first pre-malignant cyst to be aware of is the mucinous cystic neoplasm. This cyst is also primarily found in women, anywhere usually in the age range of 40 to 70 years. Most of the time, these lesions are found in the body tail. They will sometimes contain peripheral calcium. They're usually a single cyst. As many of pancreatic cysts are usually incidentally found. Often they have mucin-secreting epithelial cells, ovarian-like stroma, and they do have a malignant potential. When you're sampling or looking at these cysts under the microscope, you're generally going to see a viscous mucoid type fluid in these lesions, and they generally are going to have a high CEA level and a low amylase level. IPMNs, or intraductal papillary mucinous neoplasms, are also premalignant cysts of the pancreas. These occur when there's a proliferation of mucinous cells of the pancreatic duct that causes cystic dilations of the ductal system with an overproduction of mucus. And they can either affect the main duct of the pancreas, as you can see illustrated there on the right top of the screen, or they can involve mainly the side branches, as you can see on the bottom, or they can be mixed and involve a combination of the two. And again, these can be incidentally found and asymptomatic, but they can also cause abdominal pain, pancreatitis, jaundice, and even diabetes. When you talk about branch duct IPMNs, these are the majority. They represent about 90% of all IPMNs. These are the ones that are usually incidentally found. They can be multifocal a good percentage of the time. They're generally slow growing, and they do carry about a 5 to 15% risk of malignant transformation. Main duct IPMNs are more rare, only about 10% of all IPMNs, but they are primarily symptomatic in up to 2/3 of patients, and they carry a much higher risk of progression to malignancy than the branch duct IPMNs. Solid pseudopapillary neoplasms are also premalignant cystic lesions of the pancreas. These are the least common of the neoplasms. They're also called papillary cystic tumors of the pancreas and papillary cystic neoplasms. They're generally found in young women and in their 20s to 30s, usually in the body and tail of the pancreas. And again, they do carry a malignant potential, and so surgical resection can be curative. And lastly, cystic neuroendocrine tumors. These are also relatively rare, only about 8% of resected pancreatic cystic neoplasms. Most, again, are asymptomatic and found incidentally. They can occur in both men and women, usually in the age range of 60 to 70 years. generally, these lesions are going to have a low CEA, and the diagnosis is going to be made with cytology. You can see often they'll have a hypervascular rim or a solid component, and again, for these lesions, surgical resection is curative. So now moving on a little bit in terms of management of pancreatic cysts. When we talk about incidentally found cysts, it's important to not only work them up and try to determine the type of cyst, but also to think about the management of these cysts, which generally falls into one of two categories, which is surveillance or surgical resection. And there's a variety of guidelines that exist to try to help us decide how best to surveil these patients and when to resect them. These are some of the guidelines here. The ones that most of us are most familiar with are the Fukuoka guidelines. As you can see here, a little bit complicated, but a nice flow chart that can be followed. The AGA also has guidelines which are helpful in the management of pancreatic cysts. And then there's also guidelines from ACG as well. And the long story short is that generally all of these guidelines basically recommend surveillance intervals or surgical resection based on predictors of malignancy. And although they vary slightly, generally the high-risk features that are concerning and should prompt consideration of surgical resection include things like obstructive jaundice, a history of pancreatitis, in some of the guidelines, elevated serum CA19-9 levels, presence of a mural nodule, especially if it's enhancing. Some say any mural nodule, some specify greater than 5 millimeter mural nodule, presence of a solid component, a dilated pancreatic duct, in some greater than 5 millimeters, generally in main duct IPMNs greater than 10 millimeters, any kind of change in the pancreatic duct caliber with upstream pancreatic atrophy. Size is important. Some of the guidelines suggest 3 centimeters, other up to 5 centimeters, a rapid cyst growth rate, and any kind of calcified or thickening of the cystic wall. So a lot of these predictors require a little bit of workup of the pancreatic cysts. In addition, trying to classify the cysts often requires workup. So what are the options that we have in terms of working up these cysts? And it primarily centers around imaging studies as well as EUS with or without FNA for fluid aspiration and biopsy. When we talk about imaging study in pancreatic cysts, we're generally talking about either CAT scans or MRIs. CAT scans are good. They're fairly accurate for predicting the correct diagnosis and in differentiating aggressive and non-aggressive features. However, often these cysts have to be surveilled regularly with surveillance intervals, and there is some concern to getting repeated CAT scans every 6 months or a year because of the radiation exposure. And it's estimated anywhere from 1.5 to 2% of cancers in the U.S. are actually estimated to be related to radiation from CAT scans. And for that reason, generally, if the patient is able, MRI or MRCP imaging is preferred. And you can see some beautiful MRI images of different types of pancreatic cysts. EUS is a very important part of the workup of pancreatic cysts. It allows multiple snippets of information to be obtained. EUS can characterize the number and the exact location of the pancreatic cyst. It can look at the rest of the pancreatic parenchyma in detail. It's possible to determine the presence and number of septations, as well as to detect some of the worrisome features for malignancy, such as mural nodules and associated solid components. It's also possible using EUS to aspirate fluid and cells from the cyst, which can be very helpful in both workup and management decisions. Cyst fluid generally can be sent for CEA, can be sent for cytology, it can be sent for glucose levels, and And now, very excitingly, can also be sent for DNA and molecular molecules as well, which I'll get into a little bit later. And it can also be used to sample solid areas or nodules or even the cyst wall. And now, even for smaller cysts that are being sampled because they maybe have some concerning features, very small amounts of fluid you can still get a lot of information, most of this information that you need just from as small a volume as 0.2 milliliters of fluid. But EUS is not perfect. When looking at whether the determination of morphological criteria for mucinous versus non-mucinous cysts using EUS, this was a study of 12 centers, 340 patients, and you can see that the accuracy, sensitivity, and specificity are not great. Cytology can be very helpful. It can be very specific, but it's not particularly sensitive. So if you're lucky and you get a good sample, the specificity can be upwards of 93%, but sensitivity is only about 54%. So definitely leave some room for improvement here. CEA is used very widespreadly for classifying these types of cysts, but it's not a great predictor of malignancy. Generally, the cutoff that is used is 192, but the sensitivity of CEA when you use the cutoff of 192 is only 63%, and the specificity only about 88%. And we do know that the higher the CEA level, the higher the specificity and the lower the sensitivity. And the problem is when you have a low CEA level, you can miss lots of mucinous lesions this way. So putting that all together, you can see just using CEA levels and cytology, sensitivity, specificity, and accuracy definitely leave some room for improvement. One of the newer markers that we can use is the fluid glucose level, and this has shown a bit more promise compared to some of the traditional markers. This came from the idea that low cyst glucose, usually less than 50, has been shown to differentiate mucinous from non-mucinous lesions. And this is a study just from last year. It was a meta-analysis of 8 studies, over 600 patients, showing that the sensitivity of a low glucose was better than CEA. Markedly better, actually, 91% compared to 56%. There was no difference in specificity when the glucose in low glucose versus CEA, but the accuracy was higher of glucose being low than CEA, 94% versus 85%. And now we have some advanced techniques that can help improve all of our sensitivity, specificity, and accuracy, and I'll go into each of these in a little more detail, but especially the DNA molecular markers. We also have needle-based confocal microscopy, pancreatoscopy, and Moray biopsy forceps. So starting with DNA and molecular markers, what we mean by this is really we're looking for mutations in KRAS and GNAS. We're also looking for high replication of high-quality DNA in the cystic lesions, and we're looking for alterations in tumor suppressor genes. And when you send this panel out for analysis, you're generally going to have all these things put together and get a suggestion that the cyst is benign, statistically indolent, statistically high risk, or aggressive. And there's a lot of data that has come out that shows that these molecular markers can dramatically improve accuracy. This is a study, again, from last year, a meta-analysis of 6 studies looking at over 750 lesions. And it showed that the presence of KRAS or GNAS alone for mucinous cysts showed a specificity of 89% and 95% and a sensitivity of 71% and 46%. When you combine these two markers together for mucinous cysts, you get a much better sensitivity and specificity, over 90% in both, with an accuracy of 97%, so much better than some of the other accuracies and sensitivity specificities we were describing. Together, these two markers have a higher sensitivity than CEA and a higher specificity than CEA. And the clinical utility, if they were both positive, was 97% mucinous cystic lesion. And if they're both negative, then only 8% would be a mucinous cystic lesion. Another study looking at 618 cysts, 142 that had surgical pathology, found that KRAS had a specificity of 100% and sensitivity of 54%, and that KRAS plus elevated CEA together improved the sensitivity and specificity for mucinous cysts. This is a study from 2015 where a combination of imaging, CEA, cytology, and molecular markers were used. And this is, as I was describing you, the four categories were created: benign, indolent, statistically higher risk, and aggressive. And using these four categories, this study found that in cysts that were benign and indolent, there was a 97% probability of the cyst being benign after 7 years of follow-up, and aggressive and statistically higher risk cysts were much more likely to transform into malignancy on follow-up as well. A study by Arner et al. In 2018 of 46 patients found that the molecular analysis changed the management in 27% of cases, and this was generally to a more conservative approach of observation, meaning that patients that did not need to undergo an unnecessary surgery. And this was most common when the CEA level was indeterminate. And another study from Lauren et al. 2016, looking at comparing clinical guidelines for molecular markers and determining surveillance versus surgery in a national pancreatic cyst registry, again found that the molecular markers had a big impact in reducing unnecessary surgery in benign cystic lesions. These are several additional studies looking at how fluid DNA can change management. This study was 478 patients with 209 having surgical pathology as well, showing that when high-risk features were present, the DNA did not change the overall malignancy risk, but when only worrisome features were present, if there were greater than 2 DNA abnormalities, that increased the malignancy risk significantly, and the absence of DNA decreased the malignancy risk. And when there were no high-risk or worrisome features, the DNA did not change the outcome. And lastly, Khalid et al. Looked at 113 patients with pancreatic cysts who underwent surgery, 40 of which were malignant, 48 pre-malignant, and 25 benign. And when they looked at the KRAS mutation for mucinous cysts, it showed a sensitivity of 45%, specificity of 96%. And when there were components of DNA analysis detecting malignant cysts, basically all malignant cysts with negative cytologic evaluations were diagnosed as malignant when using DNA analysis. Confocal endomicroscopy can also be useful in the workup and management of pancreatic cysts. It's known that mucinous cysts will have villus structures on confocal endomicroscopy visualization, and serous cysts have superficial vascular networks. And when you see that, it confers about 87% accuracy. The overall pooled sensitivity for confocal endomicroscopy is around 68%. And the accuracy for classifying these lesions based on their malignant potential is about 46%. And lastly, looking at pancreatoscopy as well as the Moiré biopsy forceps, these technologies also provide excellent diagnostic information, mainly because it allows good histologic specimens and can definitely help not only in classifying the cysts, but also looking at the subtypes of the different cystic lesions. So in summary, pancreatic cysts are commonly found. The goal is to resect malignant cysts only. It's important to use imaging and EUS to classify the type of cyst. Cyst fluid analysis and cytology can be helpful in high-risk lesions. Glucose and molecular markers and DNA can add additional diagnostic benefit and have been shown to change management in patients. And other technologies such as confocal endomicroscopy, pancreatoscopy, and Moray forceps can provide additional diagnostic benefit. And really, using a combination of clinical features, cyst features, and fluid analysis, including molecular markers and DNA, is our best mechanism to determine the necessity of surgical resection. And I will stop there. Thank you so much for your attention.
Hello, everybody. This is Prashant Kadia at the Dallas Medical Center. I wanted to thank Michelle and Monica again for having us here for this fantastic course, amazing lectures and live cases throughout the day. We were going to add in a couple of interesting videos on some third space cases just to break it up a bit. And this one here is going to be talking about rectal ESD and various forms of traction we can use in the rectal ESD. This is pertinent because we have a couple of traction stations over in the hands-on, so for people to try things out and learn about it, here's kind of in a video that might highlight some of these kind of techniques. So we had a 50-year-old man who underwent screening colonoscopy and was found to have a hemicircumferential laterally spreading tubular adenoma arising 1 centimeter from the anal verge. The patient was otherwise healthy and wanted to avoid coloscopy, and thus was referred for ESD. So here's the video here. Initial evaluation and looking at this lesion, as you can see, quite large, laterally spreading, almost half the circumference, and goes almost up to the anal verge here. So right on their end, we look in retroflexion here as well. You can see the extent of this lesion, which we highlight here with some markings. So we begin approaching this lesion like all of our ESDs with some markings. We use a soft coagulation current. Here we're using a eye-shaped multifunctional knife to perform the entire procedure. So we will go around the lesion and make some soft markings. And then we start injecting and start making a circumferential incision. So here the knife is able to inject. We use a solution of hetastarch, epinephrine, and methylene blue. And we use this knife in now an endocut setting to make a circumferential incision here. Now, after incision is made, we start at the anal end or the distal end of the lesion and start dissecting. You can see in the rectum, there's very large vessels in the rectum, and we have to be very careful of them. So even before really truly being able to initiate our dissection, we had to deal with some very large rectal vessels. Here you can see a coagulation grasper kind of taking on these vessels with a soft coagulation setting as well, leaving behind some fibrosis. And this was actually quite a fibrotic lesion, so it took us a little time to release that distal end. So you can see here a little bit of dissection has been performed. There is a small plane, but to facilitate our dissection, we started with the traction memory wire. These are wires that have clips attached to a recoil wire, memory wire that has this coil shaped and can be used. The way we do it is apply one clip to the distal end of the lesion, and then we grab the wire with a second clip and place that on the proximal edge of the lesion into normal tissue and get deep bites. And that wire retains its retention force and is able to pull back on the lesion. So you can see here that clip is now being pulled back and creates a much wider plane for us to evaluate and see the resection plane of the submucosa, which is nice and wide. This definitely allows us to facilitate faster dissection with a better visualization. And you can see here we're starting to work on that left side of that lesion and release some of the tissue here. As we continue to work, we can see that left side is kind of lifted well, but we wanted to add a little bit more traction. So we actually added another clip onto the right side of this lesion. And I created 2 points of traction to lift the entire thing as it flips back. These wires, interestingly enough, you may intuitively think that they're going to lose traction as you continue to dissect, but actually the opposite is true. As there's less force on them from the distal end, they actually retract more, so kind of lift these lesions up quite nicely. So here we had double traction here, and that really opens up the plane even more, allows us to start dissecting a little bit faster and whatnot. So you can see those 2 points there. There's definitely some fibrosis in this lesion, but the traction itself does allow us to see things better. You can see the plane now, the muscle is on the lower side, and the mucosal tissue flap that we're trying to resect is on the top side here. And again, the knife is used with injection to continue creating that submucosal blue hue to allow for us to do this. So here the knife is moving quite easily across the submucosa. And after a quick 1.5 hours, we were able to finish doing that. But this was quite a large lesion. So finished it off here. That was the last cut. And you can see the size of the polypectomy here. So the mucosectomy, it's almost hemicircumferential. Generally, when we do these lesions, we'll take the coag grafts for attack any vessels and touch them up. And then I close all of these rectal ESDs with suturing. It helps me sleep better at night, and there's some data that shows that it may reduce post-op bleeding and whatnot. So this was we had to use 2 sutures just for this one because it's such a large lesion. But you can see here how nicely that closes, and in retroflexion, looks like almost nothing happened. This ended up being an RO resection for a TVA with low-grade dysplasia for this patient. Here's another technique we use for traction. Here's a suture pulley mechanism. So if you don't have that wire, you can use a suture that you may be using anyway later to close the lesion. You take a purchase of tissue on the opposite wall of the lesion. It's usually where you want your point of traction to be from. Your first bite should be on that opposite wall where you want to be the suture to be pulling on the lesion. And then you take a second bite of tissue on the distal side of the lesion here. So this is kind of akin to that dental floss method, except it's through the rectum. So you need 2 points to make it an opposite traction. So you can see a distal bite has been taken. The proximal bite is on the opposite wall. When we release the suture, the nurse or tech can be pulling on that suture and lift the lesion up, which is very nice. And they can release pressure on the suture to drop the lesion down. So it's actually dynamic traction, which is a nice thing. And so in this much smaller lesion here that we're dealing with here, that traction made it very quick and very easy to take this lesion up. And once the lesion is done, it just kind of floats up there onto the string. And then finally, last modality I would say is this to consider in these rectal lesions is just gravity, right? Because there is large, bulky lesions like this that are going to be flopping down on you quite difficultly. But if you use gravity and turn the patient in the right position, you can actually have the lesion fall into the pool. So I use the fluid pool on the left to kind of mark where gravity is and turn the patient a little bit supine, and this automatically, this plane of dissection is being seen in front of us, and we're not using any actual traction methods. And this bulky lesion is using the weight of itself to open up this mucosa. So after we do a little bit more dissection, you can see the lesion literally hanging on its last string, and we can finish that off, and it falls into the pool of fluid. So I just bring up these cases because ESD is becoming more commonly performed. However, time and efficiency are limitations in our schedules. And so traction not only makes it easier, but also faster and safer. Depending on the lesion size, shape, and location, various methods of traction can be used. And with that, I don't know if Nikhil or anybody, you have any thoughts about how you approach these lesions in these settings?
I think that's a beautiful example of various types of traction that can be used. I personally am a fan of trying to use the gravity, like you showed in the last one, for the rectal lesions. I think if you can position the patient appropriately, then you are able to, to use gravity to your advantage. I also do like the dental floss traction method. So for those that aren't aware, that utilizes a normal through the scope clip, you actually pass well, outside of the patient, you pass the clip out through the scope channel, and you tie dental floss to the tip of that clip, and the dental floss will run actually exterior to the scope. And then you advance the scope in, and you clip the lip of your ESD specimen, and then you have the dental floss that's attached to the clip, and you can have dynamic traction. Now, the caveat is that you don't have counter traction. So whenever you're pulling, it's always going to be either in a per os direction if you're doing a foregut ESD, or in a per rectal direction if you're doing a rectal ESD. There are some other wires like you showed. There are some rubber band types of methods that can be used. So there are a variety of different traction methods that are on the market. They vary in costs from being, very, inexpensive up to, there's a newer device that some of you may have seen in the hands-on section that is a little bit more complex called Track Motion, that goes onto a double channel scope and essentially has a mobile grasping arm that you can control to be able to lift and either pull or push away tissue from you. So a lot of options exist, and I think that every lesion is different. You kind of have to assess on a case-by-case basis, when it's going to be helpful for you or not. And with that, I will share my screen now, and I'll show a video as well before we move on to the to live cases. So the video that I'm going to show is a esophageal leiomyoma. Just give me 1 second. I'll put our video on. Okay, so the video that I'm going to show, it's an esophageal leiomyoma. It was in the proximal esophagus, and the patient was symptomatic with dysphagia. Patient was actually initially referred to one of our cardiothoracic surgeons, but seeing the proximal location and knowing the endoscopic resection capabilities, they sent it over to our team. So I'll play the video right now. So you can see that there's a lesion there in the proximal esophagus. And so what we do is a few centimeters proximal to this lesion, we create a submucosal bleb, usually with normal saline and methylene blue. And then we create a mucosotomy, which is going to be big enough, generally about 1.5 centimeters or so, big enough for our scope and cap to advance into the esophageal wall itself. And then the procedure that we're performing here is the submucosal tunneled endoscopic resection. So it's sort of a hybrid of utilizing poem technique. You can see we've created a little bit of a tunnel there. And the goal is to essentially tunnel down to where the subepithelial lesion is, in this case, the leiomyoma that you can start to see there. And then we basically cut the lesion out off the muscle. So we initially were using a multi-purpose knife, which you can see here, that allows us to inject, cut, and coagulate. And what we're doing now is just dissecting this lesion away from the submucosa. And then once we've freed it from the submucosa, we then start to cut through the muscle to be able to fully extract it. So here we're using an insulated tip knife, and this has a ceramic ball. This actually protects the distal aspect of the knife from extending any thermal energy, so you have less chance of causing any injury on the opposite side. So what we're doing now is essentially dissecting the leiomyoma off of the muscularis propria. And we want to be very, very careful. You can see some of the adventitia there. So we're just very gently exposing the layers of muscle and utilizing the cap there to also create some tension on the fibers that we know where exactly we need to cut. You can start to see a little bit of fat there. You can see pulsation. So very obvious that we need to be careful with our dissection planes. And a lot of times you'll see these very big vessels that sometimes are feeding the lesions that we are resecting. So my general rule of thumb is that if it tends to be bigger than the knife, I'll use the monopolar grasper forceps and grab the vessel and then apply a forced coagulation or soft coagulation current. So now we're continuing our dissection. And you can see here, it looks like we're almost done with freeing up the lesion from the muscularis propria. So we're just cutting the last sort of few muscle pedicle attachments. And then just to double check that I've completely freed it, because sometimes you don't have as much mobility within the tunnel, I'll sometimes put a snare around the lesion itself, as you'll see here. And if I can close the snare in its entirety without it getting caught on anything, then I know that I've completely resected it. So the next step is, now that we've resected the lesion, we need to extract it. So we're using a Roth net here to pull the lesion out from the tunnel and take it out then through the mouth. So there's the nice specimen. That's our leiomyoma that came out nice and intact. And then we go back in and inspect the cavity where this lesion was before. We want to prophylactically coagulate any non-bleeding visible vessels just to minimize any risk of bleeding or hematoma in the tunnel afterwards. And then here we're using an endoscopic suturing device that Prashant alluded to. This is the overstitch device to be able to close our initial mucosotomy. So in about 4 bites, we're able to close the mucosotomy, and you can see what it looks like after we have completed the closure. So the patient did very, very well. We did observe them in the hospital overnight and just got an esophagram the next morning to make sure that there was no leak. That patient had no leak. They initiated on an oral diet and were able to go home the very next day. So this is a nice example of being able to, in a minimally invasive fashion, endoscopically resect a patient that had a symptomatic esophageal leiomyoma. So I think if there are any questions regarding either the case that I just showed or the case that Prashant showed with the rectal ESD, we would invite you to put any questions into the chat box. We are happy to answer them. And if we're ready, we will swing back over to the live cases. So let's see, are you ready for us at Robert Wood? All right, so let's transition over, please.
Hi, everyone. Welcome back. So our next case in room 2 with Dr. Starkar, we have here a 55-year-old woman. She has a history of recurrent biliary strictures and had undergone multiple ERCPs a while back. And one of them had actually had a stent migration through the right, deeper into the right hepatic duct, and actually through requiring surgery, a right hepatic duct excision. She ended up having a hepatojejunostomy as well, right hepatectomy, and this was done back in 2010. Her course had further required multiple surgical interventions. She also ended up having, back in 2018, due to hepatojejunostomy and anastomotic stricture and biliary obstruction, she had a EUS-guided hepatogastrostomy. And this was was complicated by further recurrent cholangitis episodes, repeated stent exchanges as well. This time around, she was being transferred over to our hospital because there was concerns for Klebsiella bacteremia and also a liver abscess at the other institution. On CT here, that was done just a couple days ago, showed multiloculated fluid collections in the posterior left hepatic lobe that was measuring up to 3.8 centimeters, and she subsequently underwent a IR drain placement. So today we're planning on doing an EUS with a hepatogastrostomy due to concerns for recurrent cholangitis as well. And this here is the image which shows the hepatic abscess with the IR drain in place. And we'll send it over to Dr. Sarkar.
Hi, guys. Can you hear me?
Hi, Avik. We can hear you.
Great. So I know we saw hepatogastro earlier today. So I think we're going to do a second one in this patient. So she likely has a stricture at the HJ anastomotic site that's causing her to get recurrent episodes of cholangitis as well currently a biliary abscess. So I have the EOS scope down, and the left hepatic duct, or the branches of the left hepatic duct, are pretty dilated, and you can see that here. So I'll freeze it here, and I'm using the Doppler here to identify the vessels, and I'll measure the dilated duct here. So it's about 8 millimeters, so it's a pretty good sized duct. The challenge here is there's a lot of overlying vasculature, and so I'll have to kind of try to find a window where I can sneak my needle through all the vessels that are here, and I think maybe I have a window right here. So I'm going to go ahead and do a puncture here. Okay, so I think I'm there, so we're going to inject some dye. Can we have the x-ray up? Okay, inject please. And so we are filling the left hepatic duct. I think I see some filling defects actually there, consistent with stone disease. Yep, thank you, Junior. Junior just did a rotation. And Junior, can you point out the filling defects? Yep, so right there is a big filling defect. So we're going to stop the injection now. We're going to just inject some water, and then I'll take a wire, please. So we're using a 0.035 inch VisiGlide wire through our 19 gauge EcoTip Ultra needle. You can see on the fluoroscopy image the small bowel is filling, so you know, if there is a stricture, it's probably a subtle stricture because contrast is able to pass through. But clearly there's an issue because the duct is dilated and there's new onset stone disease there, as well as this new abscess that's formed with recurrent episodes of cholangitis. So Kelly's been able to pass that wire into the duct quite easily. So the wire looks, it's actually an angled tip wire. We're using an angled 035 VisiGlide wire. I'll try to play with the wire a little bit to see if I can get it down across the anastomosis, but you know, at this stage, it's not the most important thing to do. If we can get it down, that's great right now, but we have a good wire, and as long as I can coil it, we can then use it to pass our dilator to dilate the hepaticogastrostomy tract. There you go. I got the wire to flip here. So the nice thing about the angled VisiGlide wire is I have full control of this wire, and I can actually flip the tip with slight rotation of my finger. Right there, you can see I just was able to flip the tip. And I don't know if that's it.
I think you got to pull back a little.
Yeah.
The problem is that the little loop forming in that distal bowel that's making it hard to get it across the anastomosis.
Maybe there. I'm getting a little resistance. There we go.
That looks better.
Uh-oh. That's not good. Yeah, I'm going to...
It may have been just a side branch or perforation.
Yeah, I think the tip of this is floppy, so there's not that much pushability there. I think I'll have better pushability if I'm able to pass a catheter over this wire and then try to cross it. So
I agree.
Yep, let's go with the 4 millimeter hurricane. All right, for now I'm just going to loop my wire here. I'm going to do an exchange with Kelly. Kelly's going to be pushing the wire in as I'm coming out with my needle. And on EUS, I'm going to try to keep my wire in view and stay stable, while Junior is going to give me intermittent fluoroscopy to make sure we're doing a good exchange and not losing the wire. 1 second.
That's a very important step.
1 second.
You really need to have a good team, and you obviously do with Junior and Kelly there. You really do not want to lose access here, and you need to keep your wire within view on your EUS scope at all times.
Yeah. The reason that's true is because when that wire is in view, it's on pause in the direction and the plane of your pushing instrument chin, right? So when you push out that next catheter or whatever it is, the wire is straight, and the catheter is not going to bend on your wire. If you turn your scope away, you can imagine that there's a bend on your wire to go into that fistula that you've created. And if you're pushing against a bend, you might just pull the wire out. That's what will happen if you don't push in access in its plane. So it's very important.
And like, you're doing a good job of maintaining close proximity between the stomach wall here. You don't want to fall away from the stomach wall, otherwise you'll have wire that may come out into the gastric lumen. So you want to maintain a close distance to the stomach wall here, have a nice apposition.
Yeah, I feel like, sticking the duct is the easy part. The hard part is this next step, which is getting the dilating balloon through the tract and through the liver parenchyma into the duct. I think this is probably the crucial part of the procedure. The rest of it, I think, is fairly routine.
Yeah, I agree. Getting the dilating the fistulous tract or dissecting the fistulous tract, over the years it's been done with a variety of different instruments. Historically, you can put a needle knife over the wire and try to dissect a tract. Sometimes you can go with a dilating balloon. A cystotome could be used, or sometimes even the electric cautery enhanced delivery systems for some of the stents can sometimes be used just to dissect a tract over the guide wire. This is where it's a really paramount importance to keep that wire in your view as you're advancing here.
In terms of fistula tract formation, I find that for the liver and for pancreatic fluid collections, the 4x4 is generally in 9 times out of 10, even more than that, case is going to be adequate to create that fistula if you put yourself in a position of mechanical advantage as you're trying to do right now. The much more challenging place to create a fistula is in the pancreas. Like if you're going to make a EUS-guided pancreatic duct drainage in a chronic pancreatitis, even a standard, pancreatic patient without any significant chronic scarring, that fistula will be a lot more challenging. And in those cases, sometimes does need needle knife, and newer developed wire-guided cystotomes with smaller calipers are being developed, which is probably going to be something we can definitely use in the future.
Yeah, I agree. In particular, the chronic pancreatitis patients are very challenging. They are, those pancreases are very oftentimes hard and fibrotic, and so you're not going to have success with just getting a 4mm hurricane balloon across. Avik, how's it going here? It looks like we're seeing a lot of tenting of the balloon. Do you feel like it's going across, or are you getting a lot of tension there?
Yeah, so I have the balloon down. I'm at the elevator of the linear EUS scope with the balloon, and I can see my wire on EUS, and I'm going to take a fluoro shot here. I'm pretty well oriented, pretty straight, but I am getting a little bit of resistance as I'm passing my balloon down. So when you're doing this, you don't want to push your balloon too much, because you're going to fall out of the duct that way. So I'm just giving gentle pressure, slowly doing small movements, rotating my scope left and right, big wheel towards me, big wheel away, using the elevator to see if I can slip into the tract. I'm going to try this probably for a few more minutes, and if I'm not successful, I'll likely switch over to a needle knife.
And that may be partly also because of the scope position. You see that there is a bend on that scope, and so the forward pressure on the device allows for part of the scope to be pushed away as opposed to a more tangential angle from the scope. And so that does make it challenging in these hepatocogastro cases, because the initial orientation of the scope and all and your access puncture is crucial. And some of these times it makes it challenging, and these ducts, which is giving you trouble for the wire to pass through, then when you don't have enough wire access in the duct, it makes it even more challenging. So these are, seemingly straightforward cases once you get in, but there's a lot of steps to get over to make sure you have a successful procedure. So navigating requires patience and skill as you're doing.
This is where, having something like an electrocautery enhanced needle, or a cystotome, sometimes can be helpful, but, it's, in cases like this, it's always good to, have a plan A, a plan B, a plan C. I think it's reasonable here if you don't have, success with the balloon to then, potentially switch over to utilization of a needle knife and to help dissect your tract, and then follow that up with a dilating balloon, which should be able to then traverse this area pretty easily.
Let's have the needle knife handy.
I have in some cases where we have run into these kind of issues, and even a needle knife doesn't work, say, in the pancreas. You could do the same thing in this scenario, is you could use the catheter. It's a very expensive option, but the option, use the catheter of a 6 or 8 French axial and throw that over the wire, use the hot cautery setting to basically just create a fistula. And it dilates the tract with that catheter, and then you would be able to pass other tools. I've had to employ this in the pancreas. That's something you can consider here, say, if your needle knife is giving you trouble or whatnot. But it's an option. And what we need is really dedicated systems that are just cautery enhanced with those calibers in general.
Absolutely, I agree. So I'm going to give this a shot for a few more minutes, and then if I'm not successful, go over to the needle knife. I believe Haroon is ready in room 1 with his next case, so maybe we'll throw it over there and come back here in a few minutes.
Sounds great. Let's switch over to Haroon's room, please. All right, Haroon, we can see you.
Welcome back, guys. I don't know if Arslan or Paul will just present the case for me. Go ahead.
All right, so for the next case in room 1 with Dr. Shahid, we have a 65 years old male patient who was recently evaluated in our clinic as a referral from outside. He has a history of Barrett's esophagus, initially noted on an upper GI endoscopy in 2013. Afterwards was lost to follow-up, and recently got a repeat endoscopy for Barrett's surveillance done in June of 2022. In the community, we do not have report or images, but during the referral was mentioned to have Barrett's esophagus, and the pathology was consistent with high-grade dysplasia. So the procedure that we plan today is an upper GI endoscopy with possible RFA for high-grade dysplasia.
Welcome back, guys. So, as Arslan mentioned, this patient has Barrett's esophagus. We didn't actually have the initial records that were sent over, so or the records didn't mention exactly how long, the Barrett's was. But we had a biopsy of what sounds like a small nodule when I reviewed the records that came back as high-grade dysplasia. So the documentation actually did not mention the length of the Barrett's. So it was unclear exactly, is this something that had progressed? He obviously had a history of Barrett's from a very long time. There's a lot that we can discuss here. The Barrett's guidelines were actually just updated earlier this year. I think they were just published in the actual American Journal of Gastroenterology earlier this month, but they've been available online. So, one of the first things I think to discuss is, how do you diagnose Barrett's esophagus, and, how should you be reporting the findings? It's, biopsies are usually the way you're going to diagnose Barrett's. You're going to see this salmon-colored mucosa here, which is pretty typical of Barrett's esophagus or findings of intestinal metaplasia. When you have evidence of significant dysplasia, usually you'll see some surface architecture changes and abnormal vascularity. Those are things that you kind of look for areas of potential dysplasia and really high-grade dysplasia or even possibly intramucosal carcinoma. So this patient actually does not have a very long segment of Barrett's. The the top of the gastric folds is at about 40, and there's really not much circumferential here. And then you have a tongue of Barrett's that basically goes up about 2 centimeters, and you have a small island of Barrett's right above that. So not significant, much less impressive than I thought I would see for someone who had a finding of Barrett's esophagus with high-grade dysplasia. Whenever you're suspecting whenever you're suspecting someone having Barrett's esophagus, first of all, you should be doing an endoscopy with high-definition white light, as most recent scopes are. And then you should evaluate with some form of chromoendoscopy as well. And the chromoendoscopy that we usually use is digital chromoendoscopy. Depending on what scope manufacturer you have, it might have different names. I'm currently using a Pentax scope right now. So they have modes called iScan 2 and iScan 3, which I'm going to cycle through right now so you can get an idea of what that looks like. So this is iScan 2, which is very similar to the Olympus narrowband imaging in that green bluish wavelength of light. And what it does is it helps kind of elucidate the surface architecture and really look at what the surface and the mucosal pattern is for the Barrett's esophagus. And really, again, you're looking for those same abnormalities that I mentioned. Before everyone came on, I did do a thorough examination under iScan, and there was really no significant structural abnormalities. iScan 3 actually is similar to this, but it actually enhances the surface architecture even further and allows you to be able to see submucosal blood vessels as well. So this is actually the mode that I like to use when using the Pentax scope because I feel like I get a much better, almost kind of zoomed in magnification of the area of Barrett's esophagus. So when you're looking to diagnose Barrett's esophagus, the recommendation is, to follow Seattle protocol biopsies, where you're taking 4 quadrant biopsies every 1 to 2 centimeters. I'm going to switch back over to white light here. 4 quadrant biopsies every 1 to 2 centimeters to determine whether or not you have Barrett's esophagus with dysplasia or without. And, there's a lot we can talk about, especially given the guidelines have recently changed. So there are some adjunctive ways to diagnose Barrett's esophagus. And I'm going to open it up to you, Prashant and Nikhil. Do you have anything else that you use other than the typical Seattle protocol biopsies to diagnose Barrett's esophagus?
Yeah, that's a great question. There are some newer modalities for tissue acquisition, including like the Watts biopsy, which I think many labs are starting to get into their units. One comment I'll make and throw it over to Nikhil and his thoughts on it is that one thing you said was very important at the beginning of this case is the documentation of your exam, right? Like when somebody sends you over a case, they need RFA treatment for a dysplasia or whatnot, sending off a proper PROC classification, right, to the endoscopist that you're sending it to or referring to. All of them need to be speaking the same nomenclature. And honestly, there's 3 landmarks that we should be putting in all of our EGD rules, right? The D-line, EG junction, and the diaphragmatic hiatus. Those 3 things, if you have them in any report, gives the subsequent endoscopist or reader a lot of information and a lot of useful information in what they're tackling in the case. And so Nikhil, what are your thoughts about the diagnosis and any thoughts about just evaluation of Barrett?
Yeah, so over the last decade, there's been a lot of progress made in developing a minimally invasive sort of office-administered Barrett's esophagus detection test, and this is probably geared more towards either primary care doctors or general GIs, where it does not involve an endoscopic procedure, and so they generally consist of swallowable esophageal cell collection devices, and there are a couple that are available, but essentially what happens is the patient swallows this capsule that's tethered to a string or a suture, and then these devices get swallowed, they pass down into the stomach, and then they get withdrawn orally after a balloon or some spherical device is inflated, and then once that device is inflated, the suture is pulled back or the string is pulled back, so it's withdrawn orally, and it's able to obtain essentially esophageal cytology sampling. And so These tests can be performed in an office setting, even by non-physician trained providers. They don't require the use of any sedation. Sometimes you can use a local anesthetic spray to reduce discomfort during administration and withdrawal. It's very, very safe in terms of the data. And then, as you alluded to in the most recent ACG guidelines, which was published in the Red Journal earlier this year, Nick Shaheen was the lead author. They did suggest, they did suggest using a swallowable non-endoscopic capsule sponge combined with a biomarker as an acceptable alternative to endoscopy for screening patients for Barrett's esophagus, especially in those that had chronic reflux symptoms or other risk factors. Now, the strength of that recommendation was conditional, and the quality of evidence to support it was low, but it nevertheless did make the latest guidelines. And when you think about the risk factors for Barrett's esophagus, the ones that should be on your radar include the male sex, patients over 50 years old, Caucasian, those patients that are tobacco smokers, obese, or ones that have a family history of Barrett's esophagus or esophageal adenocarcinoma in a first-degree relative. I would also argue, practicing in New York, that we see a lot of patients from around the world that have various instances of, for example, gastric cancer from an area that they're endemic to, whether it's in in Asia or Russia or certain countries in Latin America. So sometimes you have to expand a little bit beyond the guidelines in terms of who you're considering for screening. But I think that there's definitely non-endoscopic opportunities available now, and you have to be mindful of of the risk factors for who you need to screen for Barrett's. And I would, again, underscore the importance of what Prashant mentioned earlier, is that we need to have clearly defined terminology that we all are using. It's not enough just to say short segment Barrett's or long segment Barrett's. You want to utilize the PROG classification, list out where all the landmarks are, and if you happen to see any particular nodular lesions, for example, really make a note of where those are, because it will be helpful if that patient gets referred out for the endoscopist that has to do an EMR or an ESD or even ablation. It will help with their case planning. So, Haroon, what's your plan here, and how would you for the audience characterize the PROG classification?
So excellent points that both of you brought up. There's not much circumferential here based on where the top of the gastric folds are, and we have a maximal extent of about 2 centimeters. So this is really like a C0M2. And I think it's very important, I tell the fellows this all the time, is that it's very important to use that nomenclature whenever you're describing what is suspected Barrett's esophagus, because it does play a role in how you follow that patient going forward. One of the things that Prashant, you mentioned was... Sorry? One of the things, Prashant, you had mentioned was that, the Watts 3D brush, which is a brush biopsy instrument, which basically is used to scrape along the total area of Barrett's esophagus. It allows you to pick up extra amount of tissue, and it gets sent to an outside laboratory that uses some 3D computational analysis to determine whether or not there's any evidence of dysplasia. The 2019 ASGE guidelines actually had included that as a possible recommendation to add that to the normal Seattle protocol biopsies to try to diagnose Barrett's esophagus and dysplasia. Interestingly, the most recent ACG guidelines in the Red Journal actually don't make that recommendation. They say that there's not enough evidence to actually conclude that Watts 3D brush should be used as an adjunct to Seattle protocol biopsies. So in terms of treatment, there's a lot of different treatment strategies that are available. Obviously, radiofrequency ablation is the most common and the most studied. That was the landmark initial trial from the New England Journal of Medicine. And that's probably the primary modality that most people use for ablating patients with Barrett's esophagus. And really the patients that are going to need ablation are those that have high-grade dysplasia or intramucosal carcinoma, and then also patients that have low-grade dysplasia. The recommendations state that patients with low-grade dysplasia can either go endoscopic eradication therapy or undergo surveillance endoscopy at a shorter time interval. So my practice is to offer ablation to anyone with any low-grade or high-grade dysplasia. In this case, there's not much circumferential Barrett's here. Normally, when I get a patient with Barrett's and they have a long segment, a lot of circumferential area, I use a circumferential radiofrequency ablation balloon. In this case, I think we can probably get away with using a more focal device, which I'll show you in a little bit. But there are other therapies that are available. I'm going to come out with the scope so they can attach one of these focal ablation devices on. In the meantime, there are other forms of therapy that are available. There's cryoablation, which is available as a cryo balloon, as well as spray cryotherapy. You can also use, hybrid argon plasma coagulation. There's also, you can do EMR or ESD of these areas when you have high-grade dysplasia or intramucosal cancer. So, I discuss this with all the patients and kind of go through the literature with them about, risks of each type of procedure and, benefits of that. Obviously, the most studied is radiofrequency ablation. One of the things that you need to let patients know, it's not uncommon to have pain after the procedure. There are some studies showing that maybe cryoablation may decrease the amount of pain post-procedure, at least within the first 48 hours. It's important to let patients know that there's a risk of stricture formation. Stricture formation with the radiofrequency ablation is about 6%. Those that undergo cryoablation, the most recent study had shown that those who use the cryo balloon, at least the major study regarding the cryo balloon showed a stricture rate of about 12%, which is a bit higher. And one of the reasons for that is that, when you do radiofrequency ablation, the depth of penetration is usually to the muscularis mucosa. In terms of cryoablation, your depth of penetration is more to the submucosa. So you got a little bit deeper ablation, which may explain why you have a higher risk of a stricture formation. They're actually ready in room 2, so I'm going to actually jump back to room 2 so you can see the rest of the hepatogastrostomy. And then when you come back to me, hopefully I'll be doing some more of the ablation here. Keep in touch.
All right, thank you, Haroon. Avik, we're live with you.
Hey guys, so I ended up using the needle knife, and that got me through. So I have my 4mm Hurricane now sitting in the left hepatic duct, and I am playing with the wire to see if I could get it down across the anastomosis. So
we get back to the split screen with the fluoro.
So I think this might be it. Do you have fluoro yet? Nope. Still waiting on.
Yeah.
So I think we're just waiting for a few more seconds on the fluoro. There we go. So I'm going to have Kelly do a little injection just to confirm that this is where the anastomosis is. Kelly, can you actually inflate the balloon first? So it's a 4mm Hurricane balloon dilator. I'm planning on dilating, obviously, the hepatogastrostomy tract. You can see on EUS a little bit of the balloon is showing up. And on fluoroscopy, you can see also the balloon is showing up. So the balloon length is 4 centimeters. We also use that to measure to determine the type or length of the stent that we're going to be using for this. And so now I have my wire in a place I think the anastomosis is. So I'm going to have Kelly inject some contrast through this Hurricane balloon just to confirm that I'm going across the anastomosis.
So sometimes injecting through the Hurricane balloon has a lot of resistance, and it can be hard to see, but it looks like you're making it somewhere over there. But sometimes a balloon catheter by itself is even a better injector to actually see if any contrast gets across the anastomosis. And then the wire, when it usually gets across, you'll see it kind of curl. It should curl in a loop of bowel or whatnot. And so when you see it kind of flack up and flop on itself, like this. Sometimes it could be in a side branch or whatnot. So you can see what shows up here.
Let's see. Yeah, I'm not certain. So let's deflate the balloon. Junior, do you have the original fluoro image where we saw the bowel? Okay, so we're replaying the initial injection, and that seems like it's kind of the place where I am, where the bowel is filling. So, what are you guys' thoughts, Prashant and Nikhil? What do you think?
If we can go back to your image currently, where the wire is at, we can maybe check the arc of the wire here. Yeah, it looks like it's in that direction, but the path of the wire is making me think that it's not in the lumen. You should see kind of curl and start moving pretty easily. You should see a lack of resistance.
I agree. I think your wire is just buckled and flattened, and if it was in the lumen, it should be a lot more open and expansive.
Yeah. All right.
The good thing about these cases is that if the wire's on the right spot, even if it's created some type of micro curve or whatnot, you can still salvage these cases. It's not a big deal. You just have to go down, get a better contrast injection so you can kind of see where the valve actually is. Sometimes the contrast will even open the pathway for the wire. See where that valve is and where your wire needs to go, and then redirect. And as long as you get across and place stents, you'll be good. So you might need to try to pacify that hematemesis and bowel.
So I guess I'm, at this point, I'll probably just finish dilating my tract. I'll put a metal stent in just to save my tract, and then I'll try to pass a balloon catheter, get a good injection, and then try to play with my wire. So Kelly, let's do a dilation here.
And what stent are you going to use?
So we were debating this. Definitely, we're going to use a 10 millimeter diameter Gore stent. We again use the Gore stent because it has these anti-migration struts or fins on them, and it's very important in these cases to make sure the covered metal stent does not migrate. So we're definitely going to use a 10 millimeter diameter. The length, we were debating between an 8 centimeter length versus a 10 centimeter length. Junior had done a measurement, and it's about 8 centimeters, pretty deep into the duct. So I don't know if I'm going to go that deep with my stent, so I'll probably end up going with a 10 millimeter by 80 millimeter fully covered Gore stent.
Yeah, I think that's a good stent choice. The reason you mentioned another one being that you don't get foreshortening with that stent, and with this, it's very important that you bridge the gap between the liver and the stomach. You don't want to have any bile get into the peritoneum. That can be very caustic. So you want to make sure you probably have at least 15 millimeters, if not 2 centimeters of stent extending into the gastric lumen, just to make sure that you're safe.
That being said, you don't want it too long either, because if it sticks out of the stomach cavity like too far, 3-4 centimeters, the position of your scopes changes, and then the angulation of wires and pushing catheters through, you can lose mechanical advantage. So it's kind of a delicate balance, and you have to measure and be relatively accurate. Obviously you don't want to go too short, but even if it turns out to be a little too short, you could always bridge it and make it just a little bit longer with another stent. If you go too long, it's a little bit harder to revise something like that.
Okay, so I've just finished serially dilating my tract. I'm going to pull out my hurricane balloon while leaving the wire in place. Junior, just give me intermittent flow to make sure my wire is good. The wire is still good. We're going to go with the 10 millimeter by 8 centimeter stent.
We're going to stay with you for the stent placement, and then after that, we'll go over to the other room to finish the ablation.
Sounds good. So again, it's important to keep your EOS view of the wire stable. And then obviously we're also looking at our fluoro view to make sure our angle is good with the EOS scope and the wire and the duct. You can actually, if you look closely, you see the tract that the dilation has made right around the wire there on the EOS.
Hey, Alec, there's a question from the audience actually about this case. Why, for intrahepatic access, why not use 22 gauge needle and a .025 wire, I guess, for a smaller caliber of access?
So maybe correct me if I'm wrong, but I don't think the 025 wire goes through the 22 needle. No. I think you'd have to use an 018 wire.
I'm not sure whether it does. I never really use 025 wires. The only reason is because I just don't want to have to exchange them later. A lot of them have improved in quality, and I know that people will swear by them and do entire cases with them. Some of them I just feel like are just not as sturdy as the .035s, and having to exchange in this kind of case where you have precarious wire positioning and access. If you ever lose a duct or lose the wire, it's a lot more devastating in a case like this than the PRSP where you can kind of try to recannulate. So you don't want to lose wire access in cases that make multiple punctures. So I just try to use one wire, which I prefer is just 0.035.
So I have the stent going in now through the liver, but I think I'm getting caught up a little bit as I'm trying to get into the duct. I'm going to just try to change my angle a little bit. How's my angle on fluoro there, Junior? Looks pretty good. So sometimes this does happen with the stent. Again, we kind of just play around with the angles and small motions to see if we can get it to pop through. If not, then sometimes we'll have to go back and do another dilation or even dilate with a bigger balloon like a 6 millimeter hurricane instead of the 4 millimeter hurricane. Have you guys run into this issue sometimes?
It can happen, yeah. It's just the tract has to be perfect, and what happens is that we don't realize it, but the shaft of the metal stent delivery device is a lot stiffer. So its ability to bend and shape with these ducts as the other devices do, they curve and bend, is not the same. And so you'll run into a higher resistance points there with those metal shafts than with the other devices. So yeah, sometimes going back with the dilation will help for sure. Usually a couple, back and forth with the dilation, you should be able to get it in. But yeah, you could even upsize the balloon.
If you look closely on fluoro, I'm actually hitting the stone with my stent. And I think that's why my stent is not progressing. So right here, if you look very closely on the fluoro image, you'll see my stent is bowing around the stone that's there. So we started this case with a huge dilated duct, and I thought it was going to be quite easy, but as you can see, these are never that easy. Oh, I think, no. Is that true, Junior?
I don't think you're in. I'd consider thinking about switching to the balloon and probably redilating your tract. Because it looks like you're getting a lot of resistance trying to push there. You could even take
Too deep. Oh, I am through. Ah, okay, I did pop through. Okay. So, yep, so it looks like I'm okay here. So we can start opening. What do you think about the location here, juniors? It's good? Okay. There you go. You can see on fluoroscopy how the stent has opened. Kelly's going to continue deploying and opening. I'm going to switch to endo view.
The stent deploys by a string sort of unraveling. It doesn't require having to pull back as much, so it should stay in the orientation and axis that you have it lined up in as you're deploying.
So Kelly has fully deployed the stent. I am just pulling my scope away. And there it is. So we've deployed the stent. You can see the bile in contrast draining. And we have a good amount of stent within the duct. So now I'm going to take this deployment system out, leaving the wire in place. And then I like to dilate the gore stent that I just placed. So we're going to use a 6mm Hurricane to dilate this stent. And then I'm going to try to put a biliary extraction balloon in, get a good injection, and redirect my wire. So I'll continue here. I think maybe we'll shoot back to room 1 to finish up with Haroon and then come back here.
That sounds great. We'll come back to you after you finish up the ablation. So let's slide over to the other room. Thank you. Haroon, can you hear us?
Yeah, I can hear you. Welcome back, guys. I'm just going to do some ablation. Whenever I have cases like this, I do like to ablate the EG junction all the way around 360, and I'll use the Halo 90 balloon, Halo 90 device here. There's a bunch of different RFA devices like this. They're different sizes, different lengths. There's even a through the scope RFA probe that you can use, they're all like paddles. It's attached to the end of the scope. You basically suction down and maneuver your scope against the area of the esophagus that you want to ablate, and you want to make sure you're getting good tissue apposition, and then you basically go ahead and hit the pedal and ablate. This is the energy delivered is 12 joules. There's, as I mentioned, multiple different devices. There's also a circumferential balloon that can be used if you have a long circumferential segment. I'm going to start the ablation. I'm going to turn over to you, Nikhil and Prashant. Do you prefer to do radiofrequency ablation? Do you prefer cryo? Do you try some other therapy? What is your normal process when you're selecting, a form of therapy for Barrett's?
Great question, Haroon. I think
we're good.
There's a lot of data out there coming out for these various new modalities, and I think everybody has their own preferences. I still like tried and true, RFA for most cases that are native, that have not been touched by other endoscopists or whatnot, and it's just a regular true and true Barrett's because the data is there that they know you'll have over 80% complete eradication of intestinal metaplasia with these and reduce the risk of high-grade dysplasia and adenocarcinoma, both in low and high grades. We know that it works. That being said, and there's also so many different types of catheters, which I also like about it. So, they have a through-the-scope catheter. I call it the golden taco. It's a really tiny little thing that comes out. You can do focal ablation. You have the 60, the 90, the ultra, the 360. So you can tailor how you want to do it, and it's a pretty quick device to use, which is also the nice thing about it. So like these types of 90 devices that you're using right now, you put it on like a baseball cap over the scope and start ablating away, scrape it with the same device, ablate again, and it's very time efficient from that standpoint. Now, you look at cryo, which has also improved in terms of delivery method. It's no longer just a spray. They have the balloons that are available with very good control from the endoscopist in terms of the spray direction, and they're coming out with even newer balloons that can do 180s and whatnot. The nice thing about cryo is that it is quick, effective, can can potentially get deeper, right? As you mentioned, it's not a set amount of energy. You can get into deeper layers of tissue. So if you think somebody has Barrett's glands or refractory Barrett's, that may be a good spot. So I generally will start with RFA. If something's refractory, I'll consider going to to cryo. And then I have also used hybrid APC in certain scenarios. I think it's a little bit more cumbersome. It's better for, tongues of Barrett's as opposed to circumferential Barrett's because it can be a little bit more time and labor intensive. But for those lesions that are really, really scarred, and it's hard to get any type of, it's hard to get a lift on them with these hybrid APCs, it's still an effective measure. I've seen as even a third-line salvage, and there is more and more data coming out for it. So I don't know, Nikhil, if you have any other algorithms that you...
No, I thought you said it perfectly. It was, I'm also a little bit more preferential to RFA, but I do like cryo. I've been using it more, and then certainly for the more refractory cases, I think it's got its role. Hybrid APC, I've only used a couple of times in this setting. And then, even with cryotherapy, there's different balloon-based methods, and then there's, other liquid spray, liquid nitrogen methods as well. So how are things going with the ablation, Arun?
Ablation's going well. I think I've ablated the majority of the G junction. I have this little area here with that little tongue there as well that I'm going to ablate. And then, as Prashant mentioned, we can, you're supposed to scrape off the coagulant after ablation and then ablate again. And there is something called the no clean method, which has been described in Europe, where you actually, instead of ablating an area twice, cleaning, and then ablating again, you actually just ablate 3 times in a row, and it's no clean. You don't have to clean, and it's been shown to be just as effective for ablation. Looks like I maybe missed a small little area here, which I will ablate here.
Nobody likes to clean, Arun.
I know. Well, what's good about the 90 or 60 device, whatever you use, you can actually use the device itself to clean. Which I'll do now. I kind of scrape against the esophagus and kind of push it in, instead of coming out and then putting a cap on and cleaning that way. So, do you guys have a preference? Do you like to use the cap?
No. For these cases, I think you're doing it appropriately. If you're using the through-the-scope device, you'll need a cap because you can't scrape very well with that device. And then if you're in 360, you'll need that.
Yeah. So I don't know if you guys can see the area. It's we've ablated pretty much the whole EG junction and the areas of Barrett's that we had. So I'm gonna ablate again, but it sounds like they might be ready again in room 2. So I'm gonna throw it back to them.
Great job, Arun.
Nice job.
Thank you. Stop injecting.
All right, we're back with you for the hepatocogastro.
Hey, so we dilated the hepaticogastrostomy stent with the 6 millimeter Hurricane. I switched it out for a 912 biliary extraction balloon. We just did an injection, and I was in a small radical. I was not in the correct limb for the small bowel. So you can see our injection here that we just did, and as I pull back a little more, you'll see that small radical there. That's what I was in. So that was not in the small bowel. So
strong work by Junior rotating the fluoro.
Absolutely,
because,
Junior is.
It's a 3D image that we're looking at in 2D. So adjusting the fluoro can help us know where we are.
Yeah. So this, I think the anastomosis is maybe a little bit posterior. So
yeah, this case reminds me of like an ANSA loop in the pancreas, where you have this loop and you're trying to get it into the main duct, but it keeps wanting to go into side branches because of just the anatomy of that anastomosis, and you're kind of doing it exactly in reverse. You just mentioned you're trying to get posterior on your image over there.
Exactly. So I'm going to ask for fluoro, Junior. So I'm going to play with the wire a little more. If I can't get it today, that's okay. I'm probably just going to leave a double pigtail across this hepaticogastrostomy and then come back another day and probably do a spyglass and then take care of the stones that are there and then use that to really direct my wire and get across the anastomosis and deal with the anastomotic stricture.
Yeah, great plan. That's a great technique too, which we mentioned in the lecture this morning. Dr. Barron has published a good amount on this with using EUS-guided hepatogastrostomy as a conduit point for surgically altered anatomy spaces, especially cases like hepatocogeginostomy, like this one, where you just create a fistula for you to do antegrade therapy. When the wire doesn't behave and you can't get across, that's another very good and technically high success procedure if you can create that initial fistula.
What about this, Junior? What do you think? Inject here? A balloon up?
For all those that are watching, we're going to stay with this case for a couple more minutes, and then at 4:45 we'll switch over to our Q&A session to wrap up the first day of MAGIC 2022.
Okay, so we're doing an injection, and yep, that looks like a small radical, not where I want to be. So we'll keep trying. Stop the injection. Yep. Do you guys ever go through the hepatogastrostomy on the same session that you've placed it?
Usually not. No. I think your procedure is already a success by creating that fistula. You've created a route of drainage that will temporarily, even as long as those stones behave themselves, that could be a long-term form of drainage for this patient too.
Exactly. Yeah, I think it's in the same way when we do cyst gastrostomies, we tend not to do same session necrosectomies. In the same way when we do hepatogastrostomies, we tend not to same session go through these.
It's get out of Dodge, right? When you're winning, just get out of Dodge. If you're having some trouble, you don't want to overstep and lose points. So those are always good words from a mentor.
All right. Well, we're coming up on 4:45. So, great job to both of you with the hepatogastrostomy and with the RFA case. I think what we'll do now is transition over to our Q&A session. As mentioned previously, please utilize the chat function to ask any questions. We'll ask our panelists to turn their cameras on. We have a whole host of speakers that are going to be hopefully joining us for the Q&A session. We had 2 outstanding sessions with a lot of lectures on pancreatic biliary disease. And so we'll give maybe another few seconds for all of our panelists to get their cameras turned on.
Well, while they're waiting, there was a question for you from the audience. Is this just a matter of experience on the learning curve, or is there a formal approach to establishing recognition?
It's a good question. So recognize the tissue layer is really the layer of importance with third space endoscopy is the submucosal plane. You'll see in all of the ESD, poem, STIR videos that we show that we utilize a colored injectate, which is usually methylene blue, or could be indigo carmine, or sometimes there are some commercially available submucosal injectates. But the submucosal space will readily expand with injection as long as there's no scarring or fibrosis. And it'll pick up very readily this nice blue dye that we add. So when you're doing your dissection and you're identifying the layers, that the submucosal dye certainly helps. I think it's also, as part of the learning curve, you need to watch a lot of cases, get involved in animal labs to be able to differentiate the planes. And then if you're starting to integrate that in your practice, and having your first few cases proctored can also be very helpful to have someone who has experience there that can sort of be the guiding guiding voice over your shoulder for that. But it sometimes does get a little bit challenging, especially if you have coagulum that could disrupt your planes, or a lot of bleeding sometimes. But if it's a nice clean dissection, utilizing a blue submucosal injectate can be very helpful to differentiate your planes.
Great question, Phil. What's your protocol? So when you get a stricture sent from a outside hospital, ERCP, and they've sampled and they've stented, they sent it with a plastic or metal stent. On your initial evaluation of an indeterminate stricture, what tissue samples are you getting? What devices are you using, and what are you sending it off for in your lab?
So Prashant, that's for me?
That's for you, sir.
Okay, just making sure, sorry. So first, thank you for having me, and thanks to all the course directors as well. Really appreciate this. So this is a really tough question, right? Because usually these people get sent to after they've had some evaluation. You know, I always fall back on this: 85% of biliary strictures are malignant. So my job is, I feel like my job is to look for cancer, and look for cancer. And people always say to me, well, is it ERCP or is it EUS? And I always say, yes, it's this. So a lot of these people, I will typically do an ERCP, do brushings for cytology, do brushings for fish, and I will do an EUS as well and have an exceptionally low threshold to do a biopsy of any lymph node or anything concerning I see. And a lot of times it takes 2, 3 tissue samples or more to get one positive tissue sample. And the other thing I would say is my threshold for cholangioscopy is incredibly low in these people.
What's your interval to bring them back?
If it comes back negative and you think it's cancer, it's probably cancer.
Yeah. What's your interval to bring them back then? You know, like, say you did all of that, you on your spyglass, you saw some tortuous tumor vessels, you have a high suspicion. Are you going to bring them back, weeks, months later to resample, or how does this go? Because that's
it's an interesting question. And I have to confess that some of it depends on where in the country you practice. And for example, if you're in a great big metropolitan area, it's very easy to bring people back on a shorter schedule. Now I'm out here in the Mountain West, where I've been for many years. And it's not uncommon for people to drive 300, 400, 500 miles for a procedure. It's difficult to bring somebody back frequently for resampling if they work on a farm in rural Wyoming. So I have to kind of take that into account. But I'm always very upfront with people that, look, I think you may be harboring a malignancy, and we need to keep looking until we can really convince ourselves that you do or don't have a cancer.
Yeah, it's a great response. Isaac, it's good to see you. We have a question for you. Can you comment on the risk of pancreatitis using sphincteroplasty in terms of past dogma and new practices?
Yeah, so sphincteroplasty, as defined as greater than 12 millimeters, and that is under the assumption that the papilla is being cut. So this is post-sphincterotomy. The risk actually is quite low. Is somewhere in the 1 to 2%. But if you go greater on the balloon, it may go up a little bit more. If you do sphincteroplasty or an attempt without the pre-existing sphincterotomy, then the risk is significantly greater for pancreatitis. And that one is somewhere in the 9 to 15%. It all depends on who you read. So sphincteroplasty always after sphincterotomy, even if it's a small sphincterotomy.
Doug, your thoughts on sphincteroplasty?
So I actually just had a tweet about this last week. I actually don't use a ton of sphincteroplasty, but I will tell you when I do use it, it is almost 100% successful. To me, the small sphincterotomy plus sphincteroplasty doesn't seem to make as much sense as generous or complete sphincterotomy and then aggressive balloon and or basket work. But I would say that I've been very, very impressed by sphincteroplasty. I probably use it less than most of the panel. Perhaps that's just the era in which I train. But I think that if you have a stricture below a stone or you feel like you cut as far as you can, I think you can get away with quite a lot. And I will tell you that I think the pancreatitis rate is actually fairly low in a properly done sphincteroplasty.
You're right, Doug. There's an international guideline on this that came out a few years ago that quoted sphincteroplasty as a level 1 kind of intervention for management of large stones. And the data out there shows what you show, that it's very high success rate. It's safe when you've done that sphincterotomy, as Isaac referred to. It's safe, and also it reduces the need for mechanical lithotripsy. That's what the studies show. And so when you do that sphincterotomy, the direction of the force goes away from the pancreas. That's what we're concerned about when it's a native ampulla that force is concentric, pushing on the pancreas, causing that inflammation. But if the sphincterotomy is done in the right direction, you protect the patient. Isaac, one question for you. This is kind of an age-long question, I guess. What do you have any preference between laser or EHL, and how do you choose? Does it matter? Is it just institution specific in terms of logistics?
Yeah, so luckily I have both. So if you're doing pancreatic stone work, I prefer laser over EHL because with laser, you'll break the stones faster, and the stones are harder to break, and you may go through too many fibers with EHL as opposed to laser, and you can fine-tune the laser to break even the hardest of stones. When it comes to biliary tree, I usually use EHL just because we have EHL readily available in the room, and it's quite effective. If the stone burden in the bile duct is too much, or if the stone is impacted distally, I prefer laser. And the reason for that is it's very difficult to break a stone that is very distal because you don't have water that retains within the duct to allow for EHL. Those are the instances where I prefer laser.
Can I make a comment?
Of course,
Nikhil?
please.
So the data does show that there is a slight advantage to laser when you compare laser to EHL in a variety of situations. But I will tell you, most people like me, unlike Isaac, most people like me just have one. And most of the time, it's EHL. So, and I will tell you, if you're comfortable with it and facile with it, EHL is extremely effective. But the data does skew a little bit towards laser, but laser requires usually a lot more expense, laser certification, laser glasses, etc. And that's tough if your staff is, you're losing staff, hiring new staff, training staff. That the laser issue can be difficult on a staff level.
Those are both great points. What about you mentioned pancreatic duct stones, Isaac. For both of you, Prashant as well. Where does, let's say you have a chronic pancreatitis patient with a stricture and a pancreatic duct stone, where does ESWL fall into your algorithm? Do you try to do upfront endoscopic therapy first with pancreatoscopy and lithotripsy, or do you favor, Nagi Reddy and his AIG group where they do ESWL first and then go to ERCP? What's your approach with those patients with chronic pancreatitis or TD stones?
Yeah, so we actually have an ongoing trial to look into this, and it's slow going, but it's going. But I'm more in favor of pancreatoscopy. I think that the data that we have from Europe is skewed towards as well. And pancreatoscopy actually works quite well. With pancreatoscopy, when we do stone work, we can also use stricturoplasty with laser. That's why I prefer laser. So you can use both modalities on the same patient. And the advantage of pancreatoscopy is that you can do stone management anywhere in the pancreas without worrying about tail or so. And as long as you can get the pancreatoscope across, you should be okay. They're difficult to do. They're difficult to manage. I'm not too convinced, actually, of ESWEL. Having done myself several times, it's tedious, and I don't see too much of an advantage.
Dr. I have a question for you. In terms of the patients that have EPI or insufficiency, how do you address some of these patients that have had, total pancreatectomies? I've seen patients that come in after, complete resections, completely insufficient, and they're up to 28 to 30 pills of Creon per day just to manage their symptoms. Do you see these kind of high dose requirements for pancreatic enzymes to manage diarrhea and keep any semblance of a quality of life in these kind of a complete pancreatectomy patients?
This for me, surprising.
Go ahead.
I wasn't sure who you
For everybody, for Dr. Gelrud, I thought he would talk about it too. I don't know if he's here, but if anybody wants to comment on the panel, go ahead.
The only thing I would say is, this is coming from somebody who writes a lot of pancreatic enzymes, I'm sure like all of us. The risks of pancreatic enzymes are very, very low if they're dosed properly. If you start exceeding typical weight-based dosage, you run into the risk of fibrosing colopathy and ulcerative jejunal ileitis. And it's super rare. Like if you're dosing enzymes typically, you shouldn't see that. But if you start exceeding weight-based dosing protocols, you may find yourself with a case of fibrosing colopathy on your hands, which you really don't want.
Yeah. The other thing is you always have to make sure in those patients that they're actually taking the capsules the correct way, because oftentimes you ask them and they're not taking them the correct way. And for no specific reason, I don't have an explanation for it, but sometimes if you switch from one pharmacologic house to another using the enzymes, they may be a response, even if the product is similar.
Great tips.
Yeah.
All right. I think with that, we'll probably wrap up our Q&A session. I want to thank all of our speakers, our live endoscopists, our panelists, Doug, Isaac. Thank you for your time. I think we're going to kick it over to Amy to wrap up day one of MAGIC. Amy?
Thank you all.
Thank you, guys.
All right, thank you. I just want to say thanks everyone for a wonderful first day. I want to thank all our fabulous lecturers for the great didactics and Q&As. Thank you so much to all of our endoscopists and the whole endoscopy staff, our amazing moderators, all of our faculty who did the hands-on today, and we are looking for and of course, all of our industry supporters as well. It was a wonderful day one, and we're looking forward to a fabulous day two tomorrow. So thank you, everyone, again, and we will close out for today.
Mm-hmm.